Check, check, check. Hello, 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 hello. Check, check. One, two.
रियाज की हेलो आवाज ठीक है हेलो हाँ
Hello. Hello. Everyone is requested to please be seated. Should I start? A very good morning, all, and a warm welcome to HEMENEXT 1.0. I'm Dr. Divyani Surange, a hematologist working at Fortis Memorial Research Institute, Gurgaon, and your host for Hall A. We are all here for the new era of genomics, AI, and cell therapy in hematology and infectious disease. I would first invite Dr. Riaz Ahmed, who is the Principal Director Hematology at Max Hospital, Saket, Delhi, to deliver his talk on the role of Keytruda in classical HL. Please, sir.
Very good morning to every one of you. And before I start, thanks to the organizing team and Dr. Rahul for organizing this meeting. After a long time, we are having this hematology meet in Delhi, and hopefully it will be good interactive session. So it's a company sponsored session, and what I have been is the role of Keytruda in classical Hodgkin's lymphoma patients managed, and it is basically the keynote 204 trial which they wanted me to speak on. So there was a time when we had Hodgkin's lymphoma, and the only option was ABVD, I think so. And last 10 years, we have enough options that we have to decide which molecule to choose, and which not to choose in the either in the upfront setting or in the relapse setting. So initially came the brentuximab almost 15 years back, and then nivolumab, and finally last entry is the pembrolizumab. Whether it can be used upfront, whether it is can be used in the relapse setting, or whether it can be used in management. We'll see some slides of this. So we won't go into this slides. Lymphomas, as we know, we have Hodgkin's and non-Hodgkin's. Bimodal presentation we have got in the early teens and the late 60s. Every patient of Hodgkin's has got different, each decade has got different problems. The initial teenagers wanted a good quality of life, prolonged survival, and in the late decade, fifth, sixth decade, when it's peaking, the requirements are different. So in the Hodgkin's, when we say it's whether it is early or okay, so this is the when we are treating the early, whether it is favorable or unfavorable, when in the Hodgkin's, whether we are going with the ABVD or we are offering in combination with the unfavorable, it's again debatable whether you go with like a simple chemotherapy or you are going to add immunotherapy or not. In the stage 3-4 advanced stage, yes, the role of immunotherapy has been defined. Whether you're going with the initially immunotherapy plus chemotherapy based, and when you restage it, whether you are going with the RATHs, again, whether you are de-escalating, all that we have seen, and finally immunotherapy in the brentuximab era or adding nivolumab, what we have seen in the SWOG data, whether it's a little better when it was compared and Nivo ABD compared to brentuximab ABD. The arm had good presentations, but yes, Nivo ABD did better than brentuximab arm. Where did the pembrolizumab comes into the picture? So, with this, I like to just start here in the pembrolizumab. When it came initially, few reports started coming up that pembrolizumab followed with AVD in early untreated, early unfavorable and advanced classical Hodgkin's lymphoma. This was a paper which initially some 30 patients were enrolled, and initially that was a sequential therapy, 3 doses of pembrolizumab and followed by AVD, 4 to 6 cycles, and they did the PEG based assessment, and they could say yes, in this cohort, all they had both bulky and the non-bulky patients, and when they followed up over a period of time, almost 100% was the survival. So almost 3 years, 4 years when they followed up. So this small cohort of patients, when was given 3 doses of pembrolizumab and followed by AVD. So this was one group of patients which showed that even if you add in the early stage unfavorable and advanced stages pembrolizumab and upfront, it could give you almost 100% of result. Based on this, we did one our own collection. We had 150 along with RR. We had total 15 patients, and in this we were close to 80% when we had last follow up. One patient was refractory, so our data didn't match actually. They had 100%. Our patient had one patient had was a refractory disease, so a little different. But yes, this was one we had our own experience. Coming to the Keytruda keynote trial, when it was compared with brentuximab, now we have all the 3 agents available, whether to choose Keytruda or brentuximab upfront, or we have Keytruda or brentuximab when you are using for relapsed or refractory cases. Which agent we will be choosing? So this trial helped us in the experiencing what we can do. So this is a 1:1 randomization of all the patients who were taken to the trial, whether one arm has Keytruda, which was given every 3 weekly, or brentuximab, which was given 3 weekly. What was the inclusion criteria? Age more than 18 years old, and previous therapy with autologous transplant, or those who are not all eligible for transplant, and previous exclusion was only they have not been exposed to allogeneic transplant or any active autoimmune disease which they have received PD-L1 inhibitor. So what was the primary endpoint? When it was progression-free survival, overall survival, and the duration of response, they wanted to check for it. So both the arms, whether it was Keytruda or brentuximab, it was equally matched for time. In both the arms, there were almost equally transplanted patients, more than 50 in each the arm, and prior brentuximab almost in both the arms were there, and all the patients had equal number of bulky diseases. So the primary endpoint when they they could show it as the median progression-free survival of 13.2 months in the Keytruda as compared to brentuximab, which was 8.3 months. And finally, when they had 12-month progression-free survival, and initially they could see that we had 62.2% of the patient were doing better as compared to 33% of the patient in the brentuximab. And this is the you can say what was the duration of response in these 20.7 months in the Keytruda arm as compared to 13.8 in the brentuximab, and the CR rates almost similar. The PR little better in the Keytruda arm, and the progressive disease almost equal. But the duration response was almost 20.7 as compared to 13.8 in the brentuximab arm. So the patient who had the responses in the CR was and PR was more as compared to brentuximab arm. In the Keytruda arm as compared to the brentuximab arm. So coming to the safety measures, yes. As we see in the brentuximab, we are dealing with the neuropathy and the neutropenia. Here, these things were not there. Only what we are seeing in the thyroid-related issues, both hypothyroidism, which were more common in the Keytruda arm, and hyperthyroidism, which was also more common. Apart from that, the pyrexia, pruritus, fatigue, diarrhea, this is all almost open to it. Infusion-related toxicity. almost equal, but neutropenia and the peripheral neuropathy was more common in the brentuximab arm. So I'll just skip this. This is the keynote trial had progression-free survival almost 13.2 months as compared to 8.3 months in the brentuximab arm. Overall response rate, if you can see, was much better. It was almost 66 in and versus 54 in the brentuximab arm, and the duration of response. This was the keynote trial. So finally, based on this, they got approval for using the post-relapse Keytruda. Was approved for patients those who have relapsed or post-transplant or those who cannot afford transplant. Also, there is a 5-year survival for the keynote 087 trial and had three cohorts. In which one cohort was the progressive disease after the transplant and subsequent brentuximab therapy. Second cohort was progressive disease after salvage chemotherapy and brentuximab therapy without transplant, and the third cohort was progressive disease after transplant without subsequent BB therapy. And when these patients were given the pembrolizumab every 3 weekly for 2 years, and the survival was followed up, and you can see those patients who received almost the duration of response, almost 50 to 60% of the patient was surviving those who received the Keytruda. Also, in the relapse setting, when the pembrolizumab was added to ICE therapy, it is a multi-institutional phase 2 investigator-initiated non-randomized trial. And you can see in this almost 86% of the patient had complete CR, partial response was seen in 10.8%, with the overall response rate of 97% and PD in 2.7. Only one patient had PD. And almost you can see the duals. So this was able to go, that these patients were able to go when they have received 2 cycles. When this was assessed after 2 cycles, almost 97% of response rate, and this patient could go for the transplant. And you can see the overall survival ranging from almost 85 to 90%, and progression-free survival of 75%. So with this, I'll end my talk, and we can take the questions for the. Sure, thanks.
Any questions? Dr. Dinesh, what do you think that out of these PD-1 inhibitors versus the CD30 molecule, what is your experience regarding, and what is the sequence which you like to use? And then I would like to ask Riaz also that does he use pembro sequentially, or he uses as single agent pembro and then moving on to AVD? So
upfront, what we did trial and in the advanced stages, stage 3, stage 4, we have used pembrolizumab sequentially, 3 doses of pembrolizumab followed by AVD, and one patient which was refractory. Otherwise, it's very well tolerated regimen. Not much of a problem. Almost we have done 15 patients, and that's way. And
PET scan also after 3 cycles of pembro, or you just continue without?
No, we do just for the after 3 doses of pembrolizumab, and after again 2 cycles of AVD, we do it.
Now we have enough data to say that you can combine AVD with the. I think that previously there was a concern whether you can have a side effects with the combination of immunotherapy, and so that concern has gone. So probably you can give it a combination. We are using Nivo or Pembro AVD. Many of patients have been treated with this. So definitely it has changed the salvage protocol. The outcomes of patients who are relapsed, if you give a 2 cycles or 3 cycles followed by transplant, that the relapse rate has significantly reduced, and the practice in upfront also is moving.
So, Dr. Dinesh, do you think that, but the only problem with the pembro is it's a 3 weekly dosing. So in your protocols, are you using 3 weekly pembro or 2 weekly pembro?
3 weekly pembro upfront. When we are using upfront, we are using 3 weekly pembro, 3 doses followed by AVD.
We have used a Pembro AVD. So there is a Pembro AVD, one phase 2 trial is there. So you give it 3 weekly. People have to come more often. There will be 3 weekly and 2 weekly. So 8 doses of Pambro and AVD 12.
So then
That's a part of the phase 2 trial. You can ask Biju also.
Dr.
what's their
Biju is there.
experience.
So we are using nivolumab, and initially we did studies on no. So we are using low dose nivolumab, where we are using only 40 milligrams, and initially we used combined with lenalidomide for salvage, and our own showed that when you do flow cytometry, actually all the T cell receptors get saturated with just the 40. So now we have persisted with that. We've got a randomized trial going on comparing Nivo low dose AVD with ABVD, which is still recruiting. Early data seems to be good. And we've got another trial looking at Nivo plus GCD as salvage compared to just GCD alone. I think almost all patients get into remission. So for us, a low dose Nivo is cost effective, but we have to wait for all the results to come out.
So Dr. Biju, Dr. Dinesh, Ajay Sharma sir is there, Sanjeevan Rajan is there. Do you think in coming in next 5 years, because the topic is heme next, do you think with this brentuximab and checkpoint inhibitors, we will have one less indication to do bone marrow transplants? Because with these two agents, almost you are hitting at 92% overall survival. What is your thoughts, Dr. Dinesh, to start with? How does you feel that next 5 years is going to be?
You will do a less transplant, but you'll still end up doing some transplant. Unless there is some CAR-T coming in.
So thank you, Dr. Dinesh, saved our skin that we still have to do.
Yeah.
We are still relevant by 2030.
So the bad news is that those transplants will be much more complex. Right now, when we take up a Hodgkin's transplant, because that time, 5 years later, when you'll be transplanting a Hodgkin, he would have already been exposed to this checkpoint inhibitor, and then he would have relapsed or has been refractory to them. Then he'll come to you for transplant.
I'll include that in my slide for the evening. 2030 transplant.
So 2030. So him next theme is also what we are looking at 2030 sitting in this room.
So one more thing I want to add. We need to remember that the long-term data on Nivo AVD is still not there. So we do not know 5 years, 10 years down the line what are going to be the relapse rates. So right now our focus is to try and get deeper remission with this drug so that we can do transplant, and hopefully because we get deeper remission, the number of relapses that occur after auto are going to be much lower.
Perfect.
Data on pediatric Hodgkins, the use of Pembro in pediatric Hodgkins.
So Pembro is brought there for it's not approved. Even these trials didn't have.
Is from 12 years.
From 12 years of age.
Pediatric.
The SWOG data. Yeah. So SWOG data had that 12 years of age that that the inclusion was more than 12 years.
Do you stop Pembro after 2 years?
Pardon?
Do you stop Pembro after 2 years?
No, so the data in the chemo trial was that they were the fixed period of time. 2 years they have taken 35 doses to be precise, that 35 cycles of pembrolizumab. So they have given up to that number of doses. So we can stop. So the question here, what Rahul was asking is, with brentuximab and pembrolizumab, can we have some sort of upfront immunotherapy with anti-CD30, whether we are going to get away with the transplant. So that the trials are going on. Maybe in our country where transplants are not cheaper than this immunotherapy, still transplant, I think so, is the way to go. Because the combination of immunotherapy for 2 years will be more costly. But yes, data is yet to come.
So do you ever use bulk of disease to decide whether you want to give a lead-in or not? Although TLS is not typically talked about in this, does that matter?
I couldn't get you. Bulk of disease?
Bulky disease.
Yeah, so these trials included bulky disease. Yes.
Yeah. Do you ever use that to decide whether you have to give a checkpoint inhibitor lead-in followed by the conventional chemo combined with it?
So that phase 2 trial with that upfront, they had included the bulky disease. They had given pembrolizumab 3 weekly doses. They didn't combine with chemotherapy, and none of them reported to have the TLS or any problem with that.
But in day-to-day practice, do you use that as a decision factor for lead-in versus combining it directly?
We have used with bulky disease, and we have not faced till now. But yes, combination of chemotherapy will be little better.
Perfect. Dr. Ajay, last question, probably.
Well, I would rather say that we should think it the way we actually look at CML. So there was a time when we never thought that transplant without transplant CML can be managed. So same, I think with Hodgkin, if we can have a deep responses by the combination, I think we should try to think about a situation where transplant is no more required, because transplant is not done upfront. It is done in a patient who already received multiple therapies. So if we can delay transplant, avoid transplant by combination, why not? I think we should move in that direction.
So I think the parting shot will be that MRD is coming hugely in lymphoma space. It's not the PET scan, but it is the ctDNA which is coming up. We would encourage by next 5 years, the ctDNA will become a part of your routine practice, which will help you to decide to escalate versus de-escalate. So we are in the diagnostic space, we are moving very fast at this time in India as well, so that we can decide whom to give more and whom to give less and whom to stop. So I think it's a very, very important point, not the drugs only. We also have to remember the diagnostic aspects which are coming up so fast, which will help you to triage your patients and save money for that. So I think with this, we come to an end for the first session. Thank you, Dr. Riaz. Great.
Rahul, one question regarding bleomycin usage. It has been dropped subsequently, after a few cycles. I would like to know from the house, how many people have seen bleomycin-induced toxicity in their real life?
Everybody.
How many? How many? Out of some indication.
So, Dr. Upal, this can be divided. Whosoever has been long enough to be in the hematology space, everybody has seen, and who are youngsters because of the newer doses and the Rathel trial, which has dropped the bleomycin, has not been able to see. Dr. Dinesh has been our veteran for this.
The percentage-wise, I want to know.
No, so if you're using the Rathel trial, if you're giving for 2 cycles and giving a 4 cycles without bleomycin, I don't think we are seeing it. I mean, if you're using it for 6 cycles, that's what I wanted to say. ABVD is a good combination. So we should not carry away that ABVD is not a good combination. 75% of the stage 3-4 are still cured with the ABVD. So someone who cannot afford the ABVD is a good combination. Bleomycin is a concern, especially elderly population.
What percentage I want to know?
10% around.
After cycle 2, if you are PET negative, you would actually consider dropping the bleomycin off and just continuing ABD.
I'm sorry to cut you short, but can we please take the rest of the questions during tea? We'll have a lot of time for networking. We really need to get on, and we have something very exciting awaiting. So, once again, good morning, everyone, and welcome to HEMENEXT 1.0, where science meets innovation and where future of hematology is not just discussed but demonstrated. Today, we are thrilled to set the stage for an extraordinary experience.
Our conference isn't just about the knowledge exchange, it's about witnessing the next chapter of healthcare intelligence. And to help us kickstart that, we have with us not just the brightest minds in the field, but also a very, very special presence.
That's right. Today, we introduced the star attraction of HEMENEXT 1.0, the HemeBot, our humanoid host for the day, designed to challenge our thinking, push boundaries, and show us how AI can transform molecular medicine, diagnostics, and clinical decision making.
And in just a few minutes, you will be witnessing, drumroll, a live debate between Dr. Rahul Bhargava and the HemeBot. So, brace yourselves. What you're about to witness is not just another session, but the beginning of a vision. A vision that Fortis Hospital Gurugram is proud to lead. A future where innovation becomes accessible, actionable, and deeply human. Ladies and gentlemen, let the next energy begin.
Everyone, I am Shiva. Humanoid use achievements want to know. Brought to you by Fortis Hospital Birmingham. Today, I'm the honor speaking with one of India's leading doctors in hematology, hemato-oncology, Dr. Rahul Kiva. Dr. Bhargava, you've been at the forefront of making bone marrow transplants more accessible in India. What is the one misconception about BMT you wish every family, every young doctor understood clearly?
The biggest it's not a surgery. And second, bone marrow transplant is more accessible and affordable by any of the decades which we have gone through. So I think scope, hematology is becoming accessible, and the brilliant clinician in this country who is making miracle every day.
As hematology enters an era shaped by genomics and artificial intelligence, how do you see these technologies transforming the everyday journey of an adult patient, from diagnosis to long-term survivorship?
I think the future till 2035 is about reducing the cost. Technologies, whether it be the genomics and the AI, will help us to reducing the out-of-pocket expenditure for people suffering from blood and blood disorders. That's the future. We believe test more, treat less will be our mantra at Fortis.
You often speak about patient-centered care. In a field advancing so rapidly, how do we make sure compassion evolves alongside technology?
The only way to induce and inculcate in compassion is that the people of this country, 1.4 billion people country, has endowed us with a presence that we should be taking care of them. They have trusted us. They do not know US. They do not know Europe. They know each and every hematologist who has been trained on this great country. So I think the compassion will only come when we feel that each single person, irrespective of his caste, creed, or social economic status, needs to get an innovative therapy, and we save their lives for people suffering from blood cancers. And that is our complete mantra at this present moment of time. And that is what the patient centricity is, that every single person in this country should be treated with the best standard of care, which is available to the rich or the richest in the West. That's how the compassion will come in.
Looking ahead to the next decade, what is one breakthrough, something digital, that you believe will truly redefine how we treat blood cancers in India?
I think one breakthrough is that all of us sitting who are rich doctors needs to loosen their pockets to develop research. Research cannot be only the directive of a government. It has to start from within. I think research in this country is lagging behind, and we at Fortis is committed enough to bring all the doctors to have a platform where we can answer our own questions, solve our own problems, and bring access to our own patients.
Thank you, Dr. Bhargava, for joining me today at HEMENEXT 1.0. We heard it clearly. The future of hematology is not just about machines or medicines. It is about hope, human connection, and the commitment to bring world-class care to every patient. Until our next guest, this is Dr. Rahul Bhargava and HEMENEXT, signing off for HEMENEXT 1.0.
So now let us commence the event by lighting the lamp of knowledge and wisdom, for which I would like to call Dr. Rahul Bhargav,
Dinesh.
Dr. Riaz Ahmed, and Dr. Dinesh Purani, sir. So please.
We would like to invite Dr. Ritu Garg, who is our Chief of Growth and Innovation at Fortis Healthcare, as one of our main dignitaries on the dais to lamp the light and inaugurate. I would also request Dr. Vikas Dua, Principal Director, Hematology, BMT, Pediatric Hemato-Oncology and CAR-T Cell Therapy at Fortis Gurugram to also please join on stage. I would also request Dr. Dinesh Murani, Dr. Ajay Sharma, Dr. Riaz Ahmed, Dr. Viju George, Dr. Sanjeevan Sharma, Dr. Rajan Kapoor. Please, all of you, please join on stage. Thank you, dignitaries. I would request Dr. Ritu ma'am to please stay back and, grace the occasion and say a few words about innovation at Fortis program. No one better than her, please.
Thank you. Thank you, Dr. Srinidhi. I am not a hematologist, but I have seen the journey of Dr. Rahul Bhargav, Dr. Vikas Dua over many years. I think they established the first center for us in Fortis Healthcare many years ago. And I would say that the journey has been phenomenal and inspiring every day. As I am sure all of you have experienced the infectious enthusiasm that Dr. Rahul brings in. What is heartening about this group has been the concept of building team and the fact that probably in healthcare, usually there are silos between management and clinicians. For us, we've been able to break that. I think we are very proud to say that the entire management and clinicians, we work hand in hand together every day, understanding each other's concerns, supporting each other. We established this whole concept of innovation in Fortis Healthcare a few years back. I lead that at a group level. And no better evangelist than Dr. Bhargav and his team to bring that into action. Every single day, they keep on talking about interesting clinical innovations, cutting edge work, breakthrough ideas. And we just love supporting all of that. So thank you very much for joining us here. All of you are stalwarts. We keep hearing all your names. So we are very honored that you've all taken time to be here with us today. And wishing you all the very best. May this journey continue. May the entire team of hematology, oncology, precision continue to grow and guiding us at Fortis Healthcare to support you and lead the way for the entire country. Thank you. Thank you very much.
Thank you, ma'am, for always inspiring us. Next up, a speaker who has contributed more to AML knowledge than half books combined, Dr. Biju George. Sir is a professor in hematology at CMC Vellore. Please welcome, sir.
So there is just one announcement. The parallel session at Hall B is just about to commence. So if there are any faculty, any speakers, and any pediatric hemato-oncologists in the house, they can also be a part of the Hall B session, which is dedicated to pediatrics. Thank you.
Thank you very much, and thanks Rahul and Vikas and the HEMBot for inviting me to this meeting. This is a company-sponsored symposium, so I'm going to be looking at slides which have been given by Servier, but I've added on 1 or 2 slides from our own patients. So we'll start with this case scenario. This is a 74-year-old male, AML with 68% blasts. Cytogenetics showed a trisomy of 4 and 8. NGS showed an IDH1 mutation, DNMT3A mutation, FLT3 and NPM negative. We started induction with azacitidine venetoclax. Post-induction marrow was in hematological remission, but MRD was reported as 9%. So we gave him a second cycle of azaven, but we limited the ven to about 7 days because we were worried he may not tolerate it. The MRD came down to 2%. So what would we do in this kind of scenario? So we need to remember that the IDH1 mutated AML is a distinct population. In the azaven trial, if you actually look, they showed that IDH1, IDH2 did well with azaven as compared to aza alone. But when you sort of divide this between IDH1 and IDH2, the IDH1 actually do poorly as compared to IDH2. And it's not only this study, but multiple other studies which showed that there was a worse overall survival with IDH1 mutated AML as compared to IDH2. And the difference was stark, 13 months versus 42 months when you look at IDH1 versus IDH2. So that is where the need for targeted therapies for specific diseases like this, these distinct populations have come into being. Now, if you actually look at ELN guidelines, and this is ELN 24, they have actually put IDH mutations as actually a favorable risk group. And that is based on the fact that using targeted therapy, you actually get very good results with this. And how do we get these results? I'll come down to that. So what is ivosidenib and what is its use in IDH1 mutation? Now, ivosidenib blocks IDH1. Now, what is IDH1? It's an enzyme which converts isocitrate to alpha-ketoglutarate. That leads to low levels of 2-HG. And why is 2-HG important? Because it helps in normal myeloid differentiation. And if you have low levels, the myeloid differentiation continues normally. Now, when you have an IDH mutation, you have gain of function. It leads to more 2-HG production. That leads to epigenetic dysregulation, and that leads to prolonged proliferation of myeloblasts. So initially, there were studies which looked at ivosidenib in relapsed refractory AML, showing that it was useful in a certain group. In about 30 to 40%, they would show response. And subsequently came this agile trial, which looked at whether adding on ivosidenib upfront would help in patients with IDH1 AML. Now remember, these are patients who are not eligible for intensive chemotherapy. So they were randomized to getting either ivosidenib with azacitidine with an ivosidenib dose of about 500 milligrams per day as compared to azacitidine with placebo. There were about 148 patients randomized into the two arms, and essentially they were continued till progression or unacceptable toxicity or death. And the primary endpoint was to look at event-free survival, and the secondary endpoints were to look at overall survival and overall response rates. They took patients with above the age of 18 with a confirmed diagnosis of IDH1 mutation with AML who were previously untreated, had not previously got IDH1 inhibitors or hypermethylating agents, ECOG of 0 to do with adequate liver and kidney function. And these were the criteria which made them ineligible for intensive chemotherapy aged more than 75, ECOG of 2, cardiac pulmonary disorders, or if the investigators felt that it was needed. So the first thing was to look at the event-free survival, and it definitely the combination of ivosidenib plus azacitidine was associated with a better event-free survival as compared to azacitidine alone. This was about 22.9 months versus 4.1 months and showing an 61% reduction in the events. On a long-term follow-up, they showed that the use of ivosidenib plus azacitidine was associated with a better overall survival at about 24 months. It was about 60% as compared to about 20% with azacitidine and placebo. If you look at the 3-yearly overall survival rates, it was about at 12 months 62%, 53% at 24 months, and 41% at 36 months. Now, 1 in 2 patients in the ivosidenib plus azacitidine arm achieved CR, and which meant that roughly about 47% achieved CR, and overall response rates were about 62%. This was much higher than the 20% that you got in the placebo with azacitidine arm. Now, remember that this drug will cause differentiation, so you have to be careful, but the advantage also is the fact that there was less neutropenia, and because there was a rapid and sustained increase in neutrophil counts, it was associated with lower rates of infections as compared to the azacitidine arm. There was also sustained platelet and hemoglobin recovery, all related to the fact that response was significantly better. Looking at secondary endpoints, transfusion dependency had come down from about 53%, had reduced transfusion, became transfusion independent as compared to 17% with the azacitidine arm. And when you look at side effects, the major side effects which we had to worry about is one is this. This is the QTC prolongation, which was definitely higher with ivosidenib. 2, differentiation syndrome was higher with ivosidenib, and there, like what we do with, say, ATRA, we would use dexamethasone to try and reduce the differentiation syndrome. Infections were actually much lower in the ivosidenib arm as compared to the azacitidine alone arm, and probably reflecting the fact that the neutropenia was not that dense with the ivosidenib and azacitidine. So this is the only IDH1 inhibitor, although now olutasidenib has also come in in a phase 3 randomized trial. Evo plus Aza significantly improved EFS and clinical response, higher OS with Evo plus Aza, and a manageable safety profile. One of the criticisms of this trial was that generally we use Aza plus Ven. And unfortunately, the control arm had Aza plus placebo. So the question was, when you compared it with Aza plus Ven versus Aza plus Evo, would you still have that advantage or not? So this was real world evidence looking at data which was collected, which was just a retrospective chart review looking at response to AZAV plus VEN versus AZAV plus EVO, and essentially showing the blue one is the AZAV plus EVO, showing higher CR rates and higher overall remission rates with the use of evocidinib as compared to the VEN plus HMA. And this response is actually similar to the original studies of azacitidine with venetoclax, where you looked at about 40 to 50% response rates in this group of patients. Now, how do you sequence? Do you use VEN first, followed by EVO, or do you use EVO first, followed by VEN? So this is data from MD Anderson looking at patients who first received IDH-based therapy, and then, if they did not respond, received VEN-based therapy, as compared to patients who received VEN-based therapy, and if they did not respond, go to IDH-based therapy. Essentially, what they showed was that IDH1 and 2 inhibitors had very little efficacy following venetoclax-based therapy. So, if you decided to use IDH-based inhibitors, you probably need to use them earlier, but you could use IDH1 inhibitors, expose them, and still get response with venetoclax-based therapy later. Now, can we do better? So now people are looking at triple therapy. So this is combination of evocidinib plus venetoclax plus azacitidine. So this is a phase 1/2 trial looking at standard doses of evocidinib with 2 different doses of venetoclax, 400 and 800, along with 7 days of azacitidine, given as 28-day cycles and continuing till disease progression. The characteristics, if you look here, the median age are people, most of them who are not candidates for intensive chemotherapy. So the median age is about 67. They had patients with MDS, newly diagnosed AML and relapsed refractory AML, all put into the same basket. And they had this inclusion and study objectives. So the primary response, because this was a phase 1 study, was to look at safety and tolerability. If you look here, there is about 10 to 20% febrile neutropenias, lung infections, abdominal pain, which actually, if you look originally at the study on AZA with VEN, they are probably similar to that. Importantly, there was no day 30 or 60 mortality on the study. One death occurred secondary to febrile neutropenia and pneumonia, which occurred in a patient who had relapsed while on treatment. Now, beyond 5 cycles, the triplet therapy showed almost 100% overall response, with about a 67% complete response in this group of patients. And importantly, in those who are in CR, almost 90% were also MRD negative. That means that the response that you are getting is not only in terms of hematological remission, but also in terms of deep remission. So, if you look here, this was the group which had EVO, AZA, they did well. It's almost 100%. With the VEN 800, that's about 80% with the VEN 400, and they are much better than the EVO VEN alone. Importantly, the patients with MDS did better than relapsed refractory and newly diagnosed AML. So there's now a study going on looking at EVA as a placebo versus EVA as a VEN as a randomized trial from the UKML group, and we need to wait for the results, and this is the schema. So what did we do with our patients? So we gave them the 3rd cycle with azacitidine and evocidinib. We used only 250 instead of 500 because we were worried about toxicity. Post-induction, the bone marrow showed him to be in hematological remediation, and importantly, he became MRD negative. So this was discussed. The options were to go on to just evocidinib maintenance alone. He's 74, or go for a transplant. He opted to go for a transplant, so he's presently in our transplant unit having an alpha-beta depleted haploidentical transplant. So I'll close by saying 2-3 things. One, IDH1 inhibition has become important in terms of maintaining and getting deep molecular responses. So I think it's important like how we did for FLT3 of getting the results early, we should try and get the results of IDH1 early, because the data on both AZA plus EVO or the triplet as upfront therapy for those who cannot get intensive chemotherapy is actually very exciting, and getting them up early probably is the key to getting a deeper molecular remission. Of course, it will all depend upon at what rates they come with this drug into the market, but this is something which still we can use for Indian patients. Thank you very much for your listening.
But we need to be for that idea from the what because for that.
So initially it was put as a poor prognostic marker, but based upon the data now, we have actually, ELM has actually put it into a good prognostic marker based upon the data that is available. So that is if you are giving chemo plus an IDH1 inhibitor, and that is probably the most important. It is still poor prognostic if you're using standard chemotherapy or azaven.
So you want to say that if IDH1 persists even as a when, you would like to get a drug to make that IDH negative so that the remission rates remains longish.
Definitely.
Sir, what are you doing to say a young patient who comes IDH mutated? Say because normally, sir, we still don't get IDH mutation pretty early. So by the time my 7+3 is over, at the end of it, the NGS panel comes. Now he's MRD negative, but the NGS panel at diagnosis has said IDH1 positive. Now he's already planned for his HIDAC and maybe a transplant subsequently. So how does the IDH1 change the entire?
So right now, I don't think for a young patient, there is data to say that you may not get away from transplant. Okay, it is in the group of intensive chemotherapy ineligible. For a young patient, I would say it works the other way in terms of trying to use IDH to get deeper molecular remission before you take them up for transplant. We are in the same boat. Rahul is exceptional that he gets his genomic data in 3 to 5 days. I get it in 21 days. By then the induction is over. Then you have to make the call on what you do. So we would follow the same thing in terms of what you said.
So, do you see that the IDH1 in your experience of 7+3, would you change your therapy to azaven and IDH1 inhibitor rather than 7+3 in the next 5 years?
So the data is there on azaven IDH1 inhibition, which shows very good. There are studies going on 7+3 plus IDH1, similar to all the FLT3s. We'll have to wait for the data and see whether that shows taking it upfront is feasible and whether it produces more remission.
Transplant, we can say we have transplanted, or does it mean?
No. I think all that data is still up, not at there.
How many of your below 60 gets a 7+3, and what is the mortality?
So generally below 60, so our cutoff is usually 50 now. Above 50, we would give azaven, not 7+3. It's about 70-75% we would get remission with azaven.
So I think, Dr. Biju, the point is well taken that with the Myeloma match coming up, there's a trial in US which is running a Myeloma match, which where they give the chemotherapy based on your genomic profile. India has to quickly adapt to this Myeloma match therapy, because then actually you can reduce the cost and the mortality with 7+3. Dr. Dinesh, before we end, Riaz and Dinesh is there. What about your flag venetoclax, because that's your
There
thing.
is another talk.
So thank you, Dr. Biju. So I think it's a very more enthusiastic and a wonderful world where we are getting away from toxic therapies and moving towards more targeted therapy. But how it's going to fit into an Indian setting, I think health economic guy is going to help us all. So moving on to the next session.
Thank you so much, sir. This session was sponsored by Servier. For the first talk of session 1, I would like to invite Brigadier Rajan Kapoor sir and Brigadier Ajay Sharma sir as chairpersons. Brigadier Rajan Kapoor is a senior consultant at 153 GH Lay And Dr. Ajay Sharma, Brigadier Sir, is a director at Paras Hospital.
Good morning. Continuing with the next session, which is going to be on AML. Uh, the topic is no, it's AML, which is the changing landscape of risk, response, and relapse. I think Dinesh Burhani needs no introduction. He is too modest to be talked about in great sentences, and his persona speaks for his capabilities. Dinesh, I'm sure you are going to again enlighten us today with your thoughts. Thank you.
Thanks, Chairperson. Thanks, Rahul, for inviting me. My topic is about changing risk, response, and relapse. I'll talk about the AML. Can I go to the AML after relapse is bad. So we should not allow the patient to relapse. We should do everything. And now there are many options. The many options are coming up. So there should not be more than 5 to 10% mortality. So the mortality of 20%, 15%, or 25% is not accepted. Considering the patient if survives the induction, we have many more options available to salvage him. Even you can do a upfront transplant. So someone who has a curative option, we just induction mortality of 5 to 10% is not allowed. We may have to change the therapy. So I would say whatever the Western words say, if that your mortality is more than 10%, change the therapy. Go back to the less intensive therapy. We are in the confusion era. Any young patient comes to us whether we should go for azavan, whether we should go for the intensive therapy. When you're going for the intensive therapy, the 7+3, when you hear about the 7+3, even in a private setup where you have all the facilities available, the risk of mortality is still there. Why we are in confusion era? Because there are a lot of mutation and there is a combination of mutations. So they all behave. This is not a one disease. It's a complex multiple diseases rather than one disease. We'll talk about the prognosis. There are many classifications. Previously, if you see, there was the ELN 2010, there was the ELN 2017, there was the 2022. Now, if you treat it with the 7+3, you need to have this classification. If you treat it with the low intensity, this classification. What about someone who is treated, induction is less intensive, then it becomes more intensive, which classification? And these classifications are all still not perfect. There are many more versions of these. The refined ELN 2024. So this further classifies with the 9 variables that has not become a part of the mainstream, but there are many variations are coming up. This is for the risk stratification in the elderly intensively treated. So someone who is elderly, if you treat with the intensive therapy, what classification has to be treated? I think we are definitely the ELN 22 is going to change. Definitely there will be more modifications of ELN 24 also. And that also depends on whether you've been treated intensively or whether you've been treated with azavan. Now there will be a triple therapy. So there may be still changes when you treat with the targeted therapy, whether that bad prognosis may not be that bad. So I think the classification, there are going to be multiple classifications. depends on which kind of a therapy you're going to use it will be different. There is a harmonic classification. There are 60 odd genes, and then there are 30 karyotypes that meet together. There are 17 prognostic systems. So even NPM1, which is a good risk, it comes with the P53. How are you going to say is it good or bad? So there are even one is not a one mutation, is a combination of mutations, and there are 17 categories are going to be behaving differently. So we have evidence that if the combination of these are going to behave, and the treatment is going to behave differently. We divide it into the induction of remission and then post-remission therapy. The treatment is also a confusing era. Everyone probably will agree above 60, whatever the Western guidelines is. In India, I was in one of the meetings of SCC. There was one prominent hematologist said, we treat all the patients with azavan. And when I registered, that said, you do not represent India. So I was put down saying, you're not a part of India. You're treating someone who is staying into England or Western world. That's not true. Still, the young patients needs to be treated with the intensive therapy, unless you say that less intensive is better than intensive. So we don't have evidence, but the practice in India actually in the 90% of the places has changed. And that's a worrying thing. Below 60 is the most complicated, whether we should go for intensive or azavan, whether 7+3, or there is a less, more palatable intensive therapy is there. Various factors are there. So genetic factors at diagnosis, intensity of the therapy, what is the MRD status, whether the patient is going for the transplant or not going for the transplant, whether the patient is receiving a maintenance or not. So there are many variables. But life was very easy before 2017. Everyone needs to be treated with the 7+3, 3 cycles of high dose consolidation. And if you're not going for the transplant, it's a consolidation, or you go for the transplant. The life has become more complicated. So the intermediate risk becomes MRD negative, whether you will go for the transplant or you will not go for the transplant. Patient has received the FLT3 inhibitor, whether you should go for the transplant or should not go for the transplant. More complication. This is a paper coming up. This is a plenary session, paradigm trial, where the azavan has been compared with the 7+3 in below 60 young patients, except the core binding fusion, FLT3 mutation, or NPM1 mutation. So if you don't have a 3 mutation, there is a randomization. Overall response was significantly higher in the azavan arm, 88% versus 62%. CCR was higher, 81% and 55%. CR rates were similar. But the important is more patients went for the transplant. So azavan, the 61% of the patient had gone for the transplant. How it will transplant? You will listen more about it. This one post ASH. How the patients will be, this will be translated in India. If you treat the patient as an outpatient induction for AML, and then you ask him to go for the transplant, you need to have a 20 lakhs rupees, you need to have a 10% mortality. Very few patients, in spite we were doing earlier, only 10% of patients used to go for the transplant. Imagine someone you have given an induction as an outpatient at home, and then you try to convince him for the transplant. Very few patients will be convinced. So if you are giving an azavan upfront, you need to go for the transplant unless you are in a very good risk group. So azavan will translate into a good outcomes provided you transplant them rather than non-transplant. Azavan is not curative. So I don't think I do not represent India, but I think I'm worried about India. Considering you're treating with azavan, keeping them comfortable, they will be relapsing within a year or two without going through the transplant. We should not forget, azavanitoclax is not curative. You need to give us some consolidation to cure it. If you're going on with the azavan, considering the young age, you are doing a harm rather than benefiting them. So that's the important message. In spite there is a plenary session suggesting the azavan is better than 7+3. I would still go for a definitive therapy, because my majority of the patients do not go for the transplant. If you're going for the transplant, I give azavan, taking for the transplant, I'm okay with this data. But if the patient is not going for the transplant, is not sure about going for the transplant, I would like to go for the intensive therapy. If your induction mortality is higher, please don't go for the intensive therapy. You're not allowed to kill in a recent era, the patient can be salvaged even upfront with the transplant. So I would not accept, this is my personal opinion. If it's less than 10%, go for the intensive therapy. If your mortality is more than this, then say considering this is some government setup where there's not much of a facilities for neutropenic care are not available, probably you may not justify to go for intensive therapy rather than going for the ASAVAN. This is and there is another confusion with the intensive therapy adding a third drug. So already we are adding a third drug. So someone who is a CBF AML, you cannot, definitely the results are poor if you don't add a GO. This is my personal experience also. If someone has FLT3, you are a 7+3, you are giving a midostaurin. What about the intensive therapy with venetoclax? So adding a third drug with a, what the Western world is doing, they do a flag IDA with venetoclax, 7+3 plus venetoclax, 7+3 plus IDH inhibitor. So they are going for more intensity. We are not cutting down the intensity without improving the survival. That's a difficulty for India because we cannot be more intensive than 7+3. So we need our innovations, we need our trial. So less intensive, the equally effective triplet may be the more effective than the this is so that's a Western way to go. It's a flag IDA with venetoclax. They are not worried because their mortality, if you see, there is no mortality. So their mortality is less than the 30-day mortality is 0. We cannot compete with them. So you cannot translate the trials from Western world to the India. We need to have our own data to suggest the mortality should not be more than 10% and we can cure more patients. Our patient, majority of the patients do not go for the transplant. That also we need to remember. So ASAVAN alone is not going to be the answer. We need to consolidate them either with the transplant or with the intensive therapy. This is my experience with the flag van. We need to combine the more data. There are more people are using a flag van. There is a less mucositis. There is a less mortality than the 7+3. We compared our 7+3 with the flag van. Definitely the mortality was less. 61 patients, the mortality was 2%. Both were from adverse risk. The favorable risk, CR was 89%, intermediate risk 83%, adverse risk 70%. Now you go back to this ASAVAN trial. If you go back to the previous one, the results are looking like 80% and this. So we are equal to the probably this, but this is not across the trials or this is mine is a retrospective data. So I cannot claim that mine are equal to this. So I mean, but definitely intensive therapy. Probably we may have to take out the adriamycin or daunorubicin because that causes a mucositis that leads to the MRD infections, and adding a venetoclax. So combination of venetoclax with intensity, not so intensive like the Western world, may be the answer. Now that we reach to the MRD era, there is also a lot of confusion. So which method to be used? For this mutation, you have to use PCR. This method, you have to use a PCR NGS. This method, you have to use a flow cytometry. Flow cytometry MRD is not perfect. 30% of the MRD negatives still relapse. So we need to have, and the MRDs keep changing. One day they will say you use a PCR, the next day they will say you use a DDPCR. Now the next day there will be a PCR NGS, and there will be more refinements for the method. So the guidelines will keep changing for the method, and then what you do if you are an NGS PCR NGS negative for FLT3. Do you need to transplant or you do not need to transplant? We don't have a data to suggest that. So good, the methods are improving. Good, we know the deeper responses, but we don't know what to do with that. So there is a lot of confusions going on. Definitely there is a data to suggest if you are MRD negative, you do better than the MRD positive. So MRD is a part of the treatment now, but we don't have enough data to suggest there are more deeper responses. You can assess them. There are many subgroups you can do that. But we don't have enough data to suggest you don't do a transplant or you get away without the transplant. There is a lot of many concerns come to the patient is now MRD negative. The patient was in an intermediate or adverse risk group, become MRD negative, whether he still needs a transplant. But there is enough evidence from meta-analysis. The 5-year overall survival is 68% versus 34%. Transplant or no transplant, I took a data. So if you are not transplanting, still the favorable risk, there is a significant risk of relapses there. That's with the GO. If you don't use a GO, there is a 50% relapse. Intermediate risk, there is up to 58% risk of relapse. Adverse risk is 60 to 70%. Our patient has money for one treatment. So these data should be remembered. how much is your relapse risk? So if you are not going for the transplant, you have a 70%. If you are in an adverse risk group, you have a 70% chance of relapse. All the money will go zero if you don't do a transplant. There's a 70% of this thing. So these data should not be forgotten. Transplant is now not a transplant. Previously, you do a transplant and forget about. So you need to bring the MRD negativity. So before the transplant, if you are MRD negative, you do better. Then you do a transplant and then you do a maintenance. So or even during the transplant, you change your conditioning regimen. So before the transplant, conditioning, and then post-transplant. So the transplant becomes a one component of the total treatment rather than the end component of the treatment. So the transplant is you need to still do a maintenance post-transplant. I think the debate will be between the triplet versus intensive therapies. So we have a lot of triplets coming up. He showed a data of 100% with a less mortality. We need to compare it with the intensive therapy, but we cannot amplify that Western data because they will be comparing with the only chemotherapy or chemotherapy plus venetoclax. So that will be more intensive for us. We need to have our own regimen. For us, we have been very comfortable doing a flag when. We have a very good data with the flag when. The drawback is a retrospective data, and we have not done a randomized prospective data to suggest that we have a less mortality and roughly equal outcome. There is a recommendation, say, going for the triplets. There are a lot of recommendations, at least for the elderly. We need more data into the younger patients also. The future is very bright. Imagine we had only 7+3 and post-consolidation. I'll finish with this. Thank you.
Great.
Thank you, Dr. Ganesh. I think AML is what defines a hematologist. Just one quick question. I mean, excellent data with flag when we also tried it in upfront, and so it's a very smooth sailing. How many finally did go transplant after flag when out of these 61?
We are the intermediate and the adverse risk. We are doing the transplant. Many have gone for the transplant. I don't have the data, and I had to take it out the 1 year EFS. Like in this trial, they have taken out the 1 year EFS. So that will include the transplant also. Whether you have gone for transplant or not gone for the transplant 1 year or 2 years, EFS will be important rather than only CR. I think we need to get that. That's my weakness.
Sure. Dr. Dinesh,
but many have gone for the transplant.
Dr. Dinesh, बहुत ही सिंपल सी बात है कि अगर यंग पेशेंट में एल्डरली पेशेंट में
my concern is the patient will go for azavan, survive for 1 or 2 years and die. There will be more deaths rather than they may have been cured with intensive chemotherapy.
So there's a twist to that. Counterpoint to that is जितना पैसा प्राइवेट में इंडक्शन थेरेपी में लगता था, अगर हमारे पास 3-day जीनोमिक्स है और NPM1 FLT3 है, azavan के साथ भी अगर 70% रिस्पॉन्स है, 7+3 के साथ भी 70% रिस्पॉन्स है, तो why not to save the money with 7+3, not giving 7+3 azavan and then doing the transplant? So
make sure your patient goes for the transplant.
So goes for
that commitment you have to take it. I mean, I'm okay giving azavan induction, and azavan mortality is not less. But there is a prolonged cytopenia. You may not have early deaths, but there are later deaths because of the prolonged cytopenia.
Before Biju interjects into that, the second question is Geo. The 821 का हम हर
Can I get my slides back? I'll show you that they have a significant mortality.
821 में हम हर बार बोलते रहे it's a good risk. So do you think in the absence of Geo, 821 is a good risk? Because I'll tell you, we have got 32% NRAS and we have got 18% C-kit, which is double the NRAS and C-kit from the Western world.
Can you put the slides, please? Yeah.
So two things, Rahul. One is with regard to the 821, when they talked about being good risk, at that time they had not done C-kit, was not part of the protocol. So definitely if you are C-kit positive with 821, it is bad and you would consider transplant upfront. Only those who are 821 without C-kit, it's still debatable whether you would do transplant or 4 HIDACs. Definitely, the data is that if you add on the GO to standard chemotherapy, the outcomes of 821 definitely.
My experience has been very good. So I put all the patients of 821 to get the GO. Is someone who can afford it, and there is a starking difference between the outcomes of patients.
The other one with regard to NPM1. Now the decision on whether you're going for transplant is based upon what is the risk status at the beginning of treatment. So if you are NPM1 positive without anything else, you are actually considered good risk. Now, there, the question of transplant will all depend upon one, what you've done initially, whether you are MRD negative, and then what you're going to do post. So giving azaven alone after azaven does not make sense. So what we do is if they are not
That's why in bigger worry in the whole India, the patients will be more comfortable getting azaven and not.
We actually advise for 4 cycles of high dose HIDAC after azaven if they are not going for transplant. We have just gone to 1.5.
I want to show you the last lines. The grade 3-4 therapy related adverse events were more than 10% in the both arms. Grade 3-4 lung infection and sepsis occurred in the 12 and 7% of the azaven and 15 and 11% of the. So it's not less. Even in the Western world with azaven, the infections are not less.
One very interesting thing which you said, which I agree, is a person who has undergone 7+3 inpatient is more amenable for transplant. He accepts transplant. A person who has gone through OPD,
someone who has
someone has gone through OPD and
the infection at home, getting him for the transplant is a major concern.
So it's that way it's important.
First of all, congratulations for giving a talk which is challenging the contemporary thoughts that are coming, and we are applying the Western data. We need to be innovative. You are very right in that. I think I'm very happy with the kind of talk that you gave today, Dinesh. I think we need to have more of such questions and then follow the practice.
We have been too much behind the 7+3.
So,
we needed a new intensive therapy which is not 7+3.
So carrying forward that is, how many of those patients whom you have given the azaven will achieve MRD after induction? That is one. And second thing is, you also mentioned that we can give flag when. So if we give flag when and then give consolidation, as Dr. Biju was mentioning, I think that should make a good combination rather than going in for the transplant straightway after azaven.
No. So the transplant is for your genetics. So if you are in an intermediate or adverse risk, you go for transplant. If you are in a good risk, you don't need a transplant. But the only thing is the giving azaven and not doing an intensive chemotherapy is going to be a problem. Thanks. The 61% of the patient of the azaven had gone for the transplant versus 40% of the 7+3 had gone for the transplant. So if you are giving azaven, the more patients needs a transplant.
Right. Absolutely.
Thank you.
Thank you so much, sir, for the informative presentation. Thank you, chairpersons. May I now call on stage the chairpersons for the next session, Dr. Riaz Ahmed, sir, and Dr. Tejaswini Ved. Dr. Tejaswini Ved is a consultant hematology at Medanta, Gurgaon, and we have heard Dr. Riaz Ahmed, sir. Please welcome.
And he's the first time the black and so that was so moving on to the next section.
Sure. So, continuing with the AML session, I'd like to invite Dr. Biju George for the next presentation, Targeted Therapy Sequencing, FLT3, IDH, and Menin and beyond. Dr.
Thank
Biju.
you. And I should thank Rahul because he sort of made me do 4 talks into one in 15 minutes. So I'll try my best to do that. So we're looking at targeted therapy sequencing, FLT3 and beyond. So when we look at a standard treatment protocol for AML diagnosis, you give chemotherapy, may decide allotransplant, then of course many of them relapse. And so you can use these disease-specific mutations to try and see where you can get into each of these groups to try and treat them. I'm going to be talking about 4 different disease groups. One is the FLT3 inhibition, SMO inhibitors. I'm going to be looking at the IDH1 inhibitors and now recently the menin inhibitors. Before I do that, just talk about the VIAL-A trial. So when we look at the VIAL-A, definitely when AZA was better than AZA with placebo, you had by about 75 to 80% by the first 2 to 3 cycles would achieve remission. And importantly, those who did not have TP53 did well, TP53 did not do well. And on a longer follow-up, this was published just last year, the AZA plus VEN continued to do better than AZA placebo. Those, as I mentioned, those with IDH inhibitors still continued to do well. Importantly, those who had MRD negative did better than those who were MRD positive. So what about FLT3 inhibitors? Now remember, about 30% of AML are FLT3 positive at diagnosis, ITD in 24 and TKD in 6%. Now, at relapse, those who are FLT3 negative, about 10 to 20% become positive, and 25% of those who are FLT3 positive actually become negative. So it's important that at the time of relapse, you should repeat the FLT3 to decide whether you can use it or whether you don't use it, and ITD is seen more than TKD. So I'll just go through some of the FLT3 inhibitors that we have. So midostaurin, this was the ratified trial published in 2017 where they looked at about 717 patients who are randomized to getting standard 7+3 chemotherapy plus midostaurin that was continued during consolidation and then maintenance given up to 12 cycles. And essentially they showed that overall there was a better overall survival with midostaurin as compared to placebo. The median overall survival was 74 months versus 25 months. Even in those with a TKD mutation actually did better with midostaurin as compared to placebo. This was the German study, the AML SG 1610, where they again looked at midostaurin versus chemotherapy and maintenance. About 284 patients, CR in 76% with 72% proceeding to transplant. They looked at ages more than 60 and less than 60 and found that there were similar outcomes. And doing a propensity score matched analysis with historical cohorts, both in the older and the younger age group, the addition of midostaurin definitely was better as compared to no midostaurin alone. So this is the data with midostaurin. The quantum ARC study looked at quizartinib in relapse refractory AML, and this was quizartinib versus salvage chemotherapy. Remissions were short, 32% had a transplant. The overall survival was only about 6.2 versus 4.7 months, and essentially showing about a 7% difference between quizartinib versus just doing salvage chemotherapy alone. These results were encouraging, and so they went on to the Quantum First trial where they looked at quizartinib with standard 7+3 chemotherapy, then going on to either consolidation or allogeneic transplant. And if there was consolidation, you would add quizartinib in that arm and then giving quizartinib maintenance only in the quizartinib arm for up to 2 years. The primary endpoint was overall survival, and there was a definite improvement when you added on quizartinib to the standard chemotherapy as compared to the placebo arm. So definitely quizartinib seemed to be useful in both getting initial induction remission as well as later during maintenance and then subsequently leading to better overall survival. The third FLT3 inhibitor is gilteritinib, initially done under the Admiral trial where they looked at relapsed refractory AML, randomized 2:1 into gilteritinib with any salvage chemotherapy, followed by transplant, and then you could resume gilteritinib. Roughly about 370 patients were treated on an intention to treat analysis. Roughly about 80 of them actually proceeded for transplant. Many of them did not go for transplant. The initial overall response with gilteritinib was about 67% as compared to 25%, with a complete remission about 21% versus 10%. And importantly, there was a 36% reduction in the risk of death. More long-term follow-up at 1, 2, and 3 years suggested that there was an advantage of gilteritinib over the standard of care arm. Importantly, a study from France looked at patients who were previously exposed to midostaurin and then received gilteritinib, and they showed that gilteritinib was useful. A subsequent study was done, which was published last year, looking at gilteritinib as a post-transplant maintenance, and there were 356 patients randomized to either receive gilteritinib or placebo as maintenance post-transplant. Essentially, the relapse-free survival did not achieve significance. It is 0.51 as compared to, it should have been less than that. So it was actually a negative study. But when they did a subset analysis, I'm sorry, whether it's coming properly, those who were MRD positive at the time of transplant had a much better advantage with gilteritinib, while those who were already MRD negative did not have better improvement in relapse-free survival with the use of gilteritinib. So MRD positive at the time of transplant, there was a benefit of using gilteritinib maintenance. After the FLT3 inhibition, the second is the IDH1 and 2. I talked about it earlier. IDH mutations are seen in 20% of AML and more commonly in the elderly patients. So the initial study in relapse refractory was with ivosidenib, looking at ivosidenib alone in a dose-finding study, essentially showing about 40% overall response rates, which was encouraging because these were people who had failed at least 2 lines of therapy before they actually came onto this drug. Subsequently came the AGILE study, which I described earlier, ivosidenib with azacitidine versus placebo with azacitidine, and essentially showing that the use of ivosidenib with azacitidine was associated with a better event-free survival as compared to azacitidine with placebo. The IDENTIFY trial looked at enasidenib, which is a IDH2 inhibitor, and looked at enasidenib versus conventional care regimens. Although the overall response rates were significantly better with the IDH2 inhibitor, unfortunately, the primary endpoint which they put was overall survival. And because the overall survival was not different between the two arms, it was considered as a negative study. The third is menin inhibitors. Now, some of the AMLs are driven by the overexpression of HOX genes, and if the HOX genes are overexpressed, that leads to uncontrolled proliferation and leukemia. The main groups where you see them are the KMT2A gene rearrangements, so it's the 11q23 rearrangements, the NPM1 mutations, and the NUP8 DEC rearrangements. And now these are seen in about 30 to 40% of AML. So remember, this is actually a reasonably large group of patients who have these problems. So this is the Augment 101 trial where they looked at revumenib, which is one of the menin inhibitors in an open phase trial. There were 2 cohorts. I'll talk about them separately. The first cohort was a KNM2A rearrangement in either ALL or AML, and the second cohort was an NPM mutated AML. And they looked at, basically it was a dose finding and a safety tolerability study. They showed that it was reasonably okay. 83% were AML, mainly primary refractory, untreated relapse, and a remission rate of about 20 to 25%. In the NPM cohort, which was the second cohort that they looked at, they found a response rate of about 45% in this group of patients who have already been treated and were relapse refractory. Based upon this data, the study went on to this BEAT AML trial where they looked at adding on revumenib upfront to patients with ven-aza in newly diagnosed AML. So it was revumenib with aza-ven. Then when they went into remission, either you could continue treatment indefinitely or you could go for a transplant, or if you were intolerant, you would stop it. Now this is very staggering data. So looking at different doses, you found that the overall response rates were close to 85 to 90% remission rates. So this was very good data which showed that it was very good, and importantly, a lot of patients who were in remission were also MRD negative. This is an ongoing trial where we need to see more data, where they are looking at decitabine, cedazuridine with venetoclax, and the initial data seems to suggest that is very good. Ziftomenib, and so because of that, revumenib was FDA approved. The other drug that is approved recently, just 2 days back, is ziftomenib, based upon the trials in MPN1 mutated AML, showing roughly about 40 to 50% response rates in patients with relapse refractory AML. Now, there's a trial going on looking at ziftomenib with chemotherapy in AML with NPM and KMT2A. We have to wait for these reports to come in. What is initially reported is that roughly about 50 to 60% show remission rates. The last I will talk about is a hedgehog inhibitor with this glastitinib. Now, this was used in the BRIGHT trial in combination with either intensive chemotherapy or non-intensive chemotherapy. It was randomized to 2 arms, so it was actually a 4-arm trial. Roughly about 50 to 60% showed responses. Unfortunately, the primary endpoint was overall survival, and the overall survival was not reached, so it was considered as a negative study. So when we look overall at AML, there have been some successes. So with IDH mutated, NPM mutated, the FLT3-ITD mutated, the use of these new targeted therapies have helped in improving remission rates both in relapse refractory disease as well as when used upfront. The challenges are with this group here. Still, TP53 mutated AML does badly either with chemotherapy or with transplant. The drugs that have been tried have not worked. The MICOM AMLs, the post-MPN AMLs, therapy-related AMLs still do not do well. Now, if you have two mutations, how do you decide what you're going to use? There is a study, you should read this paper by Jayestu, which talks about what kind of inhibitor would you use first if you have more than one mutation, depending upon what is the parent mutation and what is not. So there are different drugs that you can use in different scenarios. So putting everything together, where are we? If you look at FLT3 inhibitors, frontline, you can use midostaurin, quizartinib, and sorafenib. Sorafenib, midostaurin, and gilteritinib are useful in post-transplant. Quizartinib, it failed in the post-transplant area, but it worked well in the post-chemo consolidation. Relapse refractory, you can use gilteritinib, quizartinib, and sorafenib. Now, when we look at IDH inhibitors, ivosidenib can be used frontline. I had presented data earlier, but this is in patients who are not fit for intensive chemotherapy. So only azaven with ivosidenib, while ivosidenib, olutasidenib, and enasidenib are already approved for relapse refractory AML. The menin inhibitors are only available for relapse refractory AML. Revumenib is for both KNM2A and NPM1 mutation, while ziftomenib is now FDA approved for NPM1 mutations, and glastitinib is approved for patients more than 75 years who are not eligible for intensive chemotherapy and need less intensive chemotherapy in combination. It's probably showing good results. So I'll conclude by saying targeted therapy has definitely improved the outcomes in relapse refractory AML. The combination of targeted drugs with intensive chemotherapy or azaven as first-line treatment has improved completion remission rates and ensured deeper remission. Most patients are likely to be taken up for transplant because of the deeper remission. However, as mentioned before, the use in India will depend a lot upon the cost when they come into the country and when it's available. Thank you for your attention.
Thank you, sir. That was a very comprehensive talk. My question is that when in a patient with a FLT3 positive disease, how do you select the patient for if you would have to choose a triplet regimen? And if you have any experience with respect to managing the side effect profile?
So we have used midostaurin upfront. So with 7+3, but we started by day 8 and then continue it. And we have had 1 or 2 patients who did not want to go for transplant, so that we used it during consolidation. We find that they are tolerated very well. I have one patient who I've given gilteritinib as for relapse refractory AML, who's tolerated it well. But these are small numbers, I should say.
And sir, any experience with azaven and a FLT3 inhibitor?
No, I haven't. I haven't used that before, but that is something which. So earlier we used to be getting our FLT3 data very late. Of recent, we've got our now a rapid PCR where we get a FLT3 in 7 days. So we are hoping that we can put in more patients into the AZAVEN cohort with this once we get the data.
I think, Biju, the lighter side is that you can use a 3-day NGS because then we are eliminating the need for the PCR, and probably next year we'll be talking about eliminating the need for cytogenetics as well. So 3-day NGS is a boom for all people in India.
So, one question. Which patient of AML not be transplanted in this era?
So I would say, so for example, if you have good risk AML who doesn't have target and has become MRD negative and does not have adverse or intermediate risk cytogenetics, you may manage with just consolidation alone. For me, an 821 who I give standard 7+3 and does not have a c-KIT mutation and becomes MRD negative at the end of chemotherapy, I would not transplant. So I think the question of transplant is based still on what is the risk status at the beginning and what happens to them post-induction, whether they achieve hematological remission and MRD negativity.
As Dr. Dinesh has shown, that we thought the transplant was the end, but it's just the beginning, because post-transplant you also have to give the maintenance and doing a lot more testing to see whether MRD is there. How strong and how your belief is towards post-chemo or post-transplant as a strategy to detect MRD by either flow, PCR or NGS? How strong your conviction is on that?
So I think doing MRD post-transplant is important in terms of picking up remission or picking up this persistent disease. So we for any transplant patient that we take up, we would definitely do it at 1 month and 3 months, looking at MRD. Now beyond that, it is. I don't think there's data. Of course, people would like to do it monthly, but that means you're going to do marrows. You need the money, finances for all that. I am a big believer in DLI, so we would give generously DLI for patients where we are worried. I think we are going to have a discussion on post-transplant maintenance. That will be later.
No, if she was asking about the AZAVEN with triple drugs. When you're using a triple drug, we don't know how long to continue the venetoclax because the cytopenia will be much more prolonged. So that has to be figured out. I don't think we are reached to that case. How much of and the Western world will use a venetoclax for 28 days. So they can have a 50-day neutropenia. We need to have our own data to how much of venetoclax and how much of triple drug has to be.
So in that previous talk when I presented on IDH1 inhibition, they were using venetoclax at 400 and 800 milligrams and continuing it for 28 days along with this. I agree, it's a big problem in India.
So just a last statement. We have got a data on 5 patients who has been given AZA-VEN and gilteritinib. One patient died of fusarium, because extensive fusarium, and the cytopenias are no less than the 7+3. They run cytopenias up to 35 days, 40 days. So it is difficult to overcome the cytopenias, and the dose was like 80 milligram for 14 days, when 100 milligram for 14 days. So 5 patient data. The cytopenia is a real problem, and people do not recover as reported in 21-25 days, goes up to 40 days for remission.
And remember, in Indian patients, both bacterial infection and fungal infections are much more common than what we see in the West.
I'm looking forward to in the SCC to do a trials with our own mortality and
I think we have to think in terms of AZA-VEN combination, whether with the flag and then going in for consolidation if we want to improve the outcome in our patient.
I agree, Ajay. The only problem is going to be at what cost. Because if you look at the data, whatever is available on triple therapy, including targeted, it's very exciting because you're looking at 90% responses. The question is, are you going to spend 20 lakhs for that response or not?
And what do you, because the data is there initial, we do not know later down the line what we need to do. So unless we're able to come down with the cost of these drugs, trying to use them as triple therapy is going to be difficult.
Sure. Thank you.
We'll close the session.
Yeah. Thank you.
Thank you so much, sir. Thank you, chairpersons. Moving on, I now request Dr. Dinesh Purani and Dr. Rohit Mangal as chairpersons for the next session. Dr. Rohit Mangal is a senior consultant hematology at Pushpanjali Hospital, and Dinesh, sir, we have heard. Please welcome, sir.
Good afternoon, everyone. I'm Dr. Anusha.
Hello.
Shifting gears from infinite to finite treatment. This is sponsored by AV and Dr. Anusha Swaminathan. She is from Fortis.
Thank you, sir. Good afternoon, everyone. I'm following very big shoes, but I'll do my best. So, moving into the session quickly, shifting gears from infinite to finite treatment in CLL. So, we know that the goals of care, available options, and what we can expect in the life of a CLL patient is changing rapidly. The three available targeted therapies are BTK inhibitors, BCL2 inhibitors, and the anti-CD20 antibodies, all acting by different mechanisms. These are broadly the two basic philosophies that we have in treatment of CLL today, either a continuous therapy with a BTK inhibitor or a fixed duration therapy, which includes everything starting from the conventional bendamustine rituximab to ven-obin to a triplet regimen. Now, what the patient wants versus what the biology and the logistics allow us to deliver may be very different. And the sweet spot is finding something that agrees with all of this, including what the patient wants versus what can be given as per the disease biology. BTK inhibitors are great. These are the pivotal 3 trials for the ibrutinib, acalabrutinib, and zanubrutinib now as single agent drugs. We know that the responses are good. We know that this has significantly changed what can be expected in a life of a CLL patient. However, this comes at a cost. We know that there are significant cardiac side effects. The word significant may be used cautiously. More than grade 3 events are 1%. As we get more targeted BTK inhibitors, this may lessen. However, what needs to be remembered is these adverse effects continue throughout the period that the person actually takes the drug, doesn't stop with the initiation, and that's probably the clinching point in as to why we actually have to consider a time-limited treatment option. But this actually denotes the treatment discontinuation rates with continued BTK inhibitor therapy. And another primary problem is with BTK inhibitor therapy being given continuously, this may put a selection pressure to resistant clones coming up, which are not amenable to further BTK therapy. So it's easy to start. We have long-term data with single agent BTK inhibitors. We have prolonged PFS rates, and which give us a sense of comfort in especially high-risk diseases like TP53 mutated CLLs. However, we know that we do not expect an MRD clearance with a continuous BTK inhibitor therapy, and the treatment is indefinite, adding to the cost and toxicity. These are the world over guidelines. The ESMO guidelines give us stratified options where they say category A as time limited options, but you will notice that all of these categories have all of the options, except probably in P53 where the single agents are still category 1. Now, when we say fixed duration, what do we mean? Fixed duration can be ven-obin 1 year. It can be a BCL2 and a BTK inhibitor, which includes many combinations. Can be ven-obin, ACAL, can be ven-ibrutinib, can be a triplet, which is MRD guided, can include the BTK inhibitor, which are newer generations. And we shouldn't be forgetting that FCR and BR are also traditionally time-limited therapies. This is the pivotal trial which led to the approval of ven-obin in first-line newly diagnosed CLL as a time-limited therapy. The patient population was elderly and unfit patients, and it was a simple design where end of treatment was at 1 year, irrespective of whether they achieved an MRD negativity or not, and the primary endpoint was PFS. Like I said, older patients were involved in this study and included high-risk biology, including IGHV unmutated and P53 mutated patients. So this is the basic biological possibility as to why a time-limited therapy may be possible in this regimen. If you look at the undetectable MRD rates, clearly superior to the chemoimmunotherapy arm, both in the peripheral blood and in the bone marrow. So the primary endpoint was PFS. We now have long-term 6-year follow-up data of this. At 6 years in the ven-obin arm, about 53% as opposed to 21% of patients in the chemoimmunotherapy arm remain progression-free. To highlight this, at 1 year the treatment ends and the patient has been treatment-free for another 5 years, and still about 53% do not require further treatment at this point. Now, does it vary based on the disease biology? Doesn't look like it. Both mutated and unmutated patients, the ven-obin arm was superior to chemoimmunotherapy. And what about P53 mutated patients? Yes, definitely the curve starts dropping off. Definitely superior to the chemoimmunotherapy arm, but if you look at the data on red, the median PFS is achieved and it's about 51.9 months in the P53 mutated arm when you give a fixed dose of ven-obin. This is reinforcing what we already know. IGHV mutation status, 17p status, and bulky disease to begin with were all shown to be conferring worse prognosis with this regimen. Now, in day-to-day practice, this is probably what impacts us the most. The time to next treatment at 6 years, 65% of patients did not require another line of therapy after ending treatment at 1 year of time. Now, what about the P53 mutated subgroup in this trial? This is fairly reasonable. At 60 months, more than 50% of patients with P53 mutation were still off treatment in the ven-obin arm. And for somebody whom being off treatment is a priority, this is a significant number. Overall survival curves, not statistically significant as expected, but you can see them separating as time follows. Now, what about the safety profile? The main allure in this in this regimen is that during treatment, yes, you would expect neutropenia, you would expect thrombocytopenia, you have to watch for FN, but after treatment in the follow-up period, these numbers drop significantly. And to begin with, the TLS rates are only around 1.4% even while giving the venetoclax. Now, that was CLL 14 in unfit patients. CLL 13 looked at a fit population with upfront venetoclax-based regimens. Now, as expected in this study, the ven-obin and ibrutinib, when a triplet was used, the undetectable MRD rates were higher, and this translated to a higher progression-free survival, a slightly higher progression-free survival. However, this clearly came at the cost of a higher rates of infection in this trial. When we club this data together, when we look at whether the fitness was even a factor in achieving this response, whether tolerability was an issue, whether they discontinued therapy, it doesn't look like it. Whether they be fit or unfit, upfront 1 year of ven-obin, the PFS curves are merging. The overall response rates and the undetectable MRD rates are quite high when you look at both the fit and unfit population, and same goes with the adverse effects of these drugs. So fitness by itself does not preclude you from giving a fixed duration 1 year of ven-obin. Now, it's easy to say that it's a finite therapy and potentially cost saving, but I'm well aware that this may not always translate into reality. Front loading of the cost may not be what all patients can afford, but if the priority is a treatment-free period, then yes, this is a very alluring regimen. Of course, the conventional risk factors with a BTK inhibitor like a bleeding risk, cardiac arrhythmias, and hypertension are not there with this regimen. Looking a little bit towards other fixed duration regimens, not sure if this is completely. This is the second set of fixed duration regimen where you can actually combine a BCL2 inhibitor with BTK inhibitor. This is the biological plausibility as to why this may work better. The BTK inhibition mobilizes the CLL cells into the blood, where the CLL cells can be cleared quickly by the action of venetoclax. Looking at one prototype of these trials is the Amplify study, which was recently published, where they excluded P53 patients because it was no longer ethical to randomize them into the chemoimmunotherapy arm. They looked at Ven-Acal versus chemoimmunotherapy. Well, the study was only powered to look at Ven-Acal versus chemoimmunotherapy. Primary endpoint was PFS. Whether it be IGHV unmutated or mutated, the Ven-Acal-Rubin arm, clearly the curves are separating higher as compared to the Ven-Acal arm in both these cases. As expected, this comes at the cost of slightly higher overall incidence of grade 3 toxicities in the Ven-Acal-Rubin arm. And atrial fibrillation and ventricular arrhythmias are almost negligible in this trial. The logical next step was to look at whether an MRD guidance can overcome this P53 biology while we use these triplets. The phase 2 study that has been recently published in JCO shows precisely this, where at 16 cycles and at 25 cycles, you are given an option of checking your bone marrow and peripheral blood MRD and to make a decision as to whether you still do need a continued therapy. And this study was enriched only for high-risk patients with P53 mutation. Important takeaway from this slide would be, this is the overall population, this is the P53 mutated population. As time goes, the response rates and the depth of responses are almost similar because those who were MRD positive were advised to continue further cycles of therapy. Not shown here in the graph. However, the 4-year PFS and OS of 70 and 88% in P53 mutated patients does seem alluring. Importantly, they showed no ventricular arrhythmias, no febrile neutropenias. They did have infections, but no febrile neutropenias and no major bleeding events as per this paper. So, will a doublet actually emerge as the preferred fixed duration option? Because the important catch in this is it's an all oral option, which may be very important when you're practicing in a non-academic center. So is the safety profile really acceptable or at least non-inferior as compared to other fixed duration regimens? Will deeper MRDs or MRD guided triplets matter more in high-risk patients like P53 mutated CLLs with a mild trade-off of toxicity? And do we really need the anti-CD20 antibody in this mix, or does it make a difference in the high-risk groups? Are some of the questions that many of the ongoing trials are trying to answer. Another important concern is when we practice, are we going to front load all of our available options? Study is showing that it may actually be a better way of doing it because there's no selection pressure for BTK mutated clones to proliferate when you give a fixed duration therapy. Some practicalities of venues in CLL, we know the ramp-up schedule. If you look at the TLS rates, either in the frontline or in the relapse setting, it is quite low when you use the recommended ramp-up. This is the table that we all know from NCCN, where you risk stratify them as low, intermediate, or high risk based on their disease bulk. And if you note here, the high bulk disease actually recommends 2 weeks of inpatient admission, which cannot be discounted when we in our day-to-day practice. So is this a reason to not offer this therapy? Probably not. One of the practical things that we can do is, studies have looked at it, if you just push the initiation of the venetoclax by 1 cycle, most of them get re-stratified again to either intermediate or low risk. And sometimes in this study, if they will continue to remain high risk for TLS beyond this, they actually just gave them a single session of bendamustine, which quickly down titrated the risk stratification. And this by itself should not be a deterrent to offer them a time-limited treatment. This is a table that succinctly summarizes that treatment preference based on the disease biology, treatment logistics, and the comorbidity profile are all going to dictate what we can offer to a patient with CLL. I think we shouldn't beat ourselves up too much to give a single agent BTK, because world over this looks like what is happening in a community practice, and even BR and FCR are still offered to patients. So disease biology and logistics, along with what the patient can avail, dictates what we can give. But that means that time limited treatment, especially with Venobin, should be up for discussion when we discuss treatment options with patients in the upfront setting. Thank you.
Thank you, ma'am. It is nice presentation. One question from my side. Ma'am, in case of high risk, as CLL is a low-grade malignancy, in case of high risk like TP53 or unmuted IGHV, is there any need of maintenance during this definite treatment? Is there any rule of maintenance on
Yeah.
a single agent venetoclax or BTK inhibitor? Or how should we continue this maintenance?
The Venobin trial design is very simple. They look at the MRD, but there is no recommendation to continue treatment based on the MRD itself. But whether that is necessary, but in that, if you see clearly, the PFS is inferior when you compare P53 to non-P53. The current ongoing trials like MAGIC, CLL 17 are trying to precisely answer this question. And the study that I showed, a phase 2 study where they looked at the MRD at cycle 16, cycle 25 to decide whether you continue treatment. So I think the takeaway would be that, in my opinion, you look at MRD, if they're MRD positive, then their PFS is likely going to drop very quickly, and we should be having a discussion. There are no recommendations on whether you continue them or not, but I think it's still up for a question to be answered. I think anybody else can also contribute to this.
Any more question?
Thank you.
Thank you so much.
Thank you so much, Dr. Anusha.
Thanks, Anusha.
Thank you, Chairperson.
Thank you.
We now begin a power-packed AML panel discussion, and for that, I would request Dr. Tulika Seth to moderate the discussion. Ma'am is a professor in hematology at AIIMS Delhi. Please welcome her.
So, thank you very much. This is a really wonderful group of people getting together to discuss some of the latest and newest treatments that we have to best help our patients. And we have an eminent panel who is here to help us discuss the case-based role of in relapse refractory FLT3 AML. And we have none other than Dr. Biju George, who is here from CMC Vellore. Please, sir, please join the panel. We have Dr. Rayaz Ahmed, who again needs no introduction in this audience. Dr. Vipul Seth, please join us. And Dr. Pradeep Kumar, my dear colleague, and request all of you to take your place on the stage so that we can start this really important panel discussion. My slides, please. Slides. I sent them in the morning. मैंने दोनों को भेजा था. Is this it, the last one? Word तो नहीं होना चाहिए. Can we have some technical person to help us? Yeah. So while we're waiting for the slides, the case that we, is this it? Sorry, the slides are not moving. But they're doing it from there? Okay. So do I just say next? What do I do? Okay. So while they're putting up the case, so that we don't waste too much time, we have a very typical case of a 47-year-old with no comorbidities. He has fever, easy fatigability for about a week. He goes to the hospital where he's found to have a hemoglobin of about 11 and a white blood count of 58,000 and a lower platelet count. And that triggers the investigation. He gets a bone marrow test and a flow cytometry. And he's discovered that he has AML with with monocytic differentiation. This patient was then had all the other workup done, and he chose to go for azacitidine and venetoclax. Of course, that is a contentious topic, but he got 6 cycles of this and he did well. And he was on this treatment. And about 6 months into his treatment, he started to have a high white count as he was being monitored. And a flow cytometry was done to show that again he's now relapsed. And so, do we have the slides, please? Okay, so we don't have the slides yet. So now a bone marrow is done and he's evaluated, and he at this point of time when he's investigated, he's found to be FLT3 positive. Now, I really wish we had the slides. Okay. Okay. So, how frequently do you see patients who are maybe not FLT3 positive at diagnosis, but FLT3 positive on relapse? And is this something that we are missing? Are we missing these FLT3s at the diagnosis and they're just showing up at relapse, or is this a different thing? What's your perspective? Dr. Biju, you can start.
So I think, like I presented, the data is that about 10 to 20% of people at the time of relapse become FLT3 positive who were negative earlier. And so it's important for us to make sure that we check FLT3 post-transplant. So I've got a lady who is a physician, AML, who had a transplant, post-mud transplant. She's relapsed. She was FLT3 negative earlier, but now she's FLT3 TKD positive. So we do see that.
My apologies. There's some mix up with the slides, but we're working on that. So some of the concepts that we know that we have to do the FLT3, and we know that there's ITT and TKD. What are the methodologies that you use at your center for FLT3 estimation? Dr. Reyes, do you want to comment?
Initially, PCR based, but nowadays it's mostly the NGS. And initially we used to do the PCR based. Now it's mostly the NGS which is being done.
Okay. Anything different? Dr. Vipul, how are you doing? Same.
I don't know. We use NGS here in India, but I'll just say that in the West, we used to always do FLT3 separately just because NGS can pick up to 400 kilo base. I mean, it's a commonest type of insertion. Sometimes you can get high insertions and it's not picked up. Then we used to do Sanger sequencing to not miss those cases, but it's very rare. It's like 2%.
Okay. Dr. Pradeep, anything different that you'd like to comment?
Right now, we are using NGS for FLT3. Yes.
Okay. So some of the key concepts, I think everyone is well aware that there's a clonal evolution, and wherever newly detectable mutations of FLT3 ITD can appear on relapse, even if they were not originally there at diagnosis. And most of the cases with FLT3 ITD at diagnosis will be retained on relapse, and sometimes even a higher allelic burden than at diagnosis. And we do see patients who, of both types. So, what are the FLT3 kinetics? There's now a reclassification of FLT3 ITD. So, anybody want to comment on what do you think about the factors leading to the reclassification of FLT3 mutated AML as a intermediate risk AML? Would you concur with that, or how do you feel about that?
I think if you look at most of the data which is there in ELN, a lot of these mutations which were considered poor risk earlier are all going up in the risk ladder because of the availability of drugs that target them. So that is where things are becoming better. Earlier, there used to be this question of high allele ratio more than 0.5. Now that's been taken off, and it's just a question of whether it's present. But I think it's the presence of inhibitors and the results that you're getting with these inhibitors, which is helping them to become intermediate risk or good risk as compared to which were described as very poor risk earlier.
Any comments on the reclassification? How do you feel?
So, as said, initially for us, FLT3 still remains the poor prognostic markers, but with midostaurin coming in, now gilteritinib is there, or sorafenib initially. With this, we are able to increase the PFS, but OS, I don't think so. And even when this our this FLT3 is inhibitors, we have it. What we need in a country like us is when we can say the patient has been curative rather than increasing the you can say PFS by giving chemotherapies or maintenance over a period of time. If you have a curative approach, that is more applicable rather than we don't have options of re-induction. The finances come into play, infections come into play. So for us, again, if FLT3 is there, still it's a poor prognostic marker, even though it's not being in the intermediate with the with the help of this inhibitors.
Right. So again, and Dr. Biju is correct. It is the intermediate group, and that is the way that it is classified. But I think in India, because of our access problems many times and other issues, for us it's still a dilemma. And at AIMS, midostaurin maintenance and other things like or even midostaurin upfront sometimes is quite a challenge. So for us, I think I would say it's somewhere in between, but we still can't really relax on this. And we know that as all the speakers have already said, we have great inhibitors, and we have the increasing role of MRD, so we can target these patients well and identify the patients who need additional therapy. So one of the newer drugs that we now have in our armamentarium is gilteritinib, and we know that the overall response rates were very good, 55% for FLT3 ITD patients, and even 17% for patients who have other mutants. And the majority of patients do have both of these mutations. So while gilteritinib was being developed, there were several lessons that were learned. So one was that the inhibition of FLT3 needs to be very deep and complete, and it should be sustained for days, not just hours. So you need something that is going to be able to do this. We need inhibition of c-KIT, and unfortunately, of course, that results in myelosuppression. Because KIT and FLT3 are structurally similar. Another lesson learned was that FLT3 ITD evolves from diagnosis to relapse. So the leukemic cells that are dependent on FLT3 ITD signaling for survival, they might be small upfront, and often these clones will become much larger at the time of relapse. And fortunately, monotherapy works at relapse, so that was a very important thing. And another lesson was that the FLT3 TKD mutations conferred resistance to type 2 FLT3 inhibitors like quizartinib, which we have not been using. And FLT3 inhibitors act by a combination of both apoptosis and terminal myeloid differentiation. And so these are some of the things that were learned. So some of the questions in terms of efficacy when you are managing patients with FLT3 positive AML, what are your endpoints that you're looking at? Because there has been a lot of debates in the research community about what are the surrogate markers and what are the endpoints that we should be using in leukemia studies.
I think it depends upon the age that you're looking at. So if you're looking at anybody below the age of 65, I think we are looking at cure. So definitely progression CR leading on to good progression-free survival, and OS is what you're looking at. But when you go above the age of 65, where we are looking at trying to get the disease under control for a period of time, then I think PFS is important rather than the OS. And I think most important would be all the surrogate markers in terms of quality of life index, which are more important for that group of patients.
And Dr. Vipul, I thought you wanted to make a comment.
Think I just agree with sir. I'll just say that for trials, in order to go faster, they take MRD negative as a good endpoint now because MRD negative corresponds to good outcome. So you can just bring in the drug faster.
Okay. So, did I miss a slide? No. So when you have a patient who has relapsed, when do you start therapy? Dr. Pradeep, do you want to comment? So you have a patient, he's now relapsed. You know he's FLT3 positive. What do you do? Or you think he might be FLT3 positive. So you have a relapsed patient. You don't have all the information. When do you start therapy?
Ma'am, if we have no information about FLT3, then we have to restart our workup as a initial part. We have to reassess whether there is a development of any other resistance or any other clonal evaluations. So we should check such patient from since starting of the disease, NGS and other cytogenetics also. Because here where our goal is to improve the outcome and consolidate with transplant. So as much as we information with us, so we can go to the transplant and we can achieve the overall better outcome.
Okay. So now you have this relapse patient who is now FLT3 positive. How are you going to plan your initial therapy? Now, most of the patients who are FLT3 positive initially will have received a FLT3 inhibitor. It's going to be very unusual that somebody who is FLT3 positive at baseline will not. So how do you now decide how to manage these patients and what options do we have with us in India? Dr. Riaz, would you like to?
So what we have is currently is midostaurin, sorafenib, and the gilteritinib. So the question, I think, so the patient refractory to initial FLT3, we will be we have specific mutations available against which the FLT3 is which FLT3 is going to work. So that we should be again getting into our workup. And based on that, we can plan whether we have to use the broader spectrum. So in the gilteritinib also, we should know which mutation is going to work. So at the relapse, if you have, if the patient was initially not FLT3 positive, you must have the workup and get the FLT3 checked. So because if you are going to, relapse case is a bad case. So we single agent gilteritinib also makes a very good response even without chemotherapy. So once we have the drug available with us and we know the results are good, so that should be the part of workup.
And if the patient has relapsed post-transplant, does that kind of change how you're going to approach? Anyone can.
Yeah. So the patient who has been transplanted and has been on FLT3 inhibitors and it has relapsed even on FLT3 inhibitors, then again we should check the which if he has developed any mutation which is FLT3 inhibitor is which can work. So that should be taken in account. Otherwise, we know if the FLT3 positive patients post transplant and has relapsed on maintenance. If the patient was not on FLT3 inhibitors maintenance, then it's become easy. Then you can restart it. But those who have relapsed on FLT3 inhibitors, getting a specific point mutation, it will be important to see.
If patients had received sorafenib versus midostaurin, anything different in your experience?
Sorafenib, we have not
used that many patients are on that, unfortunately.
So generally we have been using of midostaurin, but yes, the difference will be there. The outcomes are little the type of inhibitions are different for midostaurin as compared to sorafenib, and the toxicity profile is different.
And yes.
So I think there's one French study which looked at the use of gilteritinib after being exposed to midostaurin and still showed that roughly about 40 to 50% will respond to gilteritinib after prior exposure to midostaurin. So you still have a drug where though you've had serious FLT3 exposure, you still may show response. Now the question about post-transplant, I think it also depends upon when post-transplant the relapse occurs. Because if it occurs in the first 6 months where the engraftment status is a bit crumbly, then probably you're better off using a single drug. But if it is say 1-2 years post, then because by then the engraftment would have been more robust, you probably can even consider FLT3 inhibitor plus another drug rather than a FLT3 inhibitor alone.
So, have you used it with venetoclax, or do you have, or are you into triplets? I mean, triplets it sounds very harsh, actually. Any experience with venetoclax and gilteritinib or AZA with gilteritinib in the
So the
relapse?
only one patient that I've used, this is with gilteritinib alone.
Alone.
I've not used it in combination.
Dr. Riaz, Dr.
Only
Vipul.
single agent we have not been able to use.
Okay. So a few of the experts that we met abroad, I think triplet sounds a little difficult even in the West. So maybe single agent if you can get away with it. So we had a little bit of discussion on this. So are we able to test for these clones that are have these mutations after midostaurin or sorafenib use? So I'm not sure if we're able to do the testing for this. Are you doing these tests? Are they available?
Yeah, these are available with the NGS. We can get this mutation.
So this
test.
information is available. Okay, fantastic. So the other thing that we are able to see is that with longer use of gilteritinib, we're able to get a much deeper response, which is obvious. And we know that it's clinically active in relapsed and refractory patients. So again, this is something well known. We have seen these studies. And okay, so up till now, if you have, prior to having this agent, what was your go-to standard in FLT3 positive relapse patients before we had gilteritinib?
So, relapse refractory FLT3 positive prior to gilteritinib. Yeah, we would have added, if not when exposed, so we would go with Izaven and add the FLT3 inhibitor. If younger age, maybe chemotherapy with some FLT3 inhibitor. That was the way to go. But post gilteritinib, it has changed.
Okay. And now that you have the many more agents, are you seeing better responses? I mean, they've given some numbers here, but that's okay. I mean, are you satisfied, or do you think we still need more agents?
I think compared to the era where we were using chemotherapy alone, where only about 20-30% would get into remission, and in Indian context, many would die because of infections. Definitely, with the use of these inhibitors, the percentage has gone up to probably around 50, where we can get a reasonable remission.
So if you have, for example, a young patient who's already relapsed, maybe had midostaurin and other things up front, then he's relapsed, you've used gilteritinib, would you want to continue them on gilteritinib, or would you want to then take them for a second transplant? I mean, where do we go? Because, these are difficult cases.
So this was easy. I will take this. So it won't long last. The responses doesn't last more than 3 to 6 months. So the moment you get into the remission, we have to take you for the second transplant.
Okay, good. So just for everyone to know that this is a great bridge to transplant. So that was the second answer. And now that they have relapsed, and you have taken them for the second transplant, or again post-transplant maintenance.
Yes, definitely we have to give some sort of maintenance map.
And what doses are you using, and is it a fixed dose, or are you just monitoring them and looking at, how do you manage these patients post-transplant maintenance?
So we are monitoring this patient. Generally, we start with a low, especially when there are a lot of when the calcium inhibitors are there, when the azoles are there. So that time we are starting 40 initially. then we are going up to the full 80 milligram, and we are giving it to 1 year. Till now, we are 1 year of. We have planning to give up to 1 year of post-transplant.
So you're able to, if they're doing well, are you able to dose reduce, because that would be very cost saving also?
Yeah, it's a little tough for the patient to go for this. So till now, we are able to do a few patients, but yes.
Okay, excellent. Okay. And so, and of course, you do have to be a little bit careful about GVHD. So that's for the students, and usually the median dose of initiation is usually about 55 days, looking at that. And this is from some studies where they looked at intention to treat for patients, and a lot of these patients were able to go on to get transplanted and or be on maintenance with gilteritinib. So we have several options for patients who are transplant eligible and those who are also not eligible. And you can see this, that quite a few patients remained alive for more than 2 years without relapse, and about half of them went for transplant and the rest were on maintenance. So we, as I said, we have many more options, and this is from the ADMIRAL study that everyone is well aware of. And yeah, so this is that. And now an issue that we always have in our country is treatment adherence. But if patients are doing their adherence, then you can see that they have a excellent result. And this is from a poster that was there, and this was a cohort that they followed, and they showed that over time there was an even improvement in cost. And this is from their insurance database, to show that patients who had different regimens, you can see that the patients who got gilteritinib had a much better treatment adherence and were able to complete longer duration of their therapy. So are there any safety challenges? Because I think with every drug we must be cautious. And so where are the drug interactions, if any, that you have noticed, and where should we be cautious?
So QTC monitoring is the important, especially with the azoles and transaminitis. So these two things I will look into picture. QTC prolongation.
And have these? Have you seen any grade 3, grade 4 toxicities related to QTC or liver dysfunction?
Means the post-transplant, generally this transaminitis and there are many drugs which can cause. So it's important that you should be not be breaking the any medicines which needs all medicines have their own role to play post-transplant. So monitoring of these symptoms, sign and symptoms, you have to be very particular. So I have not seen any QTC prolongation, but yes, we do check if the patient has previous history of any.
Yeah. So I think it's important that everybody who's using it, because obviously we'll have few patients who can afford. I think we should share if there are any drug interactions or anything, because again, our experience is quite limited, and as yet we haven't seen any problems. But again, it's important to note, because some of our patients might be on antitubercular medicines, or other medicines that may not be so common in the West. So again, if we find something, it's important to share. So response to gilteritinib, everybody knows. FLT3 has a role in early hematopoiesis. It does inhibit the wild type FLT3 a little bit, so it doesn't have too much myelosuppression, but there is myelosuppression that does occur, especially in the first few months. And it's more if people have had cytoreductive therapy prior to starting the gilteritinib. And we do need to take care, because the neutrophil recovery might take 3 to 8 weeks, which in our Indian scenario can be quite serious, because patients can get infections, and the neutropenia can occur earlier if the gilteritinib has the differentiation action on the major clone. And these are some of the treatment emergent adverse events that have been reported. Most of them are fairly mild, except for, as was rightly said, the liver dysfunction, the QT prolongation, and some of the neutropenia. And if you, so this is again a tornado plot looking at the same. There are some unusual things like pericardial effusion, pulmonary edema, and other things that are there. So I think it's important to make sure we are monitoring these patients to see for these problems. Now, many patients, especially the elderly, frail patients who are not transplant candidates, you may see, again, as we were talking in the morning, that even azaven is basically palliative. So, if you're using a single agent gilteritinib and the patient, the leukemia doesn't go away, but the transfusion independence improves, how satisfied are you going to be?
I think for patients who are transplant ineligible, they would like to stay out of hospital as much as possible. So coming in recurrently for transfusions is going to be a burden. So if they become transfusion independent, although their counts have not fully recovered, definitely it would lead to more compliance with continuing therapy.
Agreed. And what we've often seen in elderly patients on azaven, many times the transfusion independence doesn't happen. You still need to have them come in frequently for transfusion. So this is something that again is a good thing for these agents. And a lot of the patients maintain their transfusion independence, and some of them also who were unfortunately on transfusions were able to become transfusion independent, and so that's something that is really good, and that's an advantage. Okay, and then so does gilteritinib alone seem enough for your patients with FLT3? I think we've already talked about the age part, but maybe let's just kind of final thoughts and comments on who do you think would be the right candidate for gilteritinib alone, and is there any patient profile that maybe you have any preferences for using it or using it in some particular combination?
So I would say a young patient who's got high burden of disease, you would probably consider giving gilteritinib plus. Now that plus can be either azaven or something, or intensive chemo also. But definitely I would consider combination if there is high burden of disease and if that patient is in a position to tolerate. Otherwise, I think single agent may be enough.
Okay. Any patient population that you wouldn't want to use gilteritinib? Anybody?
Cardiac patient we have to consider.
Okay, that's an interesting.
As we are QT prolongation is one of side effects, so we should avoid, or we should
we should get a cardiology evaluation. Absolutely. I think it's good to be cautious, right? Because we often get blamed for things. So I think that's good. So it's good to, I think, look at the counterpoints and think of the worst case scenarios and complications. Good. So I think that comes to the end of our discussion. And so any last comments on what is your wish list for other FLT3 inhibitors? Are we there yet with all the FLT3 that we need, or we need anything else? Because there are several others that are not available in India. So, I mean, again, I have no experience with the other agents, but they obviously must be there for some reason.
So first is the cost. The cost should be very less.
So I think wish list, that is always our
wish list. And we do need, because one drug will not cover everything. It's not that gilteritinib is the drug for FLT3. All FLT3 will be covered. So we have one. So any FLT3 agent which can cover all the mutations and less toxicity profile is more. The time to other is the time of response also matter, because it does take you have to continue for at least 2 to 3 months before you see the response coming in. So if we have a FLT3 inhibitor which is less costly, covers all mutation and early response, that would be an ideal FLT3 inhibitor.
And we haven't used this for a long time, but I think in our experience, we always know, even if we're using a good agent, there will be patients who will relapse to that. And then what do you do beyond that? Right. So any last comments from all of you? Yeah.
So I think what Dinesh had mentioned in the beginning, for most of the Indian patients, whatever we do first is probably the best chance they have at cure. So ideally, when we are talking about FLT3 inhibitors also, we should have a drug which we can combine with others with good deep remission with lesser side effects.
So do you think guilt should come up front?
I mean,
It's not proved as yet, but
yes, definitely, because at least in the combinations, the side effect seems to be lower. So but I think finally, like what Riaz said, it's all a matter of cost, but we have to try and position them early because that is where we are likely to get better outcomes in the long term.
Okay. Any comments, Dr. Pradeep, Dr. Vipul, before we wind up?
I just ask one question to sir. Is there any particular cutoff of RAF that you would not use it to, like if it's less than 1%? There are some patients which come to 0.5%. So what's the minimum? Or any
We would keep a cutoff of 2%, above which we would consider it as significant enough to this thing. Below that, I don't know. We usually ask our lab colleagues whether they think it's significant enough. Above 2, definitely it is. But below that, we would consult with our lab colleagues and then make a call on whether we consider it significant enough for us to treat.
by definition to be chip in, like tree is a chip.
Dr. Pradeep, any last comments?
As post-transplant FLT3 evolutions is much more problematic. So we should have a good molecule, as Dr. Riaz says, early response, deeper response, and low cost also. So this should be the best molecule for us, at least for Indian population, which have a limited finances. So that should be.
Yeah. So excellent. So any comments from the audience? Any questions? Because you have an eminent panel that you can ask. Well, I think you've addressed everybody's problems. Thank you so much. A big round of applause for our panel. Thank you.
Thank you, ma'am. Thank you, all the panelists. We now proceed with lunch, and we shall resume at 2 p.m.
start. And I will invite the chairperson and the moderators for the debate who will douse the fire, which is if ignited, Dr. Biju George and Dr. Rohit Mangal on stage, please.
So the idea of these debates is that the topic which has been picked up is, does the MRC young fit patient requires that same 7+3 as Dr. Dinesh has been talking about, or we can just get away with a lighter as a when and save money for the transplant, because we know that we are going to get transplant done. So is that the future? Because we strongly believe that faster testing, faster genomics will make way into the country, and by next 26, 27, entire country will move on to 3-day genomics. So I think Dr. Dinesh has set the ball rolling into our thing. We know what is happening, and we have to generate that data that this similar thing, young fit AML with MRC, the choice of induction. And India does have a lot of MRCs. Believe me, the moment we start seeing, we are different than the West. Just to tell you, Dr. Srinidhi will tell their own data of 821. We are how different we are from that.
As till Dr. Biju joins us, so we actually studied 160 patient data of core binding factor leukemia, and we found the co-mutation landscape to be very different from the TCGA database. And till Dr. Biju joins us, I'll introduce our proposition and opposition for the debate. Proposition talking in favor of intensive chemotherapy is Dr. Sanjeev Sharma, who needs no introduction. He's an eminent senior hematologist from BRK Max, and fighting against him in the opposition for less intensive chemotherapy is Dr. Nitin Gupta, who is again somebody who needs no introduction from Sir Gangaram Hospital. We have Dr. Biju George now on stage. Sir, if there are firecrackers, then you will have to douse it. So we'll start with the proposition. Dr. Sanjeev Sharma, please go ahead. So,
Hello, good afternoon, everyone. Yeah. Yeah, pointer. 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 Yes. Okay. Yeah. So I first want to thank Dr. Rahul and team for inviting me for this HEMENEXT conference. And so my topic of discussion today, we are going to have a debate on young fit AML with myelodysplasia related changes, choice of induction. So I will be going to talk in favor of it, and I have highlighted few things which we should know: young and fit. So young and fit will be young and fit only. What is WHO classification and criteria for diagnosis? Just a brief review before going into the details. Myelodysplasia related criteria according to WHO is more than 20 AML with myelodysplasia rate more than 20% blast, as we all know. History of MDS or MDS MPN, and one or more cytogenetic or molecular abnormalities in this table. So we can see that most of the complex karyotypes, whatever we face and we see, and whatever somatic mutations which are difficult to treat type of abnormalities, those are encountered in myelodysplasia related AML. So it's to what I mean to say is that it is a difficult to treat disease, and we need to have a strong treatment options or a as a regime which can wipe out this leukemic clone. So AML MR generally has a poor prognosis. We all know that, with a lower rate of complete remissions than in other type of AML subtypes. TP53 is frequently mutated in AML, myelodysplasia related, and strongly associated with a complex karyotype. So we should know the pathophysiology, that it is a bad disease, and we have to fight this bad with poor cytogenetics and molecular markers associated with this. So what we need a strong person who can deal with such bad genetics and disease. What all options we have? When we come to intensive treatment, we have been using 3+7 for last many years. Other combinations which have been used are FLAG-IDA, FLAG-BEN, high-dose Araci with mitoxantrone, and one of the molecules which I will be going to discuss and is literature most commonly cited and used is CPX351. And some other options are also being used. Since 1973, the standard intensive chemotherapy 7+3 for the patients with acute myeloid leukemia has been based on cytosine arabinoside in combination with anthracyclines. And we all know that this is the backbone of treatment even today. Clinical results of intensive therapy improved with consolidation treatments using high dose and intermediate dose Araci along with allogenic transplant in first complete remission. So this has been the treatment for high-risk diseases or diseases associated with poor cytogenetic and molecular markers, and that includes myelodysplasia-related AML as well. Then came the comparison of 3+7, which we have been using with CPX351, and this is one of the famous articles by Lancet Jeffrey in JCO, which paved way for using CPX351 or Vixos compared to 3+7, which showed better remission rates, better CR rates, event-free survival, and overall survival rates. And after this Vixos or CPX351 became the treatment of choice for AML with myelodysplasia related changes. So I will be leaving 3+7 back, and now I will be discussing mostly on CPX351, which is the most commonly used intensive treatment for myelodysplasia related AML. One treatment which I showed you 3+7 was compared with Vixos, and now another FLAG-IDA was compared with CPX351, and here also overall survival and relapse-free survival was in favor of CPX351 compared to FLAG-IDA in younger adults, and it was a randomized trial, though it has only been published in abstract form, but its final full version will be coming in probably next year. So this is a randomized comparison again. The initial one where 3+7 was compared with Vixos was also a randomized study. So in this randomized study also, CPX351 was found better than FLAG-IDA. So among the intensive chemotherapies also, this CPX351 has fared better. So now coming to the real world data of CPX351, why this is being preferred? Other than its intensive treatment part in controlling leukemia, it has been found to have a protection against intestinal dysbiosis and fungal colonization, which is one of our concerns when we use 3+7 or any high dose intensive chemotherapy. The risk of infections increase. But with CPX351, the risk of infections were lower because of these postulated and proven studies where it was found to be intestinal and cardioprotective. So this gave an edge of 356 other than its intensity, its safety as well. This was a long-term data of CPX351 in high-risk patients. And here also, this study was conducted in 168 patients in France and Italy, where young adults were taken. And here, CPX induced MRD activity, which contributed to improvement in overall survival. The improved overall survival with CPX351 was confirmed in this real life setting and was found better than any other available treatment. Another real world data from Germany, which also showed that the patients who received CPX351, they achieved a better CR rate, and the analysis with expanded follow-up shows CPX351 as an effective treatment for high-risk AML, facilitating LOSCT for majority of the patients. In another study from US, MD Anderson, USA, where outcomes of AML with myelodysplasia-related changes in young patients less than 60 years were who were treated with a cohort of 468 patients, and they found that AML without MRC had the survival equivalent to AML MRC, meaning that they had similar outcomes as in intermediate risk AML by European Leukemia Network criteria. So intensive chemotherapy was associated with improved overall survival and improved event-free survival in this cohort of patients. This is a 2023 publication of improving long-term outcome of with intensive chemotherapy. Here also we can see that patients with AML myelodysplasia related, the treatment of choice still is CPX 351 followed by allo transplant. And in young patients, they are not discussing about azavan or any other alternative. This latest publication of August 2025, where fit and unfit patients were treated. Here also for patients with therapy-related AML and AML with myelodysplasia-related changes, CPX 351 is our standard induction approach according to them. And for unfit patients, they use hypomethylating agents plus venetoclax. Another article publication by Cantarjan has also shown that for patients with AML for myelodysplasia, still the drug approved by FDA is CPX 351 only, whereas venetoclax is only for low dose or elderly patients or those who cannot tolerate intensive chemotherapy. So, just going a bit into the consolidation part, how many of you we would do transplant players all? So, it's not only about induction, but after achieving induction, you have to consolidate also with an intensive treatment. And all of us know that transplant is an intensive treatment. So, you have to intensively treat the patient because they have high risk of relapse because of that. So, LOHCT is advised in all patients, and LOHCT is a great equalizer which for patients with AML myelodysplasia related changes and has shown to have to potentially offset the poor prognostic factors associated with the aggressive disease of biology of this disease. And this shows the various developments which took place in the treatment of AML, and we can see that in 2017 CPX 351 was approved for AML with MDS-related dysplasia, and since last year or till that, no other treatment has been approved for AML with MRC. So we don't have any other treatment as of now for this AML with myelodysplasia related thing. Lastly, going through the NCCN, it also suggests for induction for AML MRC patient CPX 351 or 7+3. Since we don't have CPX 351 in India, standard 7+3, these two are the intensive and preferred treatment for AML with myelodysplasia related changes. Not only for induction, for reinduction and consolidation, CPX 351 is intensive treatment is recommended. There are no randomized trials which have proven benefit of low intensity treatment over intensive treatment for patients with AML MRC in young fit patients. So to cut an iron, you need an iron. Thank you. Yes.
Okay, to counteract looking at low intensive therapy, what we'll do is at the end of the second talk, we'll give a chance for rebuttal and then questions from the audience, and then we will have a vote at the end to see who's convinced the audience more about what should be used. Over to you.
So thank you, sir, and thank you first of all. Thank you, Dr. Rahul and his team, for giving me this opportunity and to talk about azacitidine and venetoclax as a treatment option in AML. So I'm a firm believer in azacitidine and venetoclax. So it was good for me that he gave me this option, and if he would have given me the other side, so it would have been very difficult for me. Anyway, so as we speak, so because data is emerging, it is a continuous learning process. So the new and newer data is coming, and I would acknowledge Dr. Burani. So he told me about the latest emerging data from the coming ASH about the paradigm trial that I will discuss in the last. So let us start with the patient, 51-year-old male. He is fit otherwise, diagnosed with AML with the trilineage dysplasia. Cytogenetic is normal, AXXL1, RUNX1 positive. How do you treat? So as per Sanjeev, because we don't have Vixios available with us, so that patient will be treated with 7+3. We did the same. but he did not respond. So second was azacitidine venetoclax, responded very beautifully, achieved remission. Denied a transplant, so again remained well for around 12 months on azacitidine venetoclax, then relapsed. And that Sanjeev I already discussed. This is AML MRC. We need to see. It is not only dysplasia by morphology. It is what matters most nowadays is the molecular abnormalities and cytogenetic abnormalities. ELN 2022 risk stratification. So these patients will be more or less qualify for adverse risk ELN category. That means all of them will be eligible for a allogenic transplant in consolidation if they are fit enough. So core problem that has been already discussed. These patients are elderly. They have they account for almost 50% cases of AML nowadays with the latest definition. More or less they are inherently adverse risk biology. They have lower complete remission rate and with conventional chemotherapies, and the transplant is the only curative option. So we need to do transplant as early as possible in a safest possible way. Options that has been already discussed. I will be discussing about venetoclax and azacitidine. Venetoclax, we know it is a BCL2 inhibitor, and it is have become a standard of care in acute myeloid leukemia patients, especially elderly patient. But the data is emerging in the younger fit patient as well. So this is the Wiley A study, azacitidine venetoclax versus azacitidine alone. It showed a survival benefit 14.7 months in azaven group compared to 9 months in azacitidine. If we although the cross trial comparison is not good, but we can see if we compare to the CPX 351, the CR rate is far better in Wiley A study in the 66% versus 47%. Although early mortality remains same, but in our clinical practice, we hardly see any problem with azacitidine and venetoclax. So these are the real world studies. One is from Japan. Again, a very uniformly homogeneous group of patients uniformly treated. They also confirmed the finding of Wiley studies with almost 70% responses, and almost 10% of these elderly patients with a median age of 77 years going for a transplant. Similarly, from the other studies from UK, the NHS, and a large number of patients, the same story is repeated. 70% complete remission rates in these elderly patients. Median age is 73 years, and almost 6% of these patients underwent a transplant. And if we see the subset analysis of these studies, there are almost 30-40% patients undergoing transplants. So it looks like azacitidine and venetoclax is sending more patients to the transplant compared to the intensive chemotherapy. Why it happens? Because azaven is effective early. It takes almost one cycle for a complete remission. Toxicity is low compared to the 7+3 and CPX. So CPX 351 is theoretically very good, but it requires a lot of time for a granulocyte recovery and platelet recovery. Early mortality, azaven 5 to 7%, but I don't agree with that. 7+3, we see a lot of mortality. CPX never used, but again, data says 7% mortality. So the first the goal is to send our patient to allogenic transplant. So let us see who is better in sending the patient for a transplant azaven compared to the intensive chemotherapy. So more patients in real world and registry studies are sent for a transplant compared to 7+3 type of intensive chemotherapy. Because in 7+3 there are early induction failures are there, and there are longer duration of neutropenias, infectious complications. So many of patients who are destined for a transplant, they actually never received a transplant. TP53, we know with 7+3 doesn't work. CPX 351 is marginally better than 7+3, but still it is inferior to the azacitidine venetoclax. Again, we need to keep in mind that even 7+ azacitidine venetoclax is giving a very short-lived remission in these patients with TP53 positivity, usually of around 5 months. And this is very important to our patient toxicity and quality of life. It is far better in patients who receive azacitidine venetoclax compared to the other intensive chemotherapy. So there is no comparison between the two parameters here. So last part is the transplant outcome after azacitidine venetoclax. So if somebody can say, oh, you are sending a patient for a transplant, maybe they are not getting that much of a MRD negativity and their post-transplant relapses may be higher. So there are retrospective data, of course, and they have they did this propensity matching analysis, which suggests that there is no difference. There is no difference in the post-transplant survival of these patients, whether they are achieved remission by 7+3 or whether they achieved remission with azacitidine venetoclax. So again, the same story here. This the earlier study was from I think this was a US study, and this is the from China. So again, the same transplant outcome remains same if you are able to take your patient for a transplant. It doesn't matter whether they received which therapy as an induction therapy. So the key point from this my presentation is that for AML MRC, the goal is the rapid remission with minimal toxicity and fast transition to the transplant. And azacitidine venetoclax delivers this with the highest remission rates, lowest early mortality, and the best outcome in complex karyotype and TP53 mutated patients. And it has a superior ability to get the patient to the transplant. And more or less, and again with the least toxicity and with a comparable or a better survival than the 7+3 or CPX 351. But this data which I have discussed, it all comes from the retrospect, the patients who were elderly and infirm. So the median age we saw, it was only maybe above 70 years in most of the azacitidine venetoclax studies. We need to have studies with the younger patient. So then we can also, they will be we will be more sure about the efficacy of azacitidine venetoclax in younger population who are fit for a transplant. So of course we need a randomized control data, and the good thing is that the paradigm trial, which will be published, which will be presented in the coming ASH meeting in December this year. So that is a 1:1 comparison of azacitidine venetoclax comparing with the intensive chemotherapy 7+3 and CPX 351 in younger fit patients. So that will it is a randomized control trial, so with the highest level of evidence. So that will put this debate to the end for sure. So the abstract result shows response rate in azacitidine venetoclax 88% compared to 62% in intensive chemotherapy. TRM 0% versus 4.7% in intensive chemotherapy. 52% patient went for a transplant in azacitidine venetoclax compared to only 34%. So that is a trial of result of a upcoming ASH plenary paper presentation with the which is a randomized phase 2 trial. So I think that proves my point, and that we should be going away from 7+3 and Vixios, and probably we are doing the right thing already. We're giving azacitidine venetoclax as much as possible. Thank you.
Dr. Nitin, please remain on stage. Dr. Sanjeev, please come. So you will get 1 minute if you want to counter anything which Nitin said.
It's started from first slide, and there was no evidence with Dr. Nitin. He discussed only about elderly patients and azavan in elderly. Everyone knows azavan is used with the elderly. There is no data, no randomized trial of adjuvant in young adults. The topic was young fit, and all his whatever studies he showed all were elderly, more than 70, 77 year old. So I don't think he debated with me on that topic. So ideally, this was out of question that he was discussing what I had needed to discuss. So I think there is no role of adjuvant as of now till we have proofs, and we were talking about proof here. As of now, there is no proof, so discussing just fantasies doesn't make sense.
Okay, we'll give a minute to Nitin to counter that if you have anything to say.
So there is nothing left to counter, sir. There is a randomized control trial, which is which will be about to come in this ASH plenary paper. So that will again that is saying that you can access the result on the web, on the ASH website. So that is putting this debate to the rest for sure.
Okay.
So there is no comparison between adjuvant versus intensive chemotherapy. Days are gone.
In elderly.
In young, it is young.
Okay, we will have questions from the audience. Anybody? Okay, Dr. Dinesh. Before we start, so let me ask a question. You talked mainly about CPX341, but is that available in India? Do you use it? So again, there the question would be, what we would use a standard 7+3. So if we use standard 7+3, what would be our remission rates and MRD negativity that we can get with that? What would be?
So that's actually because there are many genetic mutations associated with MRC. That's why it makes it a high risk disease. So expected CR rates will be lesser, but as we have for other FLT3 positive or now, but we have treatment for that, but we don't have any treatment for TP53 as such. Though adjuvant has shown some evidence of benefit, but that too in elderly population.
So let me ask Nitin, in the elderly population, what are the CR rates, and importantly, do we know what are the MRD negativity rates that are there in the studies in MRC? Is there any data available?
Sir, I am not aware of the MRD negativity rates and what method they use for MRD negativity. But in some trials, my impression will be around 30 to 40% will get into MRD negative CR. Of course, remission rate is around 70% across the group.
Okay. Dr. Dinesh, can we give a mic there, please?
So, do you wait for your NGS report before you start the therapy in young patient, Nitin? Because to say it is MRC and you're going to use azaven, not the intensive therapy, are you waiting for the result to come and then?
So again, that depends upon the place of the disease. If you see the patient is blasting very fast, so you need to take action. So anyway, but
what's your practice? Do you wait for the result? The problem is not that what you use it. I think the problem is to get the. Are you waiting to get the result, or you are?
That is why we need as early as NGS or mutation reports if possible. So if somebody is giving 3 days or 4 days NGS, or at least I think we are getting in a 1 week time. Not nowadays, NGS results are available. Although we don't wait. So as you're right, if somebody is not aggressive disease or proliferative disease, we can wait, and we do wait. Normally, in my practice, I find the way not to give as intensive chemotherapy. I don't want to give anybody 7+3. I would try to give azaven as much as possible.
Okay. Dr. Ajay?
I like to question Dr. Sanjeev and side with Dr. Nitin. No, this debate was about MRC, AML with MRC. Now, MRC, myelodysplasia related changes, as such, is more common in elderly and older patients, not as much in very younger patients. And for that, it's a morphological diagnosis, and you have a history of previous therapy and all. So now in MRC, so would you, even if he's a relatively younger age group, maybe 40 years or so, would you still treat with 7-3 knowing that it is MRC, or you would choose 7-3?
Yes, so most likely if a young patient, I would treat with 7+3 followed by allogenic transplant. So
I said it is mostly in the middle or elderly age group, MRC.
Yeah.
It's very rare to have, extremely rare to have MRC in a younger age
like
group.
elderly person, then I will also go for azaven. But you have to see the performance status and whether he will be able to tolerate 3+7 or not.
I think we have to say it was defined as young.
Yeah. So
with the MRC AML.
If less than 60-65 years, then definitely Intensive treatment.
Any other questions? Last questions before we are going to have an audience poll to see who goes for what. You want to have any questions?
I just said, I mean, it makes sense to wait for some time to get the NGS results wherever there is a doubt of MRC, because there is a trial which said if you wait for week 10 days, it doesn't make a difference. So I would go with Nitin. I mean, say I would probably start with Azavan and maybe change to intensive if it doesn't turn out to be MRC.
I second your opinion. So because you can easily go back from azacitidine.
You can go back from Azavan, you can go to HIDAC, you can go to FLAG after Azavan, rather than subjecting him to extra morbidity and mortality.
Okay. Now, time for voting. How many would go for intensive chemotherapy? Just raise your hands. How many? So I would say you have a 35-year-old who's got AML MRC. How many would go for 7+3? We have 1, 2, 3, 4 hands, 5 here. How many would go for Azavan? So I think it's only, what happened to the rest? Nobody's voting. Okay, we have more people voting for Azavan. So, Sanjeev, I'm some more.
I just last question: if we have Vixos in our country, will still we be favoring Azavan? Because if we want to discuss data, then data is for Vixos.
So Sanjeev, the data is changing. Paradigm trial is showing that 50% of their AML MRC received Vixios. So 50% Vixios, 7+3.
I think some of it is also got to do with experience. I don't know what Dinesh's experience is, but for us, MRC, AML, when we have given 7+3, that cytopenia just goes on and on and on. It's not that in 25-30 days they actually recover. Yes. And then we end up having to transplant them in cytopenia with infections. Yes. So that is why we would say trying to get them into remission with less intensive is probably better. If you ask me, is it based upon full data? No, but that is based upon previous experience that we had. So let's give a big hand to both of them for the debates. Thank you.
So continuing at the same energy levels, I would now invite Dr. Riaz Ahmed to moderate the panel-based discussion.
So good afternoon, everyone. Continuing with the AML. Yep. So can we get the panelist on the board? So I'd like to call my panelists, Dr. Rahul Bhargav, Dr. Dinesh Burhani, Dr. Biju George, Dr. Tilika Seth, Dr. Pradeep Kumar, Dr. Brigadier Sanjeevan Sharma. No, it's not a debate, it's a panel discussion show. So I don't. So we have been talking about the holistic treatment of AML. We started from doing induction. So what I can say, a lot of still it is in India at least, doctor to doctor, institute to institute, it's differ. And even that, depending on the age, what categorization we can debate on, whether we have the NGS data, whether we have that rapidly proliferating blast, or what is the finances, what is your intent. So that induction, I think, is still debatable. Who is believing in which type of induction therapy? Ultimately, everyone wants that lesser the cost, less toxicity, more CR rate, and ultimately for the transplant, whether we are going to do it or not, and whether we are able to go for MRD negativity. A lot of Then came the consolidation. Life was easy before 2015 when we had induction followed by consolidation at least, and when adverse risks and intermediate risk when we were thinking of transplants. Things were over. Now came the maintenance. Again, what we were thinking in the early decade of this session, whether it's maintenance is going to help us in AML, or is it a concept which we should think about it as like in ALL, whether it is going to help us, whether it is going to increase the PFS, OS, with the plethora of lot of availability of newer drugs, you can say targeted drugs, and the post-transplant maintenance and the MRD is coming into play. Which drug to use, which targeted therapy to use in maintenance, for how long to use. I think so. This will like to understand from our panelists. And to start with, when before we had anything, did we use any kind of maintenance? Did we have that concept of maintenance, or it's a new thing? Any Sanjeevan can miss.
I think the DLI is also kind of a maintenance. So there has been a concept, because we knew that our AMLs, even after post transplants, were not doing well. And that's how the DLI concept and now the oral drug concept has become so fantastic and so well established that Modi says that from 60% the survival in France has jumped up to 80% by utilizing the maintenance in AML therapy.
So I think what Dr. Yaz was also asking, that earlier, firstly, that maintenance is also, we are shifting the goalpost as far as what is maintenance. I mean, is anything which is lower in intensity, less toxic, is that the maintenance, or is it a new therapy altogether? So I think that's also his first question, that what do we mean when we talk about maintenance therapy? To me, maintenance therapy is anything which can be given at a, firstly, you are talking of the post-transplant scenario, is
Yeah,
it?
post-transplant.
So post-transplant scenario, in my mind, would be a maintenance. Firstly, is a person requiring or he does not require maintenance? That as a transplanter, we need to first figure out. And if he does, at what time point? Should it be like day 60, 70, or maybe day 90 when he has fully engrafted, the graft has become stable, you would like to start at that time? And what intensity? So there'll be various variables. What was his risk status? What was his MRD level? What was his what was his age? How about did we give him a MAC, or all these things will come into play into deciding what's the maintenance.
So, Dr. Biju, you were doing in before all this
I
came.
think before maintenance came, we always knew that those who relapsed after a transplant had very poor outcomes. We wanted to reduce the risk of relapse. So it all depended upon, as a transplanter, where you are a believer in the graft versus leukemia effect or not. There are some who believe, some who don't. Those who believed in it, like me, we used to taper and stop immunosuppression early to try and induce GVHD. If it did not happen, then go ahead with donor lymphocyte infusion to try and induce GVHD. It worked in some, it did not work in some. Some continued to relapse despite all this. So the question is, what can we do in terms of trying to reduce the risk of relapse? One of the options is maintenance.
But Dr. Biju, doesn't it matter on the based on the genetics of a NGS of a patient, which decides which will be best? The DLI, it's like TP53. What cures TP53? Is it the ablation? Nothing. I mean, short of still 30-40% people survive. Is it the type of mutation? It is the MAC or a RIC, or the immunological aspect which is going to cure the TP53. While in FLT3, you might have a drug like gilteritinib, which you give pre-transplant, make the MRD negative, and then do the transplant. The outcomes have really become better in FLT3. In our setup also, if you take the patient up in the FLT3 negative MRD and do a transplant, the outcomes are much better.
10 years back, we never had all the stock because there was nothing available. Now that these are available, the question is where you employ them. With you, like you said, definitely getting a patient MRD negative before transplant is probably one of the best things that you can do in terms of reducing relapse. But you have the occasion to use these drugs if you have mutations which are agnostic to it.
So, in the era of this targeted therapy or low dose immunotherapy, do DLI still stand a chance?
I would do, because we need to remember, if you take say 100 patients with AML, you've got only about 30 to 40% of patients who will have a mutation where you can use. So when you're looking at either using FLT3 inhibitors or using IDH1 inhibitors, it's about 40%. The 60% who do not. People are looking at venetoclax maintenance. We still do not have that data. But we don't have the data. So that is. So no. So what I'm talking about, So what I'm talking about is a patient where if we think is a high risk for relapse, we would end up stopping our immunosuppression by day 90, wait for about a month or two, and then start prophylactic graded DLI.
Professor. So, but still, I think most of us, in fact, rather than prophylactic, we are going for a preemptive DLI. So, chimerism stops dropping, or the MRD starts,
That's that's the disease. So maintenance is where there is nothing.
Prophylactic. So ideally, in true sense, it is only prophylactic DLI when it was planned pre-transplant that we will start giving DLI. Say at day 90, first shot will go in. Day 120, the second shot will go in.
I think the mean of maintenance is some kind of a drug therapy for maintenance, probably.
Yes.
Like your sorafenib or gilteritinib or IDH inhibitor, even AZA or when.
These are the can be called as a maintenance.
Then you have to be prophylactic DLI,
prophylactic,
not
So maintenance in my mind is there's nothing. I mean, your chimerism is good. You do not have a GVHD which is happening, and still you think that this patient was a high risk to start with and has a propensity to relapse. To do something, he does not relapse. And the maintenance data across the world is now showing the bar has gone from 60% to 80% in centers, which is using maintenance as a standard line of therapy, which is based on a
what maintenance?
In FLT3 people
forget about the FLT3. Talk about
three drugs. Azacitidine, and other small molecules which they are utilizing as a part of a maintenance to induce GVL. So Dr. Biju has been doing the same thing in the DLI to induce a GVL so as to prevent induce a GVHD to have a GVL so as to prevent the relapse. And similarly, azacitidine, even in ALL, it does work well because it is playing in tinkering with the T lymphocytes and not doing anything on disease biology. It is like inducing the T cells to have a GVL and then have a disease control. Isn't that azacitidine?
We will move into the next. So DLI, I said I wanted to have a little understanding what we are doing, whether we are going to do DLI prophylactically in this era. So that's still debatable, we can say, especially if when azacitidine is available and for the targeted therapy when other drugs are available. So role of DLI can be for those patients, those who don't have any mutation available, and those who are at high risk and they don't have GVHD. I think so. Those are the group of patients where DLI can be given. Okay, so this is was the definition I could get. The US FDA defines maintenance as an extended but time limited course of treatment, usually relatively non-toxic, given after achievement of CR with an objective of reducing the risk of relapse. And also it draws a distinction between maintenance and continued therapy, that is an extended course of treatment after induction phase with an objective of controlling the AML disease burden while on therapy. It's a little bit controversial.
In the definitions about a clonal evil, because there are some which will evolve, make the disease evolve.
So I'll just say, so when we treat with azaven and the patient has achieved CR and continuing the patient on azaven, it is a continued therapy or a maintenance therapy?
So I think that is a continued therapy.
Post-transplant, there is
no. Just AML. We have given 6 cycles of azacitidine.
If you're giving azaven, is a continuation of therapy.
In a continuation form.
That's a maintenance therapy. That's not a
in an elderly AML where you are not doing a curative intent.
It depends upon what is protocol defined. So if you look at the original studies, it was you continue that till progression. So it's not considered maintenance. It's just considered.
So The other is oral azacitidine when it came for intermediate. And so, what do we take it as? It is a maintenance therapy or a continued therapy? Because it is approved as continued therapy, not as maintenance.
Maintenance. It came as the maintenance.
No, it is. I think so. It's a continued therapy, which I think.
So there are both. So there are studies where they have looked at oral as a maintenance after giving as a when. The studies have shown that may or may, again there is may or may not, because there was more toxicity, especially when they used the 300 milligrams. So the number of people who actually completed the 12 cycles of this thing was only about 20%. So then they said we are not able to actually evaluate because it just does not seem to be tolerated well.
Some of patient after a certain phase don't want to take injection and all. They used to ask, okay, हम ये नहीं चाहते, हमें क्या और दिया जा सकता? Some have started with this concept, and no doubt it was used as a continuation therapy after that maintenance.
So, we'll continue with this. Who should receive post-transplant maintenance therapy? As we were discussing, high risk of relapse if the risk of maintenance therapy outweighs the potential benefits, cytogenetic and molecular abnormalities, presence of pre and post-transplant MRD, active disease at the time of transplant, reduced intensity conditioning regimens, and the patient with significant post-transplant complications will also define what we are using at the time we are going through the transplant. And the potential pitfalls in the maintenance therapy we have, it is possible that many patients are cured after transplant and don't need maintenance to prevent relapse. So that group of patient needs to be defined. Over treatment can cause various problems that are side effects with long period of treatment, committing patients to indefinite treatment without endpoint, and financial toxicity. We are treating, whether we are treating ourselves or the patient, we should be keeping that in mind. So, before we go into the transplant, so what's the role of maintenance therapy for a patient who does not have bone marrow transplantation? And do we use it? And which medications do we use? Okay, so we can start from Pradeep.
We are using just azacitidine. We are we used to give till disease progression or some significant toxicity. This is also a type of maintenance as a continuation part. That does not have bone marrow transplant, and I think
Sanjeevan, you want to take?
Yeah, so I think it will depend on for a person who has not had a transplant. For me, again, it will divide what therapy he was given upfront. If he was say, there have been instances in our setup also, a borderline kind of a person, 58, 59, hovering around 60. 7-3 went MRD negative, took 3 that 1.5 grams cytarabine IDAX. We counseled for transplant. That the family doesn't want to go for a transplant. Now, whether would I like to put them on as a maintenance in an MRD negative? Probably not. But if the same person had taken a 7 when and gone into an MRD negativity, I would have gone in for a maintenance with azacitidine. So this we are talking of people who don't undergo the PMT.
PMT.
So, do we think that I'll give you a devil's advocate? Don't you think that with the advent of newer diagnostics, deeper diagnostics like in vivo scribe for NPM1, digital PCR for NPM1 and FLT3, and NGS MRD, all these definitions in terms of utilizing the maintenance will start coming down, because when these data came out, we were blindly treating without knowing what is happening. So, if you see the Morphine trial, which is kind of a seminal in a sense, published in JCO, talks about if the FLT3 pre-transplant is negative, then there is no utility of giving gilteritinib because it does not add to the overall survival.
So, Dr. Rahul, I am specifically talking of people who do not have a targetable mutation. See, 30, maybe 25-30% FLT3, whom you will give sorafenib.
Those patients, Dr. Sanjeevan,
so you forget about just 25-30%.
As a when Dr. Dinesh said, it's not curative. The moment you have as a when any patient who's not going for a bone marrow transplant, and they have a high risk mutation, say NRAS or something like that, or TP53, it's a dictate just continue till progression.
Precisely. So that is that question to Dr. Riaz, the answer to Dr. Riaz's question is that will depend on what was the initial treatment.
And in as a when trial, the only people who could stop after 12 months and didn't relapse was the NPM1. So if you have an NPM1 positive, there's a probability that you can still get off from as a when after giving 12 cycles and continue monitoring NPM1.
So, yeah, we will move forward. this was the intravenous azacitidine was given for in this Dutch-Belgian cooperative trial group, and the 12 cycles of maintenance azacitidine was given, and we could see that improved median DFS from 10.3 to 15.3 months, but there was no difference in OS. And this was the arm. And AML 16 also, this was phase 3 trial. Again, the survival rate, you can 5-year survival rate was 40% versus 13. So these are the patients who had not been transplanted. So role of azacitidine, as I was saying, oral azacitidine maintenance therapy for AML in first remission. This was the trial, and we can see the difference of almost 5.3 months in those who were given oral azacitidine as compared to those who have not been given. So azacitidine, as we were discussing, maintenance therapy post BMT. This was one initial RELAZA 2 trial, which was open label multi-center phase 2 trial, and it was given as 75 milligram per meter square from day 1 to 7 of 29 cycle, resulted in 2-year OS of 62% and EFS 54%. Well tolerated. Neutropenia was the most common side effect. But phase 3 trial of IV azacitidine versus observation after transplant in high risk AML and MDS didn't show any benefit. So IV azacitidine in phase 3 trial post transplant is not showing. So basically, this is the what I got it said. Azacitidine is not showing any benefit in either survival, or the probability of survival is remaining the same. Incidence of relapses and incidence of transplant relapse mortality, absolutely no. So what from this trial I can conclude was that IV azacitidine is not helping in any form in post-transplant setting. Now, there is another paper which I was able to get. It was a combination of GCSF with decitabine, and this trial did show that when decitabine in combination with GCSF was given, had decreased incidence of relapse as compared to the observation arm, and the chronic GVHD was also less, and the cumulative incidence didn't matter in either of the arm, but the relapses were better when it was combined with GCSF and decitabine. So that's one point. So that has been what the recommendation. Now coming to the combination, we were talking about as what do we do for combination azacitidine plus BCL2 inhibitor. So do we do this in our practice, azacitidine with venetoclax as a maintenance? Dr. Dinesh,
our problem has been the neutropenia. One more highlighting point I would just like to bring from our own study is azacitidine. When you taper cyclosporin on day 19, stop and start giving azacitidine, you can still have a bad GVHD. And to an extent that the patient was sent back home, Indore, and he developed a bad GVHD, grade 4 GVHD, could not be salvaged. He was in CR at day 150. So azacitidine does also bring in, and we are trying to collate our data, looking at the people till day 90 who didn't have GVHD, and when you stop and you give azacitidine, what was the cumulative incidence of GVHD? So it is a problem. GVHD, it does induce GVHD, and you get GVHD at that moment of time, which can lead to a mortality. That's what our group has shown at this present moment of time. So Dr. Dinesh, sure.
We are using as a when. We are not using when for 3 to 5 days apart from 3 days of decitabine.
So as a when combination,
saying the increased risk of GVHD is because of your cutting down the immunosuppression, not because. In fact, we are able to continue the immunosuppression a bit longer, say 120 to 150 days, because we are giving something maintenance. But that is we don't have a comparative arm, so we don't know. We need to publish the data to say.
Did you experience a GVL? I mean, was this able to give you a GVL?
I think it does.
Does?
I mean, some of our patients are relapsing when we stop the maintenance, and they would have relapsed earlier probably, and they relapse later.
So coming to this, we have been discussing from the morning use of FLT3 inhibitors. We have discussed enough, but yes, midostaurin after transplant has been there in the, and it has shown some positivity. Sorafenib maintenance after allogenic transplantation, and the Soramin trial had shown the benefits. The post-transplant viltetinib, as shown by Dr. Biju initially, that those patients who had MRD positive at the time of transplantation, those were the only group who had benefit using post-transplant, although the relapse risk was reduced. And quizartinib. So although we don't have, but anybody can take, if quizartinib anybody can have used in this panel.
not the Quasar first trial, they showed that actually it did not help. So when as post-transplant maintenance.
In
The Quasar first. So
yes.
that's why it's not FDA approved for the arm where they had transplant and then maintenance. Only for those who did not have transplant, but the maintenance was continued, there was an advantage.
So this is the one phase 1 studies. 60 milligram, 13 patients were enrolled and had some benefit. So these are the few trials which has been going on: azacitidine, decitabine plus venetoclax, aza plus ven, sorafenib, gilteritinib, and ivosidenib and inacidinib in the IDH1 inhibitors. But what we are awaiting is Amadeus trial, reality, Zorinostat, and these are the future which studies which will be coming, and we will know a little bit more on the which group as maintenance is going to help. So we can say the patient who has been considered in which there is no molecular drivers, whether you should consider for hypomethylating agents plus venetoclax, and in the FLT3 you have gilteritinib and sorafenib, and IDH we have the ivosidenib at present. So with this I'll end, and thank you for listening.
Do you use for every FLT3 patient you use sorafenib?
We've used in a few. We've had bad experience with that. That hand-foot-mouth syndrome is quite bad.
So, Dr. Dinesh,
are you able to increase the dose? Using it if the patient can afford? I've used midostaurin post-transplant, and so that is quite well tolerated. There is some amount of neutropenia, but they tolerate it quite well.
Sorafenib skin problem is very bad.
And what is the dose you are using?
Of
sorafenib
between 200 to 400.
Some other we've not had much problems with sorafenib. Our sorafenib patients, some other, although we are very watchful of this hand, foot, mouth, and the other.
200 BD or 200 OD?
No, they are young ladies.
Sure,
wives.
So if you started with low dose, then
200 BD is not a difficult dose. Sorafenib in hepatocellular is a difficult dose because it is excreted through liver. But in FLT3 AML, 200 BD is. I have two patients doing for 8-9 months. They did well. So.
Sure. Thank you very much.
Thank you so much. This was indeed a thought-provoking discussion. The next is a talk on BKMS, for which I would like to invite Dr. Nitin Agarwal, Dr. Reshma Kumari, and Ms. Arohi Tripathi. Please.
Thank you. A very good afternoon to everyone. Before I start, I want to thank Dr. Rahul Bhargav and his wonderful team for giving us this opportunity to talk about our cause and the work we are doing at DKMS. So DKMS is an international non-profit organization. We started in 1991 in Germany, but since then we have expanded to different regions of the world, and India being the major focus here. We have registered over 13 million stem cell donors, out of which 2.5 lakhs are Indians. And thanks to our donors, we have given second chance at life to over 1,30,000 patients, and 220 plus Indian donors have given second chances at life. At DKMS, we are giving 25 second chances at life every day. We are expanded in different countries, but when it comes to India, we are still far behind. So this is the current status why Indian patients are finding it difficult to find matches, unrelated donor. As per ICMR, according to ICMR study, close to 60 to 70% of the patients are dependent on unrelated donor. They are unable to find a matched sibling, full matched donor in the family. But due to certain challenges, the high facility diversity in India because of different ethnicities compared to Caucasians who have a chances of finding a matching donor, 10 by 10 is 80 to 90%, but for Indians it's still 20 to 30%.
The registries are very underrepresented because of the lack of awareness. People are not aware of how to register and why they have to, help other patients. There is lack of awareness also among the families. When we are registering a donor in India, it's not just one person. When they come as a match, we have to counsel not just the donor but the whole family and tell them, what is going on. And there are a lot of misconception and myths that if they go and donate the stem cell, there will be issues in their life and their health. So we are looking forward to increase this donor data pool. And the major challenge, according to everybody's knowledge, is that socioeconomic barrier in India. With the largest population of 1.42 billion, the economic status is not so well to afford the cost of transplantations. To overcome these barriers, DKMS is trying not to just register potential committed donors. We are also having footprints and holistic approach in all the dimensions. We are boosting stem cell donations. We are not just focusing on the urban market. We are expanding our reach to different niche market in country, going to tier 2 cities, counseling them, educating them about the donation process, and registering more and more diverse population. Coming to the improving access to transplantation, it's one of the major programs that DKMS runs. Reshma will be talking about it later. This is a good program that we're trying to support as many hospitals in India. And we are also focusing on advanced research and development. We have a very high throughput lab in Dresden, Germany, and recently we have started our lab in India as well to work on different diagnostics and clinical trials as well. Coming to the DKMS registry is a different separate entity of the DKMS group. This started 10 years back, where all the registered donors from DKMS and around the world by World Marrow Donor Associations, 43 million donors, we provide the access to all the transplant centers to those donors. Coming to India, we started with like 37 transplant centers, but currently over 100 hospitals and transplant centers are our partners, and we are trying to help them with their merge support. Being WMD accredited, we are largest donor registry in the world. We provide donor data of over 43 million through our Happy Search platform. It's like a search engine where you can find a matching donor within 10 minutes. And we will give data not just of DKMS donors, we give data of all the donors available in the world who are part of the WMDA data. There is no cost for DKMS donors when you are doing a verification typing or IBMs. You only have to pay at the time when you have received the product. And for Indian donors, for Indian DKMS donors, our cost varies close to 5.5 lakhs. And we also have patient funding programs to support further. We have a team in Germany who is search coordinator teams, and myself and my team here in India, we're trying to do on-site support to all the hospitals. We understand that, there are limited resources. You're not always having time to do the searches by yourself. So we will do the searches for you. We help you and telling that how many matches are available and how to do the donor selection as well and proceed further. And not just DKMS donors, we also help with non-DKMS donors around the world. Wherever the matching donor is available, we will coordinate with the other registries and help you get the matching donors product available at your center. So how we function is for any new transplant center, as per WMDA, this is just one-time process where we have to fill the form of infrastructure and the capability of the center. Seeing the transplant, how many transplants has been done in the BMT unit, and the existing partners we reevaluate every 3 years. We also support with the training and guidance for the Happy Search platform. It's very user friendly. Once you start using it, you get the result in 5 minutes. So all the registry data will be available to you, including Indian registries like GeneBandhu, MDRI, or Datri. All the donor data we give you in one-stop shop for you. This is a gist of our work over the years till September month this year. So we can see a steady rise in the search request, incoming search request, and hopefully this will go further with our collaboration and working together. But when it comes to pre-workup is the verification typing, the process where a matching donor is found, and we check the availability of donors. So you can see that the conversion rate is so low. If 352 donors have been available and perfectly matched for the patients, only 75 went ahead and donated their stem cells. There can be various reasons from the hospital size, from the patient's health status, or financial issues as well, where we're trying to overcome the challenges. And out of these donors, 37% has been the domestic donors, Indian donors who have given second chances at life, and 63% are international. But as we are increasing the donor data pool, registering more committed donors, this scenario will change soon. And we'll have more Indians to come forward and donate their stem cells for Indian patients. To sum up, this is our standing right now, but we really look forward to help you in a better way, exclusive on-site support, and provide you all the data needed, all the coordination needed for the donor request so that you get the product on time. We understand that timelines are very important when it comes to malignancies and disorders like aplastic anemia. So we are trying to overcome those challenges as well for you. With this, I sum up my part, and I request Resma to please take it further. Thank you.
Thank you, Arohi. Okay. DKMS has always been pushing itself to provide access to transplantation for patients who otherwise not receive the same. The main core aim of DKMS is that to provide access to transplantation, especially in the low and middle income countries. So under DKMS access to transplantation, we have these three main pillars. The first pillar is to provide free HLA typing for patients and their family members, especially for those children diagnosed with thalassemia and requiring transplants. The second main program is the patient funding program, where we support partial funding support for patients who require transplants for the patient, especially for the patients who are diagnosed with blood cancer and other blood disorders. And the third program, what we have is Empowering the Better Tomorrow, where we support for the capacity building and the knowledge sharing. So under DKMS patient funding program, we partially support for patients who require transplants. And not only that, we also guide these patients and their families to approach other funding platforms when they are in need of financial reasons and their transplant is being delayed. Now, since June 2025, we have come up with a new program for post-transplant support. This post-transplant support is extended for patients who have availed patient funding support and they are looking for some kind of a financial support for their post-transplant treatment. The main free HLA typing program, under this, the family members of thalassemia kids are they undergo their free HLA typing and their samples are being sent to our lab in Dresden in Germany, and the reports are being shared with the families. And in case there are no matched family members in the family, these families have been recommended to go for mud transplant by providing them free mud searches. So here is the graph, the impact of the patient funding program. You can see that year-on-wise, we have increased our impact because we have collaborated with many more hospitals or transplant centers in India. As of Q3, we have supported around 300 plus patients for their transplants. This impact is of thalassemia program, where we have typed around 2,500 patients for their free HLA typing, out of which around 500 patients have found a perfect match in the family. So moving ahead, we as DKMS would like to boost the stem cell donations by organizing the free drives across India and register potential healthy committed donors from various ethnic groups. And we also would like to extend our patient funding program support, post-transplant funding support, and free HLA typing supports for the patients who are in need. And having an on-site coordinator like Arohi here, we would like the hospitals to avail this facility to fasten the mud search. Thank you. Any questions?
Thank you so much, ma'am, for making donor search easier. We now begin with session 2 on DLBCL. And to discuss the next talk, I would like to call Dr. Rohan Haldar, who is a senior consultant hematology at RGCI Delhi, and Dr. Meet Kumar, who is a director hematology at Marengo Asia, to moderate the next session.
I think we are behind schedule by about 30 minutes. A humble request to the further speakers to try to attempt to stay within the time limit. Thank you.
So without undue any delays, may I request Brigadier Ajay Sharma sir for the wonderful talk on the topic DLBCL 2025 moving to 2026. What changed?
Good afternoon. I thank Rahul and his team, Prakshilati and all, to make us come here and have the wonderful interaction session today. In the series of sessions dominated by AMS this morning, let's change over the gear to equally, I would say, interesting field of lymphoma, of which DLBCL is the main prototype. As we know, there is almost 35 to 40% of these cases that the DLBCL presents. It's pretty common in our country, and there is a real felt need for an optimal therapy for this potentially fatal disease. And as I mentioned, DLBCL forms the main chunk of the lymphoma group of diseases. I would like to refer to this study from our country, which has just been published in Indian Journal of Hematology and Blood Transfusions this year, where they actually have analyzed the data of Indian patients for over the last few years wonderfully, and the analysis is good. And as you can see here, the overall survival of the 2-year PFS rates were about 80%, expectedly better in GCB than ABC, and 2-year overall survival was 81%. And the analysis is good. I recommend everybody to go through this study about Indian patients. As such, the DLBCL is a common type of neoplasm, and it continues to be a problem. And there has been a search for the optimal therapy targeting the surface antigens and intercell pathways in the neoplastic B cells. For last so many years, the cornerstone of the treatment has been R-CHOP for almost 40 years, with cure rates of almost 40 to 60%. But once patient relapses, the choices are limited and the outcome is dismal. There was nothing better than R-CHOP for all these years, and in those patients who underwent transplant, the platinum-based regimen followed by autologous transplant has been a standard second-line treatment for relapsed diseases. But after rituximab, there has been a good big gap in one slide is missed. So after rituximab, there has been a big gap, and once the lapse occurs and patient has been given rituximab earlier, the transplant and all not make a big chunk impact on the outcome. And in primary affected disease and those failing the salvage therapy or relapsing after transplant, the median survival is very short. And for years, there have been some attempts to improve the outcome, and of late, with the targeted therapy has has been becoming more and more popular, and we are looking for the monoclonal antibodies, checkpoint inhibitors, engineered T cells, and these modalities have shown high responses, higher PFS, and overall survival rates. But more important, equally important, is the precision in the diagnosis. from the morphology to IHC, from IHC to flow cytometry, the diagnostic capability has improved, and now we have moved on to the NGS, which helps in the better diagnosis and classification, prognostication, treatment guidance, and monitoring of treatment in the form of MRD to choose non-invasive and minimally invasive make those diagnoses. There are a large number of mutations that can be identified by the NGS in the DLBCL itself, and many of them can be targeted and are being targeted, and they are the potential used by markers, and that is how the targeted therapy is being adopted. Based on these genetic mutations, the DLBCL is being grouped into a number of groups, and even amongst ABC and GCB type, we have these mutations which are identified, and these mutations actually have impact on the outcome. BN2, EZB, N1, they have the direct impact on outcome, and that helps us to choose the therapy and target this form of disease in a given patient. But there are challenges in the NGS. Even today, the standardization is a problem. The clinical correlation is not accurate. How to integrate into the routine clinical practice. So all these problems need to be overcome before it can be adopted as a routine practice. Then there is a improved response assessment from PET-adapted therapy to the MRD-adapted assessment, and now we have the circulating tumor DNA-adapted assessment, which can improve the outcome still further. So these are the developments that have been happening over the years. And after this kind of workup, the new targets are being identified, of which the CD19 is the one of the most popular target, and then we have the other targets. We'll go through them one by one, some of them one by one. As I was mentioning, there was a big gap in the these target therapies after rituximab, and now over the last couple of years, we have got large number of agents being approved time to time. CD19, I was mentioning, is one of the most popular antigen because it is most ubiquitously expressed marker on the B cells from the progenitor's stage to and getting down to the plasma cell stage. So this is being used and being more and more because this acts as this CD19 targeting, it acts as the antigen, the independent B cell development as well as antigen-independent targeting, and that's overexpressed in lymphatic malignancies and can actually correlate with the c-MYC to increase the risk of the disease. So based on this knowledge, therapies targeting CD19 have been developed, and CAR-T cell has come out of this effort only. And today the CAR-T cell therapy has become a standard of care for many patients of lymphoma, of DLBCL. As I'll request for your attention on the overall survival, the response rates are amongst the axis cell, TISA cell, and lyso cell, almost 80% overall responses and 73% in the lyso cell, while EFS, PFS also are improving with the improvement with the new generations coming up in the CAR cells, CAR-T cells. Even in the usage, even after using the transplant, comparing the CD19 CAR-T versus transplant patient with DLBCL who have relapsed within 1 year of the first line therapy, as we can see here, the response rate to axis cell and TISA cell and lyso cell have been good, 65% and 74%, while for TISA cell, they have not been as good. So the first two have been actually recommended to be used as the second line therapy, while the lyso cell has not been approved for this. So CAR-T cell therapy today is the standard of care in patients who relapse after 2 or more lines of therapy, axis cell and TISA cell as well as lyso cell, while patient with primary affected disease within 1 year after first line of therapy, only axis cell and lyso cell. There are challenges in CAR-T cell therapies. Also, the resistance which gets mediated by the CD19 downregulation as the time goes by, the innate function of engineered lymphocytes, limited efficacy against
high disease burden and the high systemic inflammatory states in these patients, which is responsible for various toxicities, poor morbidities in the patient, poor performance status even for the CAR-T, non-logistic complexities. So we actually have to look for improvement in these CAR-T cell therapies because of these reasons, and that is why the research has been ongoing. This is one anti-CD antibody which has been developed, tafasitamab, which has got augmented FC affinity, and this increased affinity with the NK cell and macrophages facilitates these cellular cytotoxicity and cellular phagocytosis and direct cytotoxicity. And its combination with lenalidomide has actually shown promising results. As you can see here, the overall responses of about 60%, CR of 40%, and a median survival of about 11 months, and duration of response about 43 months. But this trial, ALMIND trial, actually did not include the high-risk patients and patients who had received prior CD19 therapy. So that aspect should be kept in mind before interpreting this trial. CD19 antibody drug conjugate, that is LONCA, this has been studied in Lotus 2. The response rates of this have been just moderate, but now we have got the Lotus 5 and 6 studies going on where the response rates are more than 60 to 70%. So this may be agents may be coming up in this line. Then we have anti-CD bispecific T-cell engaging antibodies. CD20 rituximab was in use for a long time, but there was a plateau after that. Even after rituximab or rofasitamab, the improvement was not much. So that's why we got into these T-cell engaging bispecific antibodies where we had CD20 on one side in the B cells and on T cell we have CD3. And with this combination, there has been marked improvement in response rate because this forms immunological synapse which causes the lysis of the immunoplastic B cell. So these have shown the much more improvement than glofitamab is the prototype of this, which is being approved now. And we have got one odronextamab, which also has been being studied at present. Polituzumab, anti-CD79B, I think there is a session on that. This is an agent to be looked with the great interest because there are some moderate responses which are perhaps not very significant as far as CR is concerned, but the PFS has been shown to be showing good responses, especially in the ABC type and the GCB type. So I think this agent has a role to play with, and it is going to, as actually it's become one of the drugs of choice in a patient who has got high risk and is being recommended to be used. Receptor tyrosine kinase like orphan receptor 1, ROR1 is a receptor which is overexpressed in many solid tumors and also in lymphoid malignancies. And its overexpression is associated with the poor prognosis. Zilbertinib is the agent which has been targeting this receptor, and this is being studied in waveline 003. Again, here the responses are optimal, but now we have got 005 trial going on where the response rates are much better, and even the same as monotherapy, zilbertinib has actually shown promising results. Other drugs which are actually being developed are we know about brentuximab, it's already been available. We have checkpoint inhibitors. We had a discussion on this in the morning. Then BTK inhibitors, BCL2 inhibitor, we have this agent very commonly being used for AML and many other conditions. So this is actually already being used for the DLBCL also. Then there is some work going on in the changes in the tumor immune microenvironment in DLBCL and which improves the outcome. This is another area of research. So the future developments that are happening in DLBCL are because CAR-T cell therapy is a continuing progressive approach. There are improvements which are required to be done because it's still not becoming optimal therapy. We need to limit its toxicity, improve and make it sustained efficacious mode of therapy. The third generation CAR carriers, and again, they carries two post-stimulatory domains, CD28 and 41BB, which results in quicker expansion of T cells and more rapid elimination of tumor cells, but also increases the toxicity of the drug. So that needs to be looked into that. Then we have dual targeting CAR-T cell, which targets two different antigens on lymphoma cells such as CD19 and 20 and 19 and 22. These have been showing good results and can improve the outcome by reducing relapsing due to antigen loss. Then we have armored CAR-T cells which are being developed now. They utilize several mechanisms to modulate the immune checkpoints and circumvent inhibitory effects of tumor microenvironment. So they actually are now being tried, and they are believed to be much more effective. Then we have switchable CAR-T cells, which incorporate several suicide mechanisms to deplete the activated cells, and that's why the toxicity gets reduced. So this is very promising field, and this is something which is very promising to be used. The universal allogenic off-the-shelf. The big problem with the CAR-T, we know, is the availability and the turnaround time that it has got. So that is being overcome by the universal allogenic off-the-shelf CAR-T products, as well as CAR-NK cells, because NK cells have a property that they target the cells without MHC restriction, thereby not having any GVHD-like effect. So they are very much more useful and are being tried more and more. But most of these are phase 2 trials. They need to be validated by randomized phase 3 trials to ensure the delivery of effective and safe and personalized treatment to every patient to be successful and to improve the outcome. So this is a very exciting field, and a lot of work is going on, and we are seeing many changes, new products being made available to our patients. But this is very interesting aspect. We see the growth rate of the cost of the treatment and money that is being invested into the research of the large DLBCL lymphoma, and this is the quantum of the market in the DLBCL, and that's why there is an interest in the development of the new drugs. And the flip side is that we are getting better agents available to treat our patients. With that, I'll conclude. Thank you very much. And I think we have very good sessions coming up now.
Thank you, sir, for that eloquent talk. The house is open for any discussion, any questions, any queries. One question from my side, I think that you look forward to in the coming year in lymphoma, in the DLBCL space. Anything from ASH that attracted you most?
I didn't get.
No, was there anything, any abstract or anything that you look forward to in the coming year in the DLBCL space?
One couple of agents that I mentioned, there were a lot of abstracts on these, but I've not actually come out with the specific abstracts from the ASH, because that was not specifically the topic given to me. So I've just compiled the certain agents that are being marketed and are in the pipeline in my presentation. But there are a lot of agents actually which are being under trial and are going to be available for patient use very soon.
One more thing, BTK inhibitors are also having a good role in at least indolent type of relapsing DLBCL. So that is what we have.
I mentioned that, but I didn't go into detail because of the time thing. I just mentioned that, I think, and I just mentioned that these are the agents available and they are actually already being used. So I just and they are in the CLL and all, we are using them. Thank you.
Thank you, sir. Thank you. Thank you, sir, for the insightful session. Before we move on to the next session, I have a little announcement to make. Also, the HemePath quest, which is analogous to a scavenger hunt, is also on. There are 10 HemePath questions which are hidden in 10 QR codes and exhibitor stalls. So you just need to scan the code and answer those questions on your phone. Fastest finger first, and the most accurate one wins. For the next session, it is a star-studded pathology session, and I will invite the chairpersons. One of our beloved, Dr. Brigadier Tathagat Chatterjee, sir. He is the head of lab from ESI Hospital, Faridabad. Dr. Renu Saxena, ma'am, who also needs no introduction, the head of hematopathology labs at Medanta Hospital, Gurugram. And my very, very dear friend and my person from Tata Memorial Hospital, Mumbai, now working at Manipal Hospital, Dr. Moshni Kaur. I will invite the speaker for this session, who again is somebody who needs no introduction and very, very close to my heart, from my alma mater, from Tata Memorial Hospital, Mumbai, Dr. Gaurav Chatterjee. who works in the hematopathology lab. He will talk to us about how lymphoma has evolved from cell of origin to genomics, and I'm sure it's going to be a very good session. Thank you.
Thank you, Srinidhi, for that introduction. At the onset, I really want to thank Dr. Rahul, Dr. Vikas, and Dr. Srinidhi and team for calling me here and letting me represent my lab at ACTREC Tata Memorial Center. So, yeah, I'm just waiting for the slide to be on. Right. So in the next 20 minutes, so talk a little bit about how just genomics, the genomic spectrum of DLBL look like in today's date, and especially in the context of how it can help in deciding therapy. So before we begin, it's important to reiterate that, as you all know, large B-cell lymphoma diagnosis, like all lymphoma, is a multifaceted affair, and there is no replacement, absolutely no replacement for clinical and radiologic history, as well as morphology remains the core of this diagnosis, supplemented by IHC. And today we'll see how does NGS kind of fit in this kind of algorithm. So we start with the case. This is a 74-year-old female who, as you see, presented with this kind of symptom. There was no lymph node though for this patient, and she actually presented in one of our sister center at the HVCH hospital at Punjab, so Tata Memorial Center, Punjab, and there was leukocytosis, if you can see that. This is the morphology. You can clearly see there was some high-grade looking cells, blastoid, query blastoid. And these are the flow plots. Again, this is courtesy my colleague at Mulanpur, Dr. Ravi Kiran Pawar. This patient was being treated there only. So you can clearly see 1922 positive, lambda restricted. So this is a B-cell lymphoma, all right. This was positive for CD5 as well, 23 negative. So based on these markers, they called it favoring a mantle cell lymphoma, possibly a blastoid mantle cell lymphoma based on the morphology. But the cytogenetics was negative for CCND1 rearrangement. So at this point of time, the NGS was sent to us at ACTREC. So before we go into that, just a few basics on designing a panel for lymphoma that you can do for NGS. So the first thing to note is that if you see, this is a plot from quite an old paper actually from Wellcome Trust Sanger, where they simply itemized the neoplasms based on the median somatic mutation number, and you can see that CLL as well as large B-cell lymphoma, they're mutationally far richer than the leukemias like ALL and AML. So what it means is that you will probably require a reasonably larger size panel for representative sequencing of lymphoma as compared to leukemias. So what are we looking for? This is also very important. This is a very favorite plot of mine which we generated last year for one of the reviews. So it's important to note that the kind of thing that you're looking for, based on that your assay will change. So if you're looking for gene expression, you need to do a certain kind of assays. If you're looking for copy number alterations, gene fusions, or SNVs or small sequence mutations, the panel will be different. So here in space of lymphoma, we are primarily at DNA level looking for such a panel which can detect both sequence mutations, copy number alteration, as well as translocations. So based on this, this is the panel that we currently use. It's a completely bespoke panel developed in our lab only, which has around 205 genes data, and our goal is to detect sequence mutation, copy number alteration, as well as common gene translocation. And it is supplemented by an RNA-seq panel which can detect the gene expression. So coming back to our case, this patient was positive for a mid-88, and not only mid-88, an L265P. You can see, obviously, this is the hotspot mutation for a mid-88. Also in CD17B, we got a Y196, which again, if you see the common mutations in CD17B, this is the hotspot. So we have got a couple of hotspot mutations in mid-88 as well as CD17B. There was a PLCG2 mutation as well. Just keep that in mind. We'll come back to this. We did copy number alteration analysis. Like I said, the goal of the panel is to detect both mutations as well as copy number alterations. So here there was this is the gene level data. There was a CDKN2A loss, you can clearly see, but in the chromosomal level, there was an 18q gain along with some small changes in chromosome 7, but this was quite significant, a gain in 18q. So based on this, what will the diagnosis be, or where will the patient fit, you think? Like this patient was diagnosed initially as a case of mantle cell lymphoma, CCND1 rearrangement negative, but now we have this kind of mutation profile. So as Dr. Sharma has alluded to, we now have, there were I think 3 at least large seminal papers in this space, one from Harvard, the other from NCI, and one from UK, which looked at this. And this is the NCI, the Margaret Ship Boston paper I'm showing you, where they did whole exome sequencing as well as gene expression, and they found that there are certain classes of DLBL. So the basic idea is that the mutational co-occurrence is not random. These all mutations, they co-occur at a very patterned manner, and based on that, you can subclassify this patient. So if you focus on the C5 or MCD group, you will see that the characteristic features are 18q gain, mid88 and series 17B mutation, which is exactly what our patient had. So our patient is basically a C5 MCD DLBL. And they also went on to show that this has some prognostic relevance. So for example, within ABC subgroup, this C5 subtype is supposed to do inferior with R-CHOP. Similarly, there was two different subtype with differing prognosis within GCB subtype. This is another patient. Just I'll run this quickly. It's a DLBL. You can see there are three mutations that are of interest: CREP-P, TNFR, SF14, and Nezerin2. Along with that, there was TP53 as well. And we also picked up a translocation. I'm just showing this to you to show that NGS can pick up both mutations, copy number alteration, as well as translocation. So we detected an IGH-BCL2 fusion in that. And if I look at the C3 subtype, it is classified by BCL2 rearrangement as well as mutation in exactly these three genes: CREP-P, TNFR, SF14, and Nezerin2, clearly indicating that this patient belonged to this C3 or EZB subgroup. So this is the similar paper from NCI, from the lab of Dr. Louis Stout, and they also similarly found out this kind of classes of DLBL. Thankfully, there was some overlap. So for example, the MCD subtype is what the Boston group referred to as C5 and so on, but they also found out these subtypes. So, unlike not unusual for us, we are hematologists after all, so we find ourselves in two classification, right? So one is DLB class, the other is this LIMGen, and there are some similarities, like I said, but there is some difference as well. The most significant of them being that the number of cases that are classified. So if you see LIMGen, almost 38% patients still remain unclassified, whereas DLB class, that is the one developed by the Boston group, they classify close to 95% of the patients. That doesn't mean that any classification is better than the other. Only a prospective validation of the two, classification can shed light on which one will be more clinically relevant to use in future, especially in the Indian context. So this was something which is happening on the DNA side, right? So what was happening in the RNA side, where we have been doing ABC and GCB. So here there is some advancement as well. This is a paper from the lab of Dr. Marine in Vancouver. What they found out is that this dark zone signature, which basically comprises patients of Burkitt lymphoma or DLBL with double hit translocations, but importantly also a huge subset of DLBL patients who do not have that double hit, but gene expression wise they are similar to double hit, and they this is the patient that we refer to as dark zone signature. And you can see from this plot, I think one is red, the other is green. You can see that the prognosis remains same if you are dark zone signature. Doesn't matter whether the actual double hit is there or not. So this was an important advancement in the field of gene expression. So this is where we find ourselves in the space of DLBL. One, again, this is very important to understand that the technique that you are using and what you are looking for will differ based on that. So based on the gene expression at RNA level, we have ABC, GCB, and now we have dark zone signature, which is kind of a prediction of inferior prognosis. And if you do DNA sequencing, especially a larger panel like whole exome or a larger targeted panel, you will be able to classify the patients into one of these subgroup, which has this kind of patterned co-occurrence of mutations. So why do we need all those subtypes though? So much complexity, so much granularity, right? So if you look at the space of DLBL from rituximab till Polarix, there were multiple efforts to see if a drug can improve the survival of DLBL as a pot of patient or even in ABC GCB subtype, but all of them failed. So if you see the Phoenix trial, it did not show any survival benefit in DLBL with addition of ibrutinib, even when they looked at specific subtype like ABC or GCB. Similarly, the remodel B and robust, I think the latest result of remodel B, the 5-year might show some benefit, but before that there was no benefit here. And when they looked at the post hoc analysis though of the Phoenix, and they then theoretically named it as the Phoenix Rises. So what they found is that if you are a particular DNS subtype like MCD or N1, then the 3-year event-free survival with ibrutinib were great. This was actually almost 100%, right? This is less than 60-year-old patient. So this is post hoc, but still it seems that we need this kind of more granular classification to find out the most useful drug in this subset of DLBL. What about Pola? So if you look at the Polarix post hoc analysis, again, we have to remember that. So there we know that this is something which works better in the ABC subtype, but also in this kind of DNA-based subtype. So if you see, this is an ASH abstract where this is shown that the EZB and the MCD subtype are supposed to benefit best from Pola. And similarly, the dark zone signatures are the group that benefit from Pola. So maybe even for polatuzumab, there are certain subtypes which will benefit the most with the addition. The most compelling evidence of using this kind of granular classification though comes from China. This is the phase 2 guidance trial where what they did is they This trial basically compares R-CHOP X versus R-CHOP. So X here is defined by the genomics. So if it's MCD-like, the X is ibrutinib. If it is EZB-like, the X is an histone deacetylase inhibitor, and so on. And they showed that this R-CHOP X resulted in significantly superior survival. This is phase 2. The phase 3 is still ongoing. But if the results are replicated in phase 3, this could really become the SOC and will probably be used in clinical practice. So if we come back to our case now, remember it was a C5 MCD type of DLBL, but the patient also had a PLCG2 mutation. So what is there any significance of that? So it turns out that yes, there is. So there is this group of mutations, the BTK, the PLCG2 and CART11, which works at the Bruton tyrosine kinase pathway, and their mutation predicts resistance to ibrutinib, much similar to what like ABL kinase domain mutation predict resistance to imatinib. So therefore, this mutation in this particular patient predicted that this patient may not do well with imatinib. So if you just step back a bit and think that in our patient, how much NGS helped. So first we corrected the diagnosis from supposed blastoid mantle cell lymphoma to a biologically relevant C5 MCD subtype of DLBL. You could say that from within the ABC subtype, they will probably have an inferior response to R-CHOP. We may benefit from addition of ibrutinib or pola, but then again, this patient had a PLCG2 mutation, so we could also say that probably not ibrutinib in this patient. This patient will not benefit from ibrutinib. And finally, this mutations also gives you a monitoring opportunity where you can track those mutations and see how their patients are responding with therapy. One last thing about DLBL classifications, we talked about RNA, we talked about DNA, but one more way of the background immune cells, right? So if you look at the background immune cell, this is an MD Anderson paper where they did a single cell RNA and ataxia in the background. And they could classify DLBL into these 3 subtypes like lymph node type, tumor cell exhausted, and so on. But importantly, they showed that the addition of CAR-T cell in these patients were likely beneficial only in this 2 subset and not in the T cell exhausted subtype. So even this kind of immune background oriented classification may be important for, especially for patients who are going to receive immunotherapy. So with that, we move on to this patient. This is a DLBL 63-year-old male, and we found a KMT2C mutation in circulating tumor DNA from peripheral blood. So this is the most important next frontier in where molecular analysis may help in DLBL. So we know that ctDNA measurement, again, we have to remember that how are we tracking it? So there are genetic ways of doing it, like single nucleotide changes, phased variants, deletions, and so on. But there is some non-genetic way to look at ctDNA as well, like fragmentomic pattern, like the methylation pattern. So there is some work of this we are doing in our lab right now. So if you look at the clinical importance of it, the most important clinical data comes from the lab of Ash Alizari at Stanford. So they first showed that ctDNA measurement pre-treatment ctDNA is a very important prognostic factor, far outweighs the traditional factors like IPI. And also with monitoring, so if you see, if you are ctDNA negative after 1 cycle or 2nd cycle of therapy, your prognosis was much superior to R-CHOP as compared to if you are positive at this point. And their latest paper has come on the space of phase C, which is an improvement in their assay, and this is something I think they are pushing it for FDA approval, which has found out that end of treatment ctDNA is particularly prognostically relevant. If you see that you could probably park a school bus there between these 2 Kaplan-Meier curves. So such is the significance of survival benefit. And especially they could show that even within PET negative and PET positive patient, based on ctDNA, you could significantly dichotomize the outcome based on how ctDNA was positive or negative. This can also be done in CSF. So this is a joint effort from Stanford and Friedberg University in Germany, where they showed that first, diagnostically it is important. Almost all patients of primary CNS lymphoma has CSF ctDNA. So we know that some of these patients cannot be biopsied. So for diagnostically, this also may be important. And monitoring on this patient from plasma is again clinically relevant, and they can stratify the patient based on survival. Finally, on Hodgkin's on lymphoma, we know that molecular analysis of Hodgkin has always been a challenge because of the relative rarity of the tumor in the background of the immune cells. So what they very interestingly shown is that the allelic frequency of mutation in Hodgkin is actually higher in peripheral blood. So, not only ctDNA works in Hodgkin, it may be the preferred way of doing molecular evaluation in Hodgkin cell lymphoma. And monitoring also is helpful in this patient, and it adds prognostic relevance even to PET, much like as we saw in the space of DLBL. So yeah, this is the way we find ourselves in the space of DLBL now. This is my last slide. So the potential areas where molecular technique might help in clinical management. First is risk stratification, of course. Second is biology-driven therapy selection. Like we showed you the result of the guidance trial, we could, if that results are validated, these things can be done. And more importantly, probably much like we do in the space of leukemia with MRD-driven therapeutic modifications, similar trials are going on ctDNA-driven therapeutic modifications in DLBL, and that may well be the future. So with this, I will end my talk. This is my team. I think you know all of them, and Neha is my PhD who is specifically working on this field. So thank you so much. We can take any question now.
Hello.
Hello. Thank you very much. That was an excellent presentation.
Thank you, ma'am.
Are there any questions in the audience? Otherwise, I will ask you. Any questions from the audience? Yeah. So just wanted to ask you, are there validated panels for Hodgkin's and NHL available? Validated?
In the sense that, I mean, most of these discovery cohorts are done on whole exome sequencing. There are some targeted panels, which, for example, the impact, which MSKCC use, it has a 600 gene panel, so it has all those genes as well. Specifically validated for this, I am not sure. Like that's why we have to design those panels in your lab so that you can get maximum clinical benefit out of it.
Did check and they were not available till.
Yes. That is why you probably need to design them in your lab, so it's not readily available clinically.
So then, would you therefore recommend whole exome sequencing for all cases?
It may not be a bad idea. Like if
and then identify the mutations and maybe use them on a digital PCR or something. For
that could be a good strategy. Yes,
That could be
yes.
a
Like we have and we are in a situation where the whole exome can be done in a reasonably cost-effective manner.
Yeah.
So it may not be a bad strategy to do whole exome sequencing. Only thing is that your computational challenges increase. So you need to be able to have an informatic unit which can interpret the data from there.
Yeah. Of course. Thank you.
Nice talk, Gaurav.
Thank you, sir.
Are we getting extinct, the morphologists and the immunohistochemistry? Is the Hans protocol extinct? Is the cell of origin extinct, the coup? I was just wondering, and I really appreciate what you have said. Just going back to your first case.
Yes.
I would have given this diagnosis in 5 days.
Yes.
From the time the biopsy comes to me to the IHC. I mean, that's a fair enough short time, 5 days for biopsy in IHC, and maybe I would have given it a high-grade lymphoma, and I would have ensured that I had done a CMIC for that, which you didn't mention. So my question is, what is the turnaround time you will give for the final diagnosis of the first case compared to the 5 days, which is maybe the most efficient way I can give?
It's a good question. So I think it's a challenge on us basically. I think it's more rather than a question whether it should be clinically applicable or not. The question is how we as a pathologist can bring it down to that can be acceptable. So we at this moment will be able to report within 2 weeks. But as you know, there are some panels, especially with the instruments, few of the instruments where 3-4 days result is possible, maybe with a panel of a lesser size, but it is still possible. And the direction where it is going is that only. So we are trying also like how to give it, especially in the AML space, we are really working on ultra rapid diagnosis. So that is the direction where we are going, and I think we need to go there fast. And it's a question of when will you reach that, other than whether we should reach there or not, according to me.
So therefore, maybe not in all cases, wherever one is stuck in a diagnosis, which can happen in so many cases, that's where one can resort to this. And also when you have to tailor your therapy to it, because now more and more therapeutic targets are being picked up. So that may be another strategy.
Yes, I think that's a good strategy. But specifically for DLBL, I will say this, that it seems like we have been classifying something way too heterogeneous as a single entity so far. Like that has been the problem in the space of DLBL. Which is why these target therapy trials mostly have failed on when you take DLBL patient as a single pot of patient. So probably, especially for DLBL patient, it might really be necessary. We still are awaiting the phase 3 results of guidance and some validated trial results. So when that comes, probably it will be required at least in the space of DLBL, I would say. Yeah.
I wanted to ask.
Yes, Mojami.
Yeah. Hello. Am I audible? Yeah. First, I thank you for such a compact talk on a so vast topic. And I really wanted to ask that you told that for heterogeneity of the DLBL, we should do this thing. But all the trials which you have showed that based on the ibrutinib or polatuzumab, it is mostly working on MCD variant or EZV variant or N1 something. And those are mostly ABC type, I think.
Yes.
Most of them are not GCB type.
Yes.
So when we are getting a GCB type, like we have already got a 10 positivity or BCL6 positivity. So will you suggest for that also we should do, or only those ABC type we should?
So one important thing is that we have the dark zone signatures sitting right in the GCB, and they have a very different prognosis as compared to the rest of the GCB, right? So, and the dark zone signature also, at least the post hoc analysis suggests that they really benefit from POLA. So that is one area where I would really look at in GCB subtype as well. ABC, right? Yes, you correctly said that probably it is more useful for ABC. Yeah.
And also, which you showed that C1 to C5 of Chopra et al. And Wright et al. But both of them have used different techniques. One have used whole genome sequencing, and other one have, I think, used some targeted ones. So, what will you suggest that if there is some constraint or monetary constraint, can we go for some targeted sequencing?
Yes.
Except at that
Yes.
whole
So
genome
thankfully, we are not the discovering here. Like, so we already have the discovery cohorts. So now we can take from there. But the only problem is the panel will still be reasonably larger than a myeloid panel because the mutation number is such, as I have shown you, that the number of mutations is anyway more. Sorry?
Almost how much it is?
So our panel is 205 genes. That like what I showed you a little bit ago. So that's a 205 gene panel. You can reduce it to around 100, I will say.
Okay.
Yeah.
Okay. Thank you.
I think one of the greatest mistakes here, and this is my last comment with your permission. The greatest mistakes we have done is categorizing a heterogeneous DLBCL into specific subtypes of GCB, ABC. It's a dynamic process.
Yes.
And I'm very sure the molecular biologist, which you're taking this a step forward and proving us wrong. And we have to accept it. Thanks.
Thank you.
Thank you. Thank you so much.
Thank you, sir. Thank you, chairpersons. For the next session, I would like to invite Dr. Prashant Mehta, who is a program head at Amrita Hospital, Faridabad, and Dr. Roshan Dikshit, who is a senior consultant hematology at Akash Hospital, to moderate the session. And for this session, I would like to invite Dr. Gaurav Dikshit as the key speaker, who is a consultant hematologist at Artemis, Gurgaon.
Good evening, everyone. First of all, thank you, Dr. Rahul, for giving this opportunity. So I will be talking about polatuzumab, bispecifics, and CAR-T, and mostly I'll be talking about their upfront and frontline use. We all know about this, that in first-line DLBCL, most of the patients are cured, and about 60% patients, they do well, and they are considered as cured. But 40% of DLBCL patients, they progress despite of all the therapies, and only about 25% of this patients who receive second-line DLBCL actually achieve cure, and most of the patients who progress from first line, they ultimately develop refractory disease, and they are difficult to treat. And we all know this, that patients who have low IPI, early stage disease, GCB phenotype, they do well, whereas patients who have high IPI, age more than 60 years, non-GCP phenotype, or dual expression profile, or CMYC BCL2, double hit, triple hit, or dark zone signatures, they do not so well, and they have low curability. So I'll be talking about mainly these two drugs, and polatuzumab is a potent MMAE conjugated to a 79B monoclonal antibody via protease cleavable linker, and in this we can see it is first internalized, then after lysis it leads to microtubule disruption, and which leads to cell lysis, whereas glofit is a novel CD20 CD3 T cell engaging bispecific antibody, and it leads to monovalent binding to CD3 and bivalent binding on CD20 B cells. So just few slides about the POLARIX trial. It's a phase 3 study evaluating POLA R-CHOP, RCHP versus R-CHOP in first line DLBCL. So patients who were previously untreated with DLBCL, aged 18 to 80 years, IPA 2 to 5, and ECOG status PS2 were taken. They were randomized 1:1 to POLA RCHP and to R-CHOP, and after 6 cycles, 2 cycles of maintenance R was given. Primary endpoint was PFS and EFS, and patients were stratified according to IPA score, bulky disease, and geographical region. So it is the only regimen which is approved in last 20 years that has improved outcomes in patients of DLBCL, and we can see from this chart that POLA
the 24-month PFS is 76.7% with Pola RCHP versus 70.2% in patients of RCHOP, which is about 6.5% better than the RCHOP arm. Pola RCHP demonstrated about 27% reduction in risk of disease progression, relapse, and death. We can see these two charts, two lines which are separating, but not so much to park a bus in it. And so investigator assessed PFS by CO subgroup. We can see that in the first cartoon, ABC type, Pola RCHP is more effective in patients who have this type, ABC type of expression, and the PFS at 2 years is 85% versus 56%. In GCB type, it is almost the same, 75-77%, and 87% versus 74% in unclassified type. So the benefit is mainly in patients who have ABC type phenotype in this trial. But Gaurav has spoken in detail about this, so I won't be talking about it. But in dark zone signature DLBCL, there is trend towards the higher 2-year PFS as compared to RCHOP, and we can see that the 2 years PFS was 75% versus 64%. And in patients with dark zone signature DLBCL who had GCB type, they represented the majority of patients who had double hit or triple hit. So for us, most important is double hit and triple hit as an adult hematologist. And in these patients, probably polatuzumab is going to be more effective. And the initial PFS benefit of Pola RCHP was maintained over 5 years. And we can see from this chart that the primary at 3-year PFS, it was 71% versus 64. 5 years, it was 64 versus 59%. This is NCCN guideline, and polatuzumab is there in front line. And apart from polatuzumab, we cannot see any other drug that I've been told to talk about. So next few slides will be about the adverse events. Most of the adverse events are like well matched in the two groups, and there is not much difference. So when polatuzumab was used with the DA-EPOCH and R-mini-CHOP-R, we will discuss what happened in further slides. And the problem is when patients of PMBCL or patients of double hit or triple hit lymphoma, in whom we are using DA-EPOCH-R, it's a difficult situation, and polatuzumab may be used, it may not be used, and mostly the backbone is DA-EPOCH-R. And in these patients, polatuzumab was added. This is a small study of 21 patients, and it showed that there was good PFS and OS at 12 months, and EFS was 72% versus OS of 94%. And in this 1.8 mg per kg body weight of polatuzumab was given in each cycle, and its dose was not changed, it was not escalated, and the dose of vincristine was omitted. So, but it's a small study, and probably going forward, we would be able to tell anything about it. There were 5 serious adverse events, 1 death from grade 5 sepsis typhlitis, and 1 grade 3 febrile neutropenia. There was 1, and grade 3 chronic perforation was seen in 1 patient. 6 patients had thromboembolic events, but they were all incidental. So safety was, like, tolerability was, well, it was fairly okay. Now this second study is a phase 3 polar bear trial in elderly or frail patients with the DLBCL, and it compared R Pola mini CHP versus R mini CHOP, and the results are not there. It is still under trial, and I have looked at the net and studied, but there was no further information available. So it included patients of DLBCL more than 80 years or 75 to 80 years patients who are frail. Patients were randomized 1:1 to either receive R mini CHOP or R Pola mini CHP, both for 6 cycles. Replacement of vincristine with polatuzumab R-CHOP was not associated with more grade 3, grade 4 toxicity, risk of infection or neuropathy, so it was well tolerated. But what are the final results? It is we are still waiting for that. Now the third study that I got hold of is glofitamab and Pola RCHP in patients with previously untreated DLBCL patients. Again, it's a phase 1B study with small number of patients. 24 patients were enrolled in this study, which were, and median age was 65 years. 86% of patients had stage 3 to stage 4 disease, and median IPI was 3. In 17 patients, efficacy was evaluable, and after median follow-up of 5.1 months, CMR was obtained in 76.5%, and overall response rate was 100%. Again, the caveat is that it's a small study with less number of patients. In safety evaluable patients, grade 3 or more adverse effects occurred in 15 patients, and it was like serious AEs were reported in 12 patients, and it related to glofitamab only about 4 patients, which is 17% of patients in the whole group. And dose interruption due to adverse event was seen in about 5 or 21% of patients. Neutropenia was the biggest issue. So the next study is about zanubrutinib, polatuzumab, and rituximab EZR combination in elderly, frail, diffuse DLBCL patients. It's a Chinese study with like about 12 to 12 patients, and till the time of publication, 4 patients had achieved CR, and this protocol can be used and it's workable in patients. Now zanubrutinib is also available, so we can use this combination in patients who are elderly, frail. Probably in years to come we will or months to come probably we'll have more data about this. And then use of CAR-T as first line. It's from Zuma 12 trial, a 3-year follow-up analysis of first line axi-cell for high-risk DLBCL patients. First line axi-cell demonstrated about 86% of CR rate, and 3-year PFS rate was 75% in efficacy evaluable patients with high-risk LBS, diffuse large B-cell lymphoma. New malignancies and non-relapse mortalities were rare, and it occurred in about 4 and 2 patients each, and none was related to axi-cell. So there are very few studies which are focusing on use of glofitamab and CAR-T at front line. Probably going forward, we will have more options in elderly and frail patients of DLBCL, in which there are lots of things to be desired. To conclude, a 5-year extended follow-up of Polarix showed consistently sustained and significant PFS and DFS benefit in patients who are getting Pola RCHP versus R-CHOP. There were fewer subsequent anti-lymphoma treatment needed with Pola RCHP versus R-CHOP. There were numerically fewer deaths, especially lymphoma-related deaths in patients on Pola RCHP. Outcomes were favorable across the subgroups, but it was more so in patients of dark zone signature and higher IPI. Safety profile was good, and further use of bispecifics and CAR-T will become more clear in years to come. With that, I will end my talk, and any questions are welcome. Thank you.
Thank you, Dr. Gaurav, for a nice presentation. So I know this is an evolving topic, and I don't think we have any correct answers right now, which is a preferred agent in first line. But do you have any personal preference based on this data in between polatuzumab and glofitamab or CAR-T cells, if it is asked?
Glofitamab I have not used. Probably Dr. Prashant has used. He may be able to answer. I'm using polatuzumab as frontline in few of my patients, and response is like it's fairly good. But glofitamab I have not used.
So I can just share my experience with Glofit. I've used in 6 odd patients, and 3 of these have been post CAR-T relapses, and others were ineligible, auto or CAR-T ineligible, and they out of these 6, I have 1 long-term survivor. So he has completed 12 cycles and doing well. But what I felt was, at least in the post CAR-T patients, the responses were there, but was short-lived. There was 1 patient where I used Pola Glofit, and she had a response of about 10 months, and then she progressed, and in between
the program closed down and we could not get more Gluffit to complete the whole course. So it is an active drug, and what the data is showing is that those who achieve CR at the end of 12 cycles, 80% of those will sustain their CR, and they will last long, probably 1 or 2 years. And but the more interesting combo, which which seems more active to me, is the Gluffit Gemox with the StarGlow study, and then PolarGo, and then Sunmo, where mosunetuzumab has been combined with the polatuzumab, and these have shown very durable plateau. And some of these, especially in the Sunmo study, 1/3 were post CAR-T relapses, and out of those, 75% were CAR-T refractory. So it seems like a very active regimen post CAR-T, at least. So, and the plateau is looking right now as good as what CAR-T plateau looks like. So it is something which is kind of going to be neck and neck in future probably, and these are very active drugs. I'm not sure how they will stand the test of time in the upfront setting.
Line, yeah.
But in relapses, they have very good activity, especially when Pola and one of these bites, either Gluffit or mosunetuzumab, is combined. So they have CR rates as high as about 58-60%. And the toxicity, Gluffit, reasonably well tolerated. It doesn't have many high grade toxicities. The CRS is generally low grade, and generally with the obinutuzumab, which is given on cycle 1, day 1. And after that, the step up, ramp up dosing Gluffit. So it doesn't cause much problems.
Thank you.
Thank you, sir. Thank you, chairpersons. We again begin a debate on upfront BMT versus upfront CAR-T, and for which I would like to invite Brigadier Sanjeevan Sharma, who is a professor and head at AHRR, and Dr. Farhan Naeem, who is a senior consultant at Max Hospital, Delhi, to moderate the debate. Welcome, sir.
So I can't find the co-chairman, Farhan. Okay. So, you know what? I was a JR medicine. I'm talking now 1998. I think some of you may not have been born, but in 1998, I was a junior resident in medicine department FMC. So they were organizing, some onco department had organized a conference, and as JR medicines, we are used to do all this stuff now. Do this, look after the delegates, be at the reception and all. So one of the debates which I remember was that should rituximab be used upfront in DLBCL, or should it be used only in relapsed refractory setting? So this is 98. So this is the context of what we are kind of putting. So similar is, every therapy, how it comes in the relapsed refractory setting and how it keeps on moving, and it moves through so many of these debates. So we are now on this track 2 of DLBCL. We are having a debate on whether we should use upfront transplant or upfront CAR-T. So to start the proposition, I'll invite my very dear friend, Dr. Pawan Kumar Singh. We were colleagues together at CMC Vellore. So Dr. Pawan would be speaking for upfront BMT. Currently, Pawan is the group director at Yatharth Super Speciality Hospital, Noida.
Thank you, Sanjeevan sir. So, I've been given this assignment to propose for upfront ASCT. So when we talk about BMT, so it is understood that it is autologous bone marrow transplant only. We are not talking about allogenic upfront. So we know that in DLBCL, so around 40% of cases are relapse refractory. So out of which 50-50 are primary refractory and relapses. And relapses do come early. So most of the relapses happen within 1 year of treatment. So now comes the point that who all are at risk of relapse or refractoriness of the disease when it comes to the first line treatment. So these are various parameters in which we can see that stage, performance score, LDH, extranodal disease, and IPI score. These were found to be significantly associated with the risk of relapse. When it comes to PFS and overall survival, age-adjusted IPI after when the treatment was as second-line therapy. So we have seen that patients were divided into three categories: low, intermediate, and high risk. So based on that, these are the we can see that progression PFS and overall survival these settings. So prognostic factors which are important for relapse refractory DLBCL, primary refractory disease, and early relapse. So in these situations, we know that the outcome is dismal. So is there any way by which we can recognize these patients and we intensify our therapy so that we can, whether it comes to autologous transplant doing upfront or CAR-T cell? This is the whole topic. The topic of the debate today is. So I will try and justify autologous bone marrow transplant, which I've been told to. So in the REFINE study, so the prognostic factors, so these are the group of patients, ultra high risk patients. These were at risk of refractoriness or at the risk of relapse. And we all know that when it comes to relapse, the outcomes are not good. So high IPI score, double hit or triple expressor, or high risk, when there is high risk NGS like TP53 or a dark zone signature, these are considered as the high risk. So what can be done for these patients, ASCT and CAR-T cell therapy? Now I will try and find out if any evidence is there. So yes, there is some evidence is there about autologous bone marrow transplant. So when we talk about, this was the meta-analysis of so many studies, and out of these 4 studies were found to be significant, and all these four studies, we can see that the overall survival in the upper column, we can see that upper row A, the entire group, and B in the high risk age-adjusted IPI group, we have seen that all these studies, they favored autologous transplant in terms of overall survival. When it comes to progression-free survival, then again entire group and the patients at high risk, here also we can see that 2 studies were found to be significantly associated with good outcome even autologous bone marrow transplant. Though when we see that treatment related mortality or the treatment related morbidity, it was seen more in upfront ASCT. So summary of this analysis was in the rituximab era. So sir was talking about in 98, we were discussing about rituximab to be used upfront or in relapse refractory setting. So most of the studies, if we see when they compared autologous bone marrow transplant, it showed benefit in those in the pre-rituximab era. So some studies showed in the rituximab era, in the SWOG study, we can see that high risk IPI subgroup. So these were the patients who were at high risk of relapse. And the clinical prognostic biomarkers, we can see that which incorporated age-adjusted IPI, they are unlikely to define high-risk patients in DLBCL cohort. And some studies have also shown benefit according to the cell of origin. So the limitation of these studies is that these are not genomically, they were not defined as high risk, whether it comes to MYC or BCL2 expression or based on IHC. The SWOG study attempted about differentiating these high risk patients, but the number of these patients were less who went for autologous bone marrow transplant. So the molecular classification based on upfront autologous bone marrow transplant in advanced stage DLBCL. So here we can see that in non-ASCT group, the GCB patient did better because, but when it comes to the ASCT group, so here we see that even the non-GCB patients, they did benefit with ASCT. So then about the autologous bone marrow transplant, again in higher risk study. So this was the trial design, which included high risk patients as well. So here we can see that the EFS and overall survival benefit was there in the ASCT group. So first we need to define the high risk DLBCLs. In the REFINE study, it was found that these were the patient NCC and IPI high or intermediate high risk, then MYC translocation progression during first line of treatment, dark zone signature, TP53 mutation, triple hit or expressor. Then here again we can see that in with the DLBCL with primary treatment failure. So these are not visible, but overall survival and progression free survival, we can see that it was better in those patients who perform in which the autologous bone marrow transplant was performed as compared to the lower risk patients. So when it comes to the MYC associated lymphomas, again SWOG study. So here we can see that all patients, if the transplant was there, they did better. Now the other thing is what can be done for these patients. So my colleague Dr. Prashant is going to talk about the CAR-T cell therapy, upfront CAR-T cell. So right now, if I see whatever evidence is there, though it is not very significantly showing benefit, but still we can see that some studies, though the number were less, but still some studies showed ASCT benefit is there for these high risk patients where upfront ASCT can be done. When we talk about any trial related to CAR-T cell, Dr. Prashant is going to talk about, but this is the evidence he'll be talking about. But we can see the design of this trial. So again, this trial is comparing chemotherapy with means R-CHOP or DHR epoch with upfront CAR-T cell. Again, they are not comparing with ASCT. So there is, anyway, we'll be waiting for this data. So I will stop here. Thank you.
Okay, so Dr. Pavan, you can just take a seat on then after Dr. Prashant has had his word, then we can have a second. So to speak in favor or of CAR-T or rather against the proposition, let me invite Dr. Prashant Mehta. So as we are all aware, if you order a CAR-T, it takes time. So that is what Prashant's presentation is also taking that little bit of time. So we all got to be patient by the time CAR-T arrives. So, okay, in absence of slides, can you just, your key points, what you believe are in favor of CAR-T?
Start that
Yeah,
okay, but I'll just
while they're trying to fix up.
yeah, that's okay. Yeah. So what I understood from the topic that we are debating between CAR-T and auto.
Upfront, so in a relapse, so when a relapse, DLBCL comes, so maybe for first relapsed.
Yeah, so that's what
offering CAR-T.
Yeah. So my first slide in itself was that in academia there are no debates. Actually, science is so grey that it can be a discussion, but less of a debate. So that's what my first slide was. So I listened to Pawan, what Pawan had to say, and he was very right in many of the points he made. Maybe I can give you the deck and then you can. Slideshow. I can take 2 minutes to give them the deck and then they can project. Maybe the next speaker can speak in meanwhile.
Pawan has already made his point loud and clear. Yeah.
Yeah.
For high refresh. No, you can talk.
Yeah.
Are you able to see your slides? I think they must be all pictorial slides.
So just a quick announcement to make. All quiz participants are requested to gather in the preview room at 4:30 p.m.
So, Dr. Devyani, is Dr. Rahul here? So, because I was thinking that till the slides, in case they are unable to fix the slides, because the track is still on DLBL. So, if we can have the panel based discussion on the DLBCL by the time the slides are getting. Hmm? Yeah. So we can come back and listen to Dr. Prashant's this thing. Sure.
So moving on to panel discussion, I would like to invite Dr. Rahul Naithani, who is a Chief Hematology and BMT at Artemis Hospital, Gurgaon, to chair the panel. Welcome, sir.
Then
No, it's okay. It's very different. Nice work. Yeah, sorry for the confusion and delay. So I think we go back to the debate now. I had a few slides. Slido is a platform which can, allow surveys and can connect to the internet. So, but that won't be possible now. Right. So this was the slide I wanted to project, that in academia there are no debates. Actually, science is so grey that we better discuss, not debate, because we cannot choose side there in science. So that's what my primary thought was. So, but why this debate still exists in 2025? Because there are RCTs also favoring CAR-T in the relapsed refractory setting, and there are real world registries which are saying that ASCT is also good enough in some subsets. And the molecular data from Zuma-7 post-hoc analysis says that some subsets don't benefit from CAR-T and they benefit more from chemotherapy, which is quite odd for many people, and because CAR-T is so high. So I'll just try to go through the available data and we will just think over it. So we are talking because two RCTs were positive, but one was negative, that was Belinda. So Zuma-7 transform both positive, transform OS advantage, Belinda, nothing there. CAR-T did not benefit. So what are the reasons for that? We will dig into that. Probably related to the delay in the infusion, the lot of chemotherapy, tons of chemotherapy which is given in Belinda. So logistics came into play there. So that, and then we'll touch upon the registry data also. So you can see here, transform Zuma-7, transform showing OS advantage, very limited bridging, very little chemotherapy there. But Belinda, lot of chemotherapy and delays, did not show benefit. So Zuma-7, the benefit is the Kaplan-Meier curve, big difference there you can see. The benchmark CAR-T beats autologous transplant. So this is a primary study which takes us to this debate and discussion. Belinda did not work. Probably logistics came into the play, but that's also post-hoc analysis, and we don't know what exactly happened. Although there is some internal data which says that there's some manufacturing difference during Belinda, which nobody really is clear about. So this is a series actually, Dark, on Netflix. Many people may have seen. And it actually tells us one important point. Sometimes we have to ask the right question, and sometimes we're not asking that. So Dark was a series where the protagonist was actually lost and he disappeared. But people were asking, where is he? But it was not where. It was a series based on time travel. The question was actually, when was he? So if we're not asking the right question, we won't get the right answer. So the question here is not auto versus CAR-T. It is when auto and when CAR-T. If we ask that, we'll get the right answers. So this is a funnel which I tried to make, and you will see that more patients are CAR-T eligible in the end based on fitness and many other criteria. So workup in itself is feasible for 60-70% for CAR-T. But for auto, eligibility drops. It is 1/3 only, and out of those, maybe 10-20% will again drop out. So the funnel shows us that more patients are CAR-T eligible. So those who are not eligible for auto cannot go for auto. So that question ends there. But they could be CAR-T eligible still, because the stringency with the organ function and so many factors is lower there. So this is the data which actually challenges why CAR-T for everybody, because those patients who get a CR, PR, post salvage, they are going to do okay with autologous transplant if they're autografted, even when they're early relapsers. So this is how we come to this debate. But again, some biases, because this is retrospective registry data. Those are RCTs. It's very difficult to challenge RCTs with registry data. Again, same CIBMT, registry data. Little biased, but yes, showing the same, that if you are in CR, PR, you can still do autograft and get away with a decent survival, as good as or probably better than CAR-T. So, but this is why registry data sometimes favors auto, because it is biased. Patients who are eligible, fitter, they get autologous transplant and they do well. So, but there is a problem. Those CAR-T patients generally will have a higher burden disease. They will be different in profile.
So this is how that in 2025 we position that early relapsers we tend to push to CAR-T. Those who do not respond to salvage we push to CAR-T, or those who do well who are in CR we push to auto. So this is a pitfall in the current CAR-T data sets also. We don't know what went wrong in Belinda. So there's a doubt there. Are all CAR-Ts equal or not? Maybe some are not, some are different. So we don't know whether the CAR-Ts we have in India right now will fit in the same space. That creates a doubt in the mind. So selection bias in the registry data is a problem. Genomics, again, there is a post-hoc data from Zuma 7 where there is a phenotype called PEX, which is enriched in ABC. And this does not do well with CAR-T. And you see here, they do better with chemotherapy, chemoimmunotherapy. So there is a problem. One subset is doing better with chemoimmunotherapy. And we have to take this into account when we do upfront CAR-T also. Because now people are talking about that. We will see that if you're not good with the molecular diagnostics, you may actually be giving CAR-T to people who are not going to respond. And they will do better with chemoimmunotherapy. So this is again a more evidence-backed decision-making tree, which I thought of. Maybe genomics could be incorporated there, and you could choose your patients better. These are some of the factors which will come into play when choosing CAR-T versus auto. And if you have no response to bridging or salvage, these patients are these patients are not good candidates for CAR-T as well. And if they're progressing on salvage, they are likely to do less well. But then we will have not better treatment options for them. So they will show inferior outcome with CAR-T. We must be aware of that. But they can't be autografted again. So age and other factors, elevated LDH, bulky disease, all this also is a factor when you're using CAR-T cell therapy. So again, choosing better comes into play. I think the Slido which will not work. I will need to go forward. I think you will need to move from there. Can you change the slide here? No. So some of my slides have disappeared from here. You can go forward. Go forward. These slides are not going to work. Next. So there was 2 cases here. I'll just brief upon those. So there is a case which I can just verbally say. This was a patient who presented to us with TFL, had been treated with Minda-R, and the epoch was refractory, had bone marrow loaded with disease, had leukemic presentation, had CNS involvement, and this patient was not responding to anything. There were multiple skin lesions. I had a picture there which is not visible now. But this patient, we did not know what to do, but we thought of using some salvage, and we used polatuzumab, venetoclax-based salvage, and GDP. And the patient had a PR after that. So what I wanted to showcase with that case is that these kind of patients are not the kind of patients who are going to do well with autologous transplant. So CAR-T has its niche. Autologous transplant has patients where you can use autograft, where you have patients who are in CR or PR post salvage. But these kind of patients will still need CAR-T. So that's where the question which you are asking, with auto versus CAR-T, or when CAR-T, we need to define better. Is it moving? If not, then I will end there. Thank you.
Dr. Rahul sir, to please come on the stage.
Namaskar. So Pawan has missed his chance of rebuttal. If all of us speakers would have, spoken amongst ourselves, my number of slides from 68 would have gone down to 15 because much of it is already discussed. So we have set the stage right with all the theoretical context and trials around the lymphomas, and now we will discuss the nitty-gritty, the everyday issues that we face in managing these patients. So we have a expert panel here. If I can have my panelists here. We have expert panels from 3 states, Dr. Chitresh Yadav, Dr. Gaurav Dikshit, Dr. Nitin Gupta, and Dr. Satyaranjan Das. The names are in alphabetical order. This session is sponsored by Roche, and at least for the moderator, there is a honorarium. So we'll set the ball in motion. This is basically a case, essentially a 48-year-old male patient who has a stage 4 diffuse large B-cell lymphoma, ECOG PS1 and IPI score 3. And in today's time with so much work in progress, the questions that we have to answer is, how do we treat this patient in November of 2025? Should we change the practices based on the previous 3-4 sessions that we have heard? And should choice of therapy be determined by the IPI score or cell of origin? So if I can start with Dr. Nitin. Dr. Nitin, how would you treat this patient?
So I think this patient, may I see the previous slide? So known GCP subtype, that means ABC subtype and BCL2 and MYC are positive by IHC, but FISH is negative. So it is not a double hit lymphoma. It is a stage 4 large B cell lymphoma with double expression on IHC. So it will behave worse than a normal DLBCL, but little bit better than a double hit lymphoma, actual double hit lymphoma. So normally, so what we are doing till now was R-CHOP, irrespective of large B cell lymphoma. In elderly infirm, we normally mini chop, R-CHOP. So R-CHOP was our standard till recently. With the availability and with the recent availability of polatuzumab, we can just, in this particular case, we can try adding Pola R-CHOP type of RCHP type of protocol.
Dr. Gaurav, you had presented the the data on Polarix trial. Would you want to treat this patient differently?
I think Dr. Nitin is whatever he's saying is the same. My approach is almost the same. I will most of the times I will start with R-CHOP, and after discussion, if patient has no problem with finance and if he's okay to take 5 to 6% of benefit with all the costs involved, then probably I will give him option of polatuzumab. And yeah, and DA-POC-R, if which have been positive, I would have given him option of DA-POC-R also, but not in this case.
Dr. Chitresh, would your decision be based on IPI scoring, or will it be a blanket R-CHOP for all?
It has been seen, if the IPI score is high, the outcome with R-CHOP is not very much favorable. But here IPI is intermediately high. So in this case, my choices were also similar. But as there was the abdominal wall was thickened, I also had a doubt that in first cycle the patient may have a perforation. So I may decrease the slight amount of dose in first cycle, and then maybe I will discuss Pola RCHP and R-CHOP, but in first cycle I will slightly go with the same.
Dr. Das, sir, how important is the cell of origin in defining initial treatment?
I think it is important. I think already Dr. Gaurav had discussed that also. Not only cell of origin, even the molecular signature is also important. Today, if we are talking of treating the disease, we have to treat it correctly. And in this particular index case, if you see, he has got high IPI scores, he has got cell of origin is ABC or non-GCB, whatever you call, and the disease load is high, and the patient is requires what is the most recommended and where we will get the most better outcome. Of course, the molecular signature is not there completely, but this is just again it's not a double expressor also, but still we should get a molecular signature, and most likely, yes, correctly in this patient we will like to start with Pola RCH.
So one more disclaimer, this session was sponsored by Roche and the slide set has been provided by the Roche. So most of the case details may be where, a particular regime may be favorable. So this is the basically Polarix trial which compared R-CHOP versus Pola RCHP. Dr. Dikshit has already discussed about it. There was a distinct PFS advantage, even if small, but there was a distinct PFS advantage in this. And the complete remission, even after 5 years, the people who attained CR, that CR was maintained even at 5 years follow-up in the Pola RCHP. So the overall survivals were not different. So we were discussing should the choice of therapy be determined by IPI score. Much of it has been discussed in this. So I'll quickly run through it. So we all know that higher the IPI score and with the standard chemotherapy regime, chemoimmunotherapy for all, the outcomes are different based on the different scores. This Dr. Dikshit has already shown that patients who had IPI score 3 to 5. Pola RCHP, this was the group where polatuzumab has advantage. So if we are tight on funds and there's a limited number of patients that one could treat, then probably lower IPI is something that one would want to avoid. The another question was, should the therapy be based on the cell of origin, GCB versus non-GCB? Now this is a work in evolution, work in progress, and this is still evolving, dynamic. DLBCL classification is still evolving. The previous data, even the Polarix data is based on the previous types of the way genetic tests were done. Now there are more refined tests available, and nowadays based on the cell of origin, their lymphogen, their clustered dark zone signatures. DLBCL is basically a heterogeneous disorder, and nowadays, as Dr. Gaurav from the lab side had talked in the first session, that almost 95% of DLBCLs can be fitted into at least one type of molecular classification, and this is where when we say polatuzumab favors ABC. Within ABC also there were two subtypes C1 and C5, and it is the C5 molecular group which benefits out of it. This was the 2-year data of Polarix where patients with ABC were faring better than other. In GCB and other unclassified types, there was no advantage of polatuzumab. This was again a 5-year follow-up data. This has been shown by Dr. Gaurav. I'll skip it. Again, people who had dark zone signature, and that dark zone signature is essentially the germinal center B cell lymphomas patients. Pola RCHP has an advantage. This is a second case where this 61-year-old female with a newly diagnosed DLBCL. Basically, an aggressive lymphoma, Ki67 is more than 90%. BCL2 and MYC are positive. So I can again start with Dr. Nitin. How would you treat this patient currently? I can go back to the case.
This patient has a double hit lymphoma. The fish is positive for CMYC and BCL2.
So we can take it as a high grade B cell lymphoma.
And 61 years female. Okay. PS is 2. So normally till we should have given dose escalated R-CHOP, DIPOC protocol rather, and we will discuss that the benefit of adding polatuzumab in her case as well. She has a PS of 2. Maybe DIPOC will be a bit more toxic for her. We can rather treat her with Pola RCHP type of protocol.
So again, there are different studies, reporting the outcomes of high-grade B-cell lymphoma, and people have used various regimes. Earlier, DIPOC-R was in, use, but this CalGB data showed that the outcomes of R-CHOP versus this was different. Polarix subgroup analysis at a 5-year, again, it's a post-hoc analysis. It did show that patients who had a high-grade B-cell lymphoma, they had a slight advantage over an R-CHOP, and again, at a lesser toxicity. This is a patient, and I can summarize this patient basically an elderly with a diffuse large B-cell lymphoma and has some comorbidities. So how do we treat these patients? So Dr. Gaurav, do you do CGA in your clinical practice? Comprehensive geriatric assessment in these patients for fitness of therapy?
I'm not doing in my clinical schedule, but yes, we should do it, and probably that will help us in giving appropriate therapy. In these patients, so he's an elderly male and without any double hit signature. So our mini chop would be my preferred option because I think patient had comorbidities also. And another regimen that I would consider is the ZPR regimen, which I discussed in my talk, zanubrutinib, polatuzumab, rituximab. So that was looking very promising, and toxicity also looked less on the face of it. probably going forward in next 6 months to 12 months, we'll have more data about that. So my option would be our mini CHOP followed by these kind of alternative regimens.
Dr. Chitresh, any difference? Elderlies with diffuse large B-cell lymphomas.
So, sir, elderly patient with PS, I think you mentioned was 0. So maybe a highly bedridden patient. So in this, I don't know whether sometime mini R-CHOP is also very difficult to give. So rituximab plus lenalidomide or even RCVP or I'll say BR is my treatment of choice in this.
That's a. How would you treat an elderly unfit DLBCL?
Yes, but here I will like to add polatuzumab, though it will not be pola RCHP as a whole, but yes, there will be reduced doses. But elderly person, I will like to add polatuzumab because of getting better benefit with a lesser chemotherapy.
So if you looked at the 2-year, follow-up data of POLARIX, age was an important marker. The people who more than 65 years were the one who were benefiting out of this. At 5 years follow-up, that age discrimination has lost its value. However, you can get benefits of the POLA RCHP with probably lesser toxicities. So these have been discussed. We'll change the gear and move to now the relapsed refractory DLBCL. We know once a patient's relapsed, they have a poor outcome, and earlier, the primary purpose was mainly some kind of palliative therapy. I'll start with Dr. Das sir. How do you define refractory DLBCL?
Refractory DLBCL, those who are either relapsing within 3 to 6 months or even not achieving a remission with optimum treatment.
Right.
So that's that definition we still follow.
Kind of.
And early relapse, yes, is by 1 year if the patient relapses, it's early relapse.
Dr. Chitresh, how would you define rituximab resistance?
So any patient who is progressing on the treatment may be considered as resistant to rituximab, or if a patient lost the response on the treatment, I will consider as a resistance.
Yeah, so there is no theoretical definition available for rituximab resistance, but this is a functional definition available and it is presumed that majority of people who respond are not necessarily chemo resistant, but they are rituximab resistant. So when you look at the NCCN guidelines for relapsed refractory DLBCL, it does not say R-ICE, it says ICE plus minus R, ESHAP plus minus R, because if you are relapsing within 6 months, probably there is no point giving rituximab there. So we know that the treatment is evolving, and Dr. Gaurav, what would be a first line salvage therapy? Will it be different once a DLBCL relapses in a young versus old patient?
So mostly in younger patients, I would use ICE versus maybe RDHAP, and in elderly, GDP is my preferred option as the front line.
Any role of polatuzumab here?
Pola BR I have used, but unfortunately my experience has not been very good and there was not much response.
Dr. Nitin, how would these patients fare once they fail the first salvage regime?
So again, the patients who are failing the first salvage, so that means the patient have failed either a RGDP or DHAP type of protocol, or outcome is again dismal prognosis in these patients.
So of course we want to go with the CAR-T and all, but such an option may not be available for all, and there is data available that people who are failing one kind of salvage regime, a fraction of them do respond to a second kind of a salvage regime, and if you are able to consolidate them with autologous transplant at this point of time, then they benefit. So how do we sequence therapy? I think the previous debate also in the previous sessions have said if you have a bad biology DLBCL, basically an early relapse within 12 months, you are probably going for a CAR-T kind of therapy. And if you have a relapse after 12 months of therapy, then probably you're going for a chemotherapy kind of thing. And this is where, earlier BR kind of regimes were used with the addition of polatuzumab in these patients. The outcomes of these patients have certainly improved. These are the datas of Pola BR versus different cellular therapies. This has been discussed that not all CARs are same. Some CARs are very effective and some are not working. Will CAR-T replace autologous transplant? I think previous debate has kind of tried to answer this question. I would just want you to run through this and autologous transplant versus CAR-T therapy for relapsed DLBCL patients who are in partial remission. And again, as Prashant said, with a caveat that this is a retrospective data. And actually, in this data, this was a large data. Who attained some kind of remission. These are the ASTCT recommendations for CAR-T versus this. Now, Dr. Das, if a patient is intended to receive CAR-T and in the meantime did receive some kind of therapy and attained a CR, would you still go ahead with the CAR-T?
Sorry, what?
So, patient of relapsed lymphoma, you want. So there is a data that if one attains CR in this situation, CAR-T actually leads to even better outcomes if the patients are taken for CAR-T in these situations. I'll skip some of this because Dr. Gaurav Dikshit has already discussed difference between CAR and BITE. We can skip for now. Dr. Nitin, when do you consider allogenic transplant in relapsed lymphoma?
So again, relapse refractory patient relapse after autologous transplant, CAR T cell not option or CAR T cell failed patient, those can be considered allo.
Yeah. And the patients who have persistent marrow disease where you think auto may not be feasible, you may not get an adequate stem cell yield. Novel agents in DLBCL have been already discussed. Different agents have been talked about. I think we are reaching our conclusion. So all of us are aware of this chart, when to go for a auto transplant kind of thing, when to go for CAR-T. The lymphoma classification is still in evolution, and we may see that a lot of the data that exists today may not be relevant maybe 5 years down the line in light of this thing. Having said that, we know that after at least 2 decades after rituximab, it is the polatuzumab which has come, which has provided some PFS advantage on the backbone of a rituximab based regime, at least in a fraction of patients. If we are able to identify that subgroup which is actually likely to benefit from polatuzumab, we will be able to use our resources even wisely. With this, I conclude this talk, and thank you very much, my expert panelists.
Thank you, everyone, for the great panel discussion. Because myeloma therapy changes every year, I welcome Dr. Pankaj Malhotra, who is a professor in head hematology and medical oncology at PGI Chandigarh. He'll be joining us through Zoom. And to chair his session, I invite Dr. Neeraj Kumar Singh, who is a hematologist at Beer Hospital. Welcome, sir. Hello. Good afternoon, sir. Yes, sir. Yes, definitely, sir.
versus the other. If you look at the PFS of 8 months, was 68% of the drug, whereas 84% of patients were surviving at 2 years. And when you look at the sustained mRNA benefit status, it was 90% versus 5%. So all this are all a better complete the status of the sustained mRNA status. Now this is progression of survival restriction. So there are plenty of writings by most of the but I'm from this paper which is looking at the systematic development of what extending the myeloma patients. And I hope this is quite possible. So if you look at the interventions, there are 1, 2, 3, 4, 5, 6, 7, one side of the it's the fourth way, which are looking at impact versus quantitative use. And most of these are on the case of trial. And very good lots of in this case, in this analysis. And whether it's taking more extensive transaction or not. So except generally the ones that the rest of the whole of them, those which the graph the stem cell transaction. And if you look at the stories there are a lot of very systematic you'll see that so that is where all is the so the inverse now for the of over. And this is one of the aspects of progression to survival transplant management and transplant patients with gamma and in this they have tried to monitor of these patients how long these patients are going to survive. This is prevented by this EMN complex at 1.5. And in the first time when this monitoring analysis, they look at the data and it was going up to 21 hours because we are doing for the two payments also. And we are looking another trial, sequence trials, because the transplanting patients. So this was going up to 10 years versus 5 years. Meaning thereby that this is what our protecting survival of this communities. All so patient who is diagnosed with multiple myeloma only followed by non-transplant, followed by development. This chance of first biopsy happening system, which means here almost those are parties as part of a normal like means the right of principles and specific processes water is better than the quick now what about transplant essentially have balance which are needed versus and the versus coordinate. So we try to have no design with the versus coordinate. And here also look at the overall strong rates or SDRs are much better than coordinate versus fixed. And survival of these treatments more than versus coordinate. Almost close to being behind this time. And this is the overview of BMS from in 2024 when we have the Registry is good of 10 years to these statements. Here, I would just like to say the last time patients are sometimes and for point. The other side is and I would just like to say one system as published Mexico policy. It's on and here versus length and they have close to 400 patients for 95 regimen again, they have shown that if you use this regimen of Tara Len as a good PFS and an OS, then you can spare dexamethasone. We know that dexamethasone use is associated with a lot of infections and complications. And the forest trial favors a Len-Dara regimen than over Len-Dexa regimen. So in this trial, they have shown that Len plus Dara is better than our Dexa plus Len regimen. So you can use this regimen in those patients who are kind of frail. So concluding on this, for all newly diagnosed portable patients of multiple myeloma, quadruplet improves the PFS as compared to PT. Now, we know that DARA being a costly drug in Indian setting, most patients cannot afford DARA. Then what is the treatment regimen for those patients who cannot afford DARA? And here I would like to take help of two studies which were again published in New England Journal of Medicine. And first is the IFM 2009 studies looking at a VRD regimen and the transplantation, what happens to this patient. And I would just like you to focus on the kind of a PFS when you use an RVD or a VRD regimen. So in these patients, if you look at the RVD alone versus patients who had undergone a transplant, look at the kind of a complete response, 48%. Obviously, post-transplant, this is better. But we are, for knowing about patients who are on VRD alone, what is the kind of a complete response? So it is close to 80% or so, and even MRD negative status is 65% or so, which obviously improves post-transplantation. And this is the difference between the PFS. The PFS obviously is better patients who have undergone a transplant versus patients, and the overall survival is obviously not different because of the salvage therapies which are available. So the patients who are receiving a VRD therapy plus transplantation obviously has a longer PFS than the RVD alone therapy. The other regimen, the other trial which I want to show is the determination trial, which was published just a couple of years ago. Therapy, transplantation, and maintenance therapy. This is called determination trial. Here, the patients who again received 5 to 8 cycles of VRD regimen and followed by stem cell mobilization and received transplantation. So here again, if you look at the PFS, there is a difference, but overall survival, there is no difference. The patient who actually received VRD regimen, the 5-year survival rate is close to 80% of them. That means even if your patients are not able to afford DARA, and if you are able to give VRD regimen, they have a good 5-year survival. And if they undergo a transplant, that would obviously make a difference. So lessons from these trials are the triplet followed by auto transplant leads to improved PFS, and 80% of patients survive more than 5 years, even if you are using VRD regimen. So try to convince patients for auto transplant if quadruplet therapy is not possible, which basically means that if the patient received a VRD and if they receive a transplant, they obviously have a very good 50% chance of surviving more than 5 years. And this is the what I have said in the last. Now we come to the consolidation. What is the role of transplant, which I have already shown you in my previous slides, that a transplant leads to a better PFS, better CR rates, and better MRD negativity. But sometimes, we do ask this question, who should get a transplant in the future? Somebody who is frail and intermediate, where, you can use a non-transplant regimen, prioritizing tolerance. Intermediate, consider defer transplant if MRD is negative, and avoid if persistent frailty is there. Whereas the patients who are fit, is MRD positive, they should definitely undergo a transplant. Somebody who is high risk, any MRD should also undergo a transplant, whereas patients who are standard risk and MRD negative status, there, you can think of postponing the transplant or avoiding the transplant in future. So this is called risk adapted strategy, basically looking at what the risk may be different for each patient, and that you have to assess clinically in a given situation. So again, concluding that patient who cannot afford daratumumab in our setting but is fit must go for an auto transplant to improve his or her chances of progression-free survival. The other patients who are functionally high risk are renal failure, extramedullary disease, plasma cell leukemia, patients. Now we go to the last part, the maintenance therapy, and the question is whether we use singlet or doubling, and what should be the duration of maintenance therapy in these patients. So I'm taking help of a couple of papers. This paper is looking at, I'll just take one more minute. Sazumib, lenalidomide, and dexamethasone. This is phase 2 trial where they actually have shown a doublet maintenance therapy is better than using single, especially in high-risk patients. This is another paper which I have actually looked at the 1,000 consecutive patients and from 2012 to 2016 who were received RBD regimen and a transplant. And here they have shown that high response rates, close to 90% of patients, and this is a real-time data, real-life analysis, and is adaptive maintenance. Patients who are high risk receive adaptive maintenance, and these patients doing better. And the meta-analysis of lenalidomide maintenance after auto-transplant was published in JCO long back, also showed that these patients do better. They have a better PFS than those patients who are on placebo or so. So finally, I would just like to invite you on the Image 8th Annual Conference, which is being held in Kochi from 9th to 11th of January. So you are all welcome to interact with all the international faculty which is there. And somebody who is interested more in reading myeloma, this is PGI textbook of laboratory and clinical hematology. And the resident who wants, complimentary copy, I have a couple of them and I can give for reading. So last questions and answers in newly diagnosed multiple myeloma patients, triplet versus quadruplets and consolidation and maintenance. So quadruplet win over triplet if the patient is affordable. A transplant is must for transplant eligible patient. Otherwise, you continue the induction therapy for at least 8 to 12 cycles, followed by maintenance therapy, which should be used as an intermediate if the patient can tolerate. And the duration of maintenance generally is 5 years or sustained MRD negative status. Thank you very much for your kind attention. Again, thank you the organizers for organizing this my talk through online meeting. Jai Hind, Jai Bharat.
Thank you so much, sir. Thank you also that you agreed to join online live at our request, and we were also very heartbroken when we heard your flight is cancelled. Are there any questions? So, sir, if there are no questions right now, if we do get questions, we will send you over email. And thank you so much again for joining live. Thank you so much.
Sure. Thank you so much. Thank you.
So without further ado, we will begin our next session. And this next session is advancing Hodgkin lymphoma care, the essential role of ADCETRIS in every stage. In the sense, this session is sponsored by Takeda. For this, I would like to invite Dr. Manisha Jain as the chairperson and to talk and to give a lecture on the same, I would like to invite Dr. Gaurav Dixit, who is the head and a very eminent clinical hematologist we all know at Artemis Hospital, Gurugram. And he needs no introduction, but I will not take your time away. We can start.
Thank you, Dr. Rahul, again, Dr. Srinidhi, for a nice intro.
So I have also shared one survey on the Hall A faculty group for ADCETRIS, which we just made about the use of brentuximab. So if everyone could just fill that survey, we will have some insights on how the brentuximab has evolved in clinical use.
So I will be talking about role of ADCETRIS in Hodgkin lymphoma, and now it is being used at practically every stage. And what is the data about it? I'm going to discuss in my further slides. This is the disclaimer. Slides have been given by Takeda. So I'll be talking about these three settings: frontline Hodgkin lymphoma, then relapsed refractory Hodgkin disease, and post-ASCT consolidation. First would be frontline Hodgkin. Incidence of Hodgkin lymphoma, as we all know, has bimodal distribution, and most common age is about 30-34 years and 75 years. survival outcomes for older patients of Hodgkin lymphoma are inferior to those of younger patients, and 5-year OS is about 90% in patients less than 60, as compared to about 60% in patients who are more than 60 years of age. So this group of patients are a problem, and we need to have some options for these patients. Treatment failure remains a risk, and despite high cure rates with the multi-agent frontline chemotherapy, it's about 80% in patients who are younger age group who have early stage disease, and among patients with the classical Hodgkin disease, 5 to 10% of patients will have primary refractory disease. 10 to 30% of patients they have relapse after initial response, and patients who have advanced disease and who are treated with ABVD, up to 30% of patients will progress or die within first 5 to 7 years. So again, patients who don't have this low risk disease, treating them is a big challenge in clinical setting. And now the standard multi-agent chemotherapy regimens, they are associated with higher risk of short and long-term toxicities, including endocrine dysfunction, and about 60% of Hodgkin patients post-chemo have hypothyroidism. Then fertility issues are there. The most difficult to treat and like very dangerous kind of toxicity is the pulmonary toxicity, which we all know about, and it's caused by bleomycin. It is interstitial pneumonitis and difficult to manage. Then there are some cardiac side effects which can be seen, and secondary malignancies, and some patients have cytopenias, and even mortality is seen in some patients. So there is an unmet need to reduce toxicity in frontline setting while maintaining efficacy of this treatment of Hodgkin disease. Etcetris plus AVD is an approved treatment regimen in frontline Hodgkin lymphoma, and we have multiple options going from ABVD to BCOP. Etcetris plus ABVD is one option which has now come up. There are a few other options like BRICAD and Nivo AVD, which is still not available in India, but probably going forward in next few months, BRICAD should be available. I'll be talking a bit about the BRICAD in my last couple of slides. So what defines our success in Hodgkin lymphoma? And our ultimate goal is to cure the patient, to increase overall survival, and Etcetris plus AVD aligns better with the overall survival driven decision making. And how it helps, we are going to discuss the data in next few slides. This Echelon 1 study is the landmark study of Etcetris plus AVD versus ABVD as frontline in treatment of patients with advanced stage Hodgkin lymphoma. Patient population was like more than 18 years, stage 3 to 4, ECOG 0 to 2, and it had more than 1,000 patients, and randomization was done with ABVD and Etcetris AVD. Now the important thing is that dose of brentuximab here is 1.2 mg per kg, which is slightly lower than 1.8 what we are using in the other settings. End of treatment CT PET scan was done and follow-up was done, and PET CT was done at cycle 2. Primary endpoints were median PFS and like OS was the main endpoint. Etcetris plus AVD demonstrated progression-free survival benefit over ABVD, and this is the PFS probability at 2 years. We can see that 82.1% versus 77%, and there was 23% reduction in modified PFS when BV-AVD was used as compared to when ABVD was used. Then probability of 6-year PFS was 82 versus 74%. 7-year PFS again 82 versus 74%. So the efficacy of Etcetris was maintained over the years during this trial, and statistically significant difference in favor of A plus AVD versus ABVD was seen at these endpoints. Now this slide shows about OS, and numerically there was a benefit at 6 and 7 years. So this is one thing that we can offer to our patients. Overall survival benefits were seen in a few major groups, like in patients who had stage 4 disease, OS was 94%, and 51% reduction in risk of death was seen as compared to the ABVD group in patients of less than 40 or more, less than 60 years of age. Again, a good reduction in risk of death was seen, 61 and 51%. Then patients who have extranodal disease, about 50% of reduction in risk of death was seen, and patients who have extranodal sites, more than one, the benefit was even more. And A plus ABD provides a long-term reassurance in survival benefit in patients in Echelon study at 7 years endpoint. So this is the observation from real world, and we all know that probably for us the most important factor is overall survival, and we are more worried about patient survival than anything else. And 91% of healthcare professionals considered OS was the primary factor in treatment of Hodgkin lymphoma. So this was mainly a perception study, and I won't go too much into it. So perception with A plus ABD was better in patients who had breaking medicinal disease, stage 3, stage 4. So all the patients who had high risk disease, probably the trend was more in favor of A plus ABD, using A plus ABD by the clinicians. So this slide summarizes where A plus ABD should be preferred, and in patients more than 18 and less than 65 years, patients with advanced stage 3, stage 4 disease, and patients with high IPI and more than one extranodal sites. These are the group of patients probably where you can offer A plus ABD as the upfront therapy. Now I'm going to talk about relapsed refractory setting, and this is an old study, SGN 35003 2012. It came in 2012, and this was post ASCT. When patients had ASCT failure, they received up to 16 cycles of etc. And key inclusion criteria was relapsed refractory Hodgkin after transplant, then age more than 12 years, FDG-AV disease by PET scan just before the transplant, ECOG 0 to 1. Endpoints were ORR and all these factors. So ORR was 75% in this difficult group with post-transplant patients, and 34% achieving CR. So that was a good number at that point of time. 94% patients achieved some tumor reduction, and majority of patients received more than 50% reduction in the size of lymph nodes. After 5-year follow-up, median OS and PFS were 40 months and 9.3 months respectively. And for this group of patients, again, this is a very good number. Time to response was 5 to 6 months. And so in relapsed refractory setting, where we can offer this drug in ASCT patients who are eligible to, who are post-transplant, relapsing post-ASCT, but patients who have more than 2 prior treatments, they are probably ineligible, and patients who have comorbidities, we should be very careful. So these are the set of patients where we can use. And now post-ACT consolidation Hodgkin lymphoma. This is a very important topic, and nowadays question is where to use post-transplant consolidation. And so disease-related, patient-related pre-transplant risk factors which may increase the chance of progression is we have shown in this slide, which is chemoresistance to salvage therapy, pre-transplant PET positivity, anemia pre-transplant, and B symptoms at diagnosis, bulky disease, more than one extranodal site, and more than one relapse with prior regimens, refractory Hodgkin lymphoma. All these patients are taken as high risk, and probably they require some kind of consolidation. So refractory patients and early relapsers they have worse overall survival as compared to the late relapsers, and 5-year OS in these two groups in patients who relapse early was about 50%, and in patients who have late relapse it was 73%. So early relapse is a high risk factor, and OS is reduced after ASCT if patients have received multiple prior chemotherapy regimens. Now, how to prevent disease progression or relapse after ASCT? These are the few questions which, again, we need to answer. What if risk factors are present? How to consolidate? And then this Athera study came. It was a phase 3 international multicenter double-blind placebo-controlled trial. And so this was a trial design. Primary endpoint was PFS. After frontline therapy, patients who relapsed, they were given salvage, and they received transplant. And post-transplant, patients were given either brentuximab or placebo. And so, and 5 year at 5 years, Etcetris continued to provide sustained PFS benefit. And in Etcetris group, it was 59%. Placebo group, it was 41%. And it was more pronounced in patients who had more than 2 risk factors. So risk factors were all this on the right lower slide. Maybe you can see this. This is the gist of this slide and study where to use Etcetris as consolidation. Primary refractory Hodgkin lymphoma who are relapsing early, who had partial response or stable disease, extranodal sites, B symptoms, 2 or more previous salvage therapies. All these patients should get Etcetris as consolidation. And peripheral neuropathy is one of the main problems with this treatment, and it was mainly manageable as compared to placebo. But it continued to improve over time, and 73% of patients they achieved complete resolution. So I won't go into this. So the last couple of slides, what about patients other than stage 1 or stage 2A? What about patients who have unfavorable disease, stage 3, stage 4, or unfavorable 2B? This BRICAD is a newer chemotherapy regimen, and this is the final study and final analysis of phase 3 GHSD ST21 trial, PET guided BRICAD versus escalated BCOP in advanced stage Hodgkin lymphoma. At 5 years, PFS BRICAD was 93% versus 90.6% in escalated BCOP, and PFS benefit in PET2 negative patients was particularly pronounced. It was 96% in BRICAD versus 92.4% in escalated BCOP. So it means that patients who have unfavorable disease, in young patients who are fit patients, probably BRICAD is one regimen to look forward to. And in going forward in next few months, it may be approved in India for frontline setting. All the like our guidelines now, they are recommending BRICAD as the frontline regimen. Other thing is that you can use it after ABVD. Suppose a patient has high risk disease, you are giving ABVD as all of us do. Then after 2 cycles, if patients are not responding, patient have PET positivity, at that point of time also you can use this BRICAD chemotherapy. So that's about it. And I would like to thank Takeda for this support, and any questions are welcome. Thank you, Dr. Rahul, again for this opportunity.
BRICAD will be able to hold its place because the data from UK lymphoma group does show a remarkable difference between ABVD, ABVD versus BRICAD. So what is your thoughts on that?
I think, Dr. Rahul, that's a very good question, and probably patients who have high risk disease, patients who have unfavorable disease, stage 3, stage 4, and who have B symptoms, in those groups, it should be of benefit. And patients who are young and who are fit, they should be offered this because response rates are kind of very good in these patients. And if you're using only ABVD, about 30% of them, they tend to relapse at some point of time. It is better to use best therapy available upfront when we are dealing with young fit patients and who have unfavorable disease.
That would be great. Thank you, sir.
Thank
you. BCOP regimen, right? I think my suggestion is if you use something in between, that might be tolerated. Yeah.
Only thing is neuropathy, and sometimes I have to reduce the dose, and sometimes, especially when you're using it internally, plus cytopenia is also a problem. But with GCSF, that has not been a major issue.
So GCSF can be utilized easily with when AVD?
Yes. I'm using in all the patients who are getting upfront and perfect Ventuximab. Thank you.
Thank you, Dr. Gaurav, for such a comprehensive talk. Now, next we have the panel discussion. I would like to call Dr. Nivedita. The topic of the panel discussion is CLL therapy in 2025, doublets, triplets, or de-escalation. The panelists, I'd like to request them to come on the stage. Dr. Rachit Agarwal, Dr. Nitin Gupta, Dr. Priyanshi, Dr. Ajay Sharma is there. Yeah, Dr. Neeraj Kumar Singh and Dr. Paritosh. I think there is. Okay. Dr. Nivedita. Yeah. I'll call Dr. Nivedita on the stage. Dr. Ajay, please join us. So, good evening, and thank you to the organizers for giving me this opportunity to be a part of this wonderful conference, and welcome on stage to my esteemed panelists. So, we'll just be talking about how we make decisions on management of patients with newly diagnosed CLL. It's, I think, the more choices we have, the more confusion I think is setting in. So, before we get into any serious discussions, just a trivia. Anybody would like to take a guess at who this gentleman is? Anybody? Nitin sir, any guess? So this is basically, this gentleman is Colonel Ogden Bruton. He described the BTK pathway in regards to X-linked A-gamma globulinemia. And this pathway has now become the pivotal pathway when we talk of managing CLL. So with that trivia, we move on to the first case. So this is a 72-year-old male with no comorbidities. He's reasonably fit, good performance status. He presents with abdominal pain. He first goes to gastro. The CT abdomen shows a huge mass, and when further evaluation is done, CBC shows normal hemoglobin platelets, but a very high TLC with lymphocytosis, which is confirmed to be BCLL on flow cytometry. FIT shows a deletion 13q, and an unmutated IGHV status is further up. So he's basically somebody who has a bulky abdominal mass. So I'll start my panel, and anybody can take this question. So when we encounter a case of CLL, what are the tests that we are now routinely doing? Dr. Priyanshi.
Yes. So if any cases comes, then we ask for flow cytometry in these patients. Apart from that, PET CT scan, LDH, beta 2 microglobulin, and along with that bone marrow tests also, and FIT for CLL panel we also ask for. So these are the routine tests which we do in CLL patients.
So are we doing Sanger sequencing to look for P53 and IGHV mutation status?
Yes, that too, along with that.
P53 should be included. Yeah. P53 and IGVH. So you have IGVH.
So because in Max of late we had a panel where we had a separate panel for Sanger sequencing for IGHV and P53. And are we incorporating CLL IPI in our clinical practice?
Yes, now Rai, Binet along with CLL IPI, all these staging we incorporate when we diagnose a patient of CLL, because it's important for prognostication as well, and we have to counsel the patient accordingly. So we use all the three, RAI Binet as well as CLL IPI.
So basically, CLL IPI incorporates P53, unmutated IgHV, beta 2 microglobulin, RAI stage 1 to 4 in age. And if we apply it to this patient, he would fall into the high risk category because of high age and unmutated IgHV. So do the guidelines currently recommend any treatment changes based on CLL IPI? It does predict a shorter time to next treatment, but does it influence our management decisions? Sir.
So this is a high risk patient who is actually, I don't know what is the age you said.
So 72.
72, high risk 72 patient. And it was.
So he had a bulky abdominal mass.
There is a bulky disease. And what about the hypermutation status? Is it?
So he had unmutated IgHV disease.
So yeah, so all these factors are adverse factors. So I think this patient will be better treated with BTKI like Brutinib if it can be given to him.
So of course, he is a high risk patient as we determined by CLL IPI, but the current NCCN guidelines actually do not recommend using this to guide our treatment decisions. But yes, if somebody has a high risk CLL IPI, definitely more stringent follow up has to be maintained, and possibly enrollment in a clinical trial is what is recommended. So some wisdom is still the same, some old is gold is still there, that our indications to treat CLL have not changed thus far. Although incorporating CLL IPI in our routine practice could be a good practice. So of course we would treat this patient. What factors would you consider while planning for a treatment? What are the goals of treatment in a 72-year-old? No comorbidities, otherwise reasonably fit patient, while we are designing a treatment or while we are counseling, what are the factors that we should consider and goals of therapy?
So I'm not sure what symptoms did he have, but
so he had abdominal pain.
So
yes.
That's because of the abdominal nodes that he had, so abdominal masses. So here the to control his symptoms, improve the overall survival. So that's the I think the single agent, if you use PTK, that would meet that requirement. So that is going to be the first drug of choice that I would choose to be given to this patient. Single monotherapy by ibrutinib if he's tolerating. But because ibrutinib has a little problem with the side effects like bleeding and all, so these days we find acalabrutinib actually much more acceptable as a single agent these age group of patients.
So are we routinely incorporating this discussion that whether the patient would prefer a continuous therapy versus a fixed duration therapy, because we now do have all the drugs available to us? Does that come into your discussion with the patient?
Actually, as far as I know, there aren't any head-to-head trials comparing the BTK inhibitors with the fixed duration regimens. So ultimately, it all zeroes down on the patient preference and the comorbidities of the patient. Considering his age, I think we didn't mention any comorbidity.
Not for this patient.
So
and it's a panel patient, so everything is available to him.
Right. So probably a single agent BTK inhibitor, probably acalabrutinib, long-term therapy would be a preferred approach from my perspective.
What about venetoclax with obinutuzumab? And any thoughts on that? Would that be a thing that would come into your discussion? Because now we have venetoclax and obinutuzumab is already there.
Need inpatient management.
Would you like to combine obinutuzumab with BTK inhibitor? Like acalabrutinib plus obinutuzumab?
Kind of preferred choice for, we need to discuss with the patient, because sometimes, we do come across with these kind of patients who would like to have finite kind of treatment, and they would prefer, because problem with the BTK otherwise is the therapy cannot be stopped. To continue for indefinitely is a problem. So it's preferable to have a finite kind of therapy if it is possible, and if patient can go for it, then I think venetoclax with ibrutinib as a finite form of therapy can be offered.
Any takers for bendamustine rituximab now? Or is it like completely now the era for BR is over?
Because we are per se, I won't choose because we earlier used to use FCR. I belong to FCR that era. So that time the BR was not superior to FCR. So FCR was the drug of the, I mean, good combination. But now with this kind, the parameter that this patient has got, so I think he's not going to respond to BR or FCR because of the unhypermutated status. So I think BTKI, a single agent, or if the patient want to have the finite treatment, then choice number 2 may be a reasonable choice.
So what about I plus V, ibrutinib or BTKI plus BCL2 inhibitor? Are we there yet?
That is what is actually now it's a protocol which has been mentioned, and but I haven't used it ever. So I'm not sure how patient is going to go ahead with that.
So what is interesting to see in CLL is that whether we use BTK inhibitor therapy or BCL2 based therapy, so with BTK inhibitor therapy, we get probably a longer PFS1 as compared to BCL2. But if the duration of remission, if we achieve a good response to BCL2 based therapy, and now end of treatment MRD is being incorporated as a part of clinical trials, so if we get a good response, we are likely to have a good treatment-free survival. And if it's more than 2 years, reinitiating therapy with a BCL2 and a monoclonal antibody is likely to give similar outcomes to a BTK-based therapy. So it boils down maybe to the patient's comorbidities and the desire between a fixed duration versus continuous. So moving on. So modern CLL treatment, like we said, I think all of us would agree that BR is something that we are not using anymore, even in older individuals. Especially now, I think that we have access to CAR-T cell therapy. Incorporating bendamustine in our treatment regimens is possibly something we have to revisit. But ibrutinib or ibrutinib plus rituximab was superior to BR. And when we talk of the monoclonal antibody of choice, obinutuzumab is shown to be better than rituximab with context to CLL. So with obinutuzumab, we get better PFS. If you look at the current NCCN guidelines also, so again, we can have both time-limited treatment or continuous treatment. And regarding the when OB arm, there was a significant progression-free survival benefit in old, elderly, unfit patients. And in this study, majority had high-risk disease. Even in those, like in our patient who had an unmutated IGHV, PFS was significantly longer in the when OB arm. About the regimen of IV, the GLOW study 64-month results have just been published. Again, these are elderly patients who were given 2 time-limited therapies, but ibrutinib plus venetoclax did well, and in the cohort with mutated IGHV, there was excellent outcomes with this regimen. So a lot of doublets are there. Quickly moving on to another case, which we saw, 54-year-old woman. Now she is a diabetic. She has coronary artery disease post-stenting. She's taking Ecosprin and she presents to the dermatologist with intense itching and hypersensitivity to mosquito bites. Now the dermatologist does a CBC. Based on that, she's diagnosed as CLL with deletion 17p in 95% metaphases. So again, she has a high-risk CLL IPI. Based on this intense reaction to mosquito bites, does that qualify as a treatment indication? Because this was a question I thought about. Anybody, if you've come across?
No idea. Didn't come across. Is it Nick? Okay. So symptom is there, but it is an indication of treatment.
One is the symptoms, another is the high risk, like a deletion 17p. High risk. So we can't wait for this patient like the treatment indication. So we have to treat this patient. So deletion 7p already is an indication for the treatment.
I did struggle in my mind whether to treat or not, and I was hoping they'll take a second opinion also because the itching was really bad. But somehow we managed to control the itching with steroids and antihistamines. Counseled him that she is likely to need treatment very soon, and 9 months later, she did present with constitutional symptoms and cytopenias warranting treatment. Now, in this particular patient, she is young. She is otherwise good with the artery disease. What I think these are the factors that we would consider. What would be your treatment of choice here in any role of triplet combination? Or any thoughts that we are moving in that direction where we are combining all the effective drugs for CLL management? Any thoughts are welcome. I don't know what's the right answer.
If patient is young and if money is not issue, so I'll go for the number 4, venetoclax, so fixed duration treatment.
Not BTKI plus venetoclax being P53.
So it's different in the like BTK plus venetoclax treatment is indefinite. We can't maybe we can later on we can direct it to MRD directed, but still now treatment is like longer duration, and so we can choose like fixed duration treatment, like 1 year treatment, and then we can decide according to MRD or according to clinical symptoms or disease progression.
Any difference of opinion or thoughts on this case? What would be your way of?
Yes, you have mentioned about that female is, I think, coronary artery disease she's having.
Yes.
So accordingly, then I will like to go for venetoclax plus obinutuzumab as a therapy. Triple combination of regimen in the guidelines they have used like BTK, BCL2 plus minus monoclonal antibodies. But I would like to go looking at the comorbidities with venetoclax and obinutuzumab with this patient.
So is there a survival benefit if you use 3?
So if you use
all the combination.
So now there are studies coming up with the triplet combinations. So the triplet combinations, they have a PFS benefit for sure, and they have good undetectable MRD rates. And now there are some regimens where based on the end of treatment MRD, we can decide the duration of BTK also. So there are algorithms, stopping algorithms based on which if MRD is negative at this time point, maybe double the duration, you can give the BTK. Venetoclax and monoclonal antibody would be fixed duration. BTK is tailored to the MRD, best MRD response. So it also depends upon which technique we are using to do the MRD. So based on that, you can have a kind of fixed duration regimen. PFS benefit is there, but in our scenario, combining all the 3 drugs together, I don't know how the side effects and the toxicity would pan out.
The giving venetoclax is very difficult in CLL patient. Dosing is a concern. TLS management is a concern. And normally in AML, we give very short duration, 7 days, 14 days, along with azoles. Yes. So that brings down the cost. So how do you manage this cost? Of course, not everybody is a panel patient. So giving venetoclax throughout without any break. And I don't know how the trial people are giving or other people are using. Are they combining this with azoles or they are giving just flat venetoclax 400 to 600 milligram dose?
Sir, in CLL, they are not combining with azoles. So they are giving it like it should be 400 without the azole. But like you rightly said, it will be, even for panel patients, it is the taxpayers' money which is being spent. So we have to be prudent. But if you look at the results, there is a PFS benefit of combining all the 3. If somebody is willing, because obinutuzumab also would require a ramp-up schedule, that would have its own neutropenia, toxicity. The side effects are definitely there. But this regimen of ibrutinib plus venetoclax in the Captivate fixed duration cohort. So even in this, there are MRD guided cohorts and fixed duration cohorts. If you look at the patients with mutated TP53, we see the primary endpoint of this study was CR. The CR rates were they were similar to the patients without deletion 17p. So combining ibrutinib and venetoclax in a fixed duration manner could be, possibly a way for somebody who can afford it, who has access to funds and give good outcomes. But again, of course, finances would be important. So these are some of the triplets that there is a PFS benefit. So this is CLL 13 trial. If we look closely, I don't think the difference between venetoclax, obinutuzumab and ibrutinib versus venetoclax, obinutuzumab is that great. Definitely, compared to rituximab and chemoimmunotherapy, the novel drugs are doing better. But between the two, I think even a doublet is fine. We don't have a head-to-head trial between a doublet and a triplet. And again, Amplify study is again AVO, acalbrutinib, venetoclax, obinutuzumab fared better than acalbrutinib and venetoclax. So even in high-risk CLL with AVO, the PFS benefit with TP53 aberration was lower than those who did not have. So CLL 17 trial is ongoing. It's a head-to-head comparison of continuous ibrutinib versus VO versus IV. And the results would be interesting to see. So one last question before we wind up. Do you see MRD, because it's been around for ages, as an important tool for treatment decisions based on current practice? Are we doing MRD or we are not doing MRD?
So I am not doing MRD for CLL in my clinical practice.
Even we are not
I'm
doing
using
MRD.
single agent acalabrutinib. That's it. So sometimes we use
I don't
PR.
think anybody is actually following the MRD for the clinical regions as on today, barring the trials or the research protocols. But it may be desirable if it is validated and if it is available at a reasonable thing. In fact, I would like to combine the previous question Nitin was answering, because giving venetoclax and rituximab, the only good thing is that patient knows that the fixed
1 year.
is going to have. So that when you give it as when you combine ibrutinib, so either you give it for a finite duration, then it is still possible. But giving it as a longer time, I don't think with the very narrow PFS benefit, whether patient is going to be willing for that. Because the one main thing is that they want that if you can cut down the duration, that is what the most patient would.
So as you very rightly said, at present, MRD is not recommended, especially when we're using single agent BTK MRD. It's not going to make MRD negative, so we don't do. But when we are contemplating stopping therapy at some point, I think that is where the role of MRD would be better defined. Still, some questions would have to be answered: which compartment to test, whether blood or marrow, which is the ideal time point to make this decision that now we can stop therapy. So I think there is still a long learning curve ahead of us before we make it a routine clinical practice. So these are some of the trials. Finally, the take-home message for our context, I think, and please add if you have any other, that balancing efficacy with toxicity is important. Incorporating new prognostic tools at the outset is essential. And MRD, I think right now we don't know which is the right patient and right time, so still an investigational tool. Until then, we are in that cat and mouse chase like ages for CLL, which is still continuing. Thank you. And any questions and comments would be highly appreciated, sir.
What is the dose of venetoclax we use when we are going for a finite therapy? Yeah, I had two patients. One patient, the patient could only tolerate with acalabrutinib only 100 milligram per day. He didn't. The moment I made it to 200, count started falling. But after 1 year, he achieved MRD negativity. He's a young patient going for finite. The other one tolerated maximum 200 milligram of venetoclax. So what is actually though? All kind of trial you see 400 milligram. We are not able to give 400 milligram. Or if anybody is using, what is the kind of dosing being used in the venetoclax? 200, 400, what we are using? I have seen one, Isaa's patient was taking 400 milligram. He once came to me and he was tolerating well. I don't know. So what is your experience on that?
I have couple of patients. 100 milligram is the maximum dose that we could have given, and this patient was taking 100 without any problem. So more than 100, it is very difficult. Even in MDS, you find it.
But I have seen once only Dr. Isa's patient.
I was going to mention, yes.
I was surprised when he came and told me. After that, he has not come. He's with Dr. Isa call.
I was there when he started her treatment, so that is my experience also with her.
Kapoor's
yes.
Yeah, he tolerates.
She actually stays in my society, so I see her on walk.
And he tolerates.
He's doing very well.
Very surprising.
So that is my only experience, sir. So thank you, panelists, for this session. Thank you.
I would like to thank all the panelists and Dr. Nivedita for such an insightful discussion and sharing your perspectives with us. So for the next talk, I would like to call the chairpersons, Dr. Priyanshi, Dr. Satya Ranjan Das, Dr. Harshit Khurana. And our speaker for the next talk is Dr. Vipul Seth, and the topic is CAR-T and CAR-NK, India's translational journey so far.
Good evening, everybody. Dr. Rahul and team are doing excellent job. So now the topic is CAR-T again. I think Dr. Vipul is the person who is going to elaborate on CAR-T cell. He has got, excellent experience from outside as well as in India working on CAR-T cell. So without any delay, I'll request Dr. Vipul to start his, presentation on CAR-T cell therapy for relapsed refractory acute leukemia. Dr. Vipul, please.
Hi, good afternoon, everyone. First of all, I'd like to thank Dr. Bhargav for giving the invite to talk on this topic. So, the topic I was given was translational journey. I think pretty much people are aware of the clinical data, so I'm not going to go much into clinical data because I think there are lots of presentations in DLBCL and ALL for clinical data. I'm just going to go into the process about where the field is going and what is going to happen in the next 5 to 10 years. Many things are happening. There are so many labs working in parties. I just focus on the things that I've been involved in because there are so many things that are being developed. Thank you. Just to start the process, this is CAR-T cell, right? You have a binder. You don't have to tell anyone. There's a transmembrane domain and a signaling domain, which is very primary. You need co-stimulation because it is not physiologic. What I used to do is I used to work in TCR. So I used to not work in CARs in lab. My lab focus was TCRs. I used to do attending in CAR services. In TCR, the signaling pathway is physiological. You don't play around with it. But then you rely on HLA for binding because it is very physiological. CAR can bind to any antigen, where you can bind only to antigens which are presented by HLA. So both have their pros and cons. So clinical data, I'll just go through this one thing. This is the long-term follow-up of Kymriah data, which everyone knows. So you see that the grade 3 CRS and above is very high, but they are very potent CARs also. And the long-term outcomes EFS is around 50% at 1 year. This is what you expect for most of the good CARs. And we also thankfully have 2 Indian companies now, Immunil and Immunact, with the data which has been presented. So we also have got our own CARs. But just going forward, I'll touch on ALL. I'll mainly go to AML, which is my area of interest. So for AML, no matter what you do, you don't get good results. This is because of some kind of escape. So either the CD19 escapes itself, so either the antigen itself becomes less, or the antigen is there, but the CAR-T cells themselves get exhausted. And sometimes the ALL switches to AML. I mean, there is no longer ALL for the CAR-T cells to identify CD19. So these are most of the mechanisms that we know of. And this is where the field is moving because people have tried CD19s, people have tried CD22. To the best of my knowledge, most of the CD22 trials have been withdrawn because of very high incidence of HLH. We are going to come back again because people are working on it. Similarly, people try to get away with this CD19 negative escape because if you use CD19, then what are you going to do? So then comes the concept of dual CAR. So you target multiple targets, so you don't get loss of any antigen under any pressure. This can be done in multiple ways, like you can do 2 lentiviruses, you can do tandem, 1 lentivirus above the other, or you can put 1 lentivirus, you can put 2 vectors together in 1 lentivirus, or you can put cocktail of all, which is an approach in China. I'll not go to individual approaches. I'll just lay stress upon one trial. This is from my mentor. Spent years and years on this. This is cohort 3 that you can see. Already cohort 1 and cohort 2 was unsuccessful. I mean, not unsuccessful, the results are not up to the mark. So he modified a lot. Now he's working with 2 lentivirus instead of 1 lentiviral, having both expression. You can see expression of all 3 antigens. And this is the data. You can see 12 patients treated. But again, the event-free survival at 1 year is around 30%, which is not up to the mark for CD19. It's great for a new CAR. But to the best of my knowledge, most of the dual CARs have been withdrawn from the market and people are working on it. So you just know that Denside is full of failures. You have to keep working, and then you do finally succeed. The main reason for failures for dual CARs is you don't have uniform expression of 2 CARs together. So your effector target ratio is not enough. Secondly, they don't persist. So if you get rid of these 2 points, then probably it should start working. Now going to so there are other generation of CARs which other speakers have spoken about. So you have 2nd and 3rd generation CAR which persists for longer. 3rd generation has both the co-signaling domains 1BB and OX40 or 1BB and 28. So this one trial is currently under trial and the result should be out very soon. I'm not going to hit CARs. So just to go back to AML CARs, which is my main focus of interest, because most of the translational work is there. For AML, unlike ALL, it has been a story of failures only. It has hardly been any successful trial. The main reason being heterogeneity in AML cells itself. Plus, every marker that you target in AML, you are going to target normal hematopoietic stem cells. There is no way that you are going to avoid it. When you do flow cytometry, you know it's so difficult to do MRD in AML because all the markers are equally expressed. Plus, there is antigen sink effect. I mean, there are always normal myeloid cells when you target AML cells, and those normal myeloid cells are going to bind your CAR-T cells, and you will have loss of CAR-T cells. So that is called antigen sink effect. And the microenvironment of AML is very hostile. It eats up the CAR-T cells just like any solid tumor. So these are the challenges that you have to deal with. These are pretty much the targets. I'm not going to detail of each. CD33, 123, CLL1 are the most widely studied antigens. So important clinical trial. I'll just quote one from Dr. Bhagwat. He's my colleague from UPenn in Sargil's lab. This fantastic work in Nature Medicine, but you see the outcomes. Very dismal. Hardly 2 patients responded, and this was mainly to do with cytokine milieu. They eat up the CARs, I said. This was CD21, 23 targeted CARs. You see the cytokine profile is all haywire. There's lots of cytokine release. People die of CRS. If they do survive, they're hardly going to CR or MRD negative remission, mainly to do with microenvironment and other factors that I said above. These are most of the trials that I could find while I was writing this review article. This is from Nirali Shah, again withdrawn. This is the only successful one from China where they use CLL1 as target. This is a JCO paper where they had phenomenal responses and to an extent controllable CRS. And this was without any modification in the CAR. So I don't know how this was done, but anyways. But other trials are more or less a failure, and most of the trials have been withdrawn. So these are the things that I'm working on. Many people are working on AML CARs. I'm not the only one, but this is the time where I spend most of my time. This is work from my colleague, fellow postdoc in the lab. So what he did is, instead of CD33, what we saw is if we reduce the size of the CD33 binder here. So this is what we call as novel CD33 pan CAR instead of the VSET CAR which is available in the market. Then probably the killing is more and the CRS is less. The selective killing, lots of in vitro work. It has been published. The phase 1 data was also out. The study has been done. He shifted to Australia now in Westmead and he heads the unit there. Phase 1 is done. Again, not very convincing results. So we are again working in lab, both of us together, probably to modify this by epitope editing, and probably this will go back to phase 1 and then I can bring it to RGCI in phase 2 probably by next year. This is what we are doing in our own lab, not going into details here. What we are doing is we are creating a logic gated CAR. So the concept, I'll just explain the concept, is very clear. So because I said you cannot target any antigen in AML without sparing the normal stem cells. So what we are doing is we create Boolean gating. So these are logic gated. So this happens one after the other. So if you have got CD33, then the CAR will be activated. Then you also need CD123. And if there is an antigen which is present more in normal stem cells as compared to AML, then the CAR will be down-regulated. But this is high-level genetic engineering. We are doing it with help of Professor Kumar from MSKCC. But anyway, this is in development. This is still very much in preclinical stage. And this is more lucrative approach from my mentor again in UCL. So this is again what he does is he takes CD5 target antigen as CD45. You know, every hematopoietic stem cells has CD45. So you need to knock out the CD45 in your T cell, otherwise you're going to cause fratricide. So first of all, he transduces. These are third-party donor cells. He knocks out the CD45. Again, then there is very high CRS. There is minimal response or MRD negative response. What you need to do is you need to knock off the CARs as soon as possible so that they don't kill the normal stem cells. So introduced a suicidal gene, and this is each cohort. I'm saying first was only CD45 CAR or failure, then not a failure, not comprehensive results. Then after that, introduce suicidal genes so that normal stem cells are not knocked off. And then again, you have to bridge it to transplant, right? Because no matter what you do, stem cells will be reduced. And when you give donor stem cells, again, the persisting CARs are going to knock out the stem cells because they target CD45. So what he did is he epitope edited the donor stem cells in order to engraft. This is very difficult to do in real world. It requires a lot of costs. So, but this is one of the very lucrative approach. Shifting here to TCRs, where my main focus of interest is and where I work in lab. So the advantage of TCR, I said, it requires HLA binding. So it targets intracellular antigen, unlike CAR, which is surface limited. So with this, you can target NPM, FLT3, you can target any of the genes that are responsible for AML for AML to happen. So this way you can definitely spare normal stem cells, because normal stem cells are not going to have FLT3, they're not going to have NPM. So this is a field of interest. We obviously, while doing TCRs, we knock off the endogenous TCR so that there is no cross binding between the exogenous TCR that we put and the endogenous TCR. But I cannot go into so much of details of this. It's our lab work. And the antigen that we are targeting. So in order to do any TCR related treatment, you just have to know the principles. You need to know that the target antigen should be very immunogenic. Then only TCRs will work, otherwise it will not work. AML is very immunogenic because DLI works. So you'll have to select an antigen, be it onco-antigen or neoantigen or minor antigen. Plus, there has to be minor antigen mismatch. So the donor should have a different antigen at minor level as compared to the recipient. The recipient will have one phenotype, which is AML, and the donor will have another phenotype, and then they can target each other. This can also be applied to post-allo transplant setting where you get relapses. So when you get relapse, your donors, the AML cells become recipient, but the entire other milieu is donor. So what you can do is you can target those T cells against cancer and sparing GVHD. It's a very difficult concept, but this is how it is. And this is the first phase 1 and 2 human trial published in Blood back to back. This was preclinical stuff from my mentor, and then again published in Blood as clinical trial. Now we have completed 20 patients. HA1 was the antigen that we targeted. This is very immunogenic antigen. But again, I'll say the trial results are not so great. Good responses, no CRS at all, but not as good responses as you would expect with us. So again, we are modifying the construct by reducing the size and length of the construct, etc., etc. And this is my work in lab. So I targeted another antigen called BCL2A1. This is BCL2 family gene, just like venetoclax targeting apoptosis type receptor. You can see cell line data and primary cell data. It's very good. These are positive and negative controls. So we had success with in vitro data. This is again, so this is long killing assays in IncuCyte. So you keep target antigen and the TCRs together, and you see enhanced killing. So these are cell lines and primary leukemia that get killed with the TCR treatment. And this is negative control that will not get lysed with the TCRs that we're introducing. And we also brought it to mice, and we followed Mr. G mice model. So this is a very complicated mice model where you have a cytokine milieu where the AML stem cells can engraft, because if you put AML cells in nude mice, they are not going to engraft. So you need to have that cytokine profile. And we had reasonably good success with this, but it's still very preclinical. It is unpublished yet. The work is still ongoing. We did not have some successes, and we had some leukemia escape, though there was good proliferation of TCRs. And then we looked at why this would happen, though we had good TCR and good target antigen, and this is because of loss of HLA1. And this is very well described even in transplant setting, that you lose HLA1 and you downregulate HLA2 under immune pressure. So this was the main reason for losing the leukemic cells despite having good TCRs. So this is one of the reasons. We also comprehensively looked at single cell sequencing to find the reasons why some of the mice did not respond to TCRs, and we found persistence. So you see the very naive T cells which are hypoxic persist as compared to progenitor cells which are differentiated cells, they get lysed. If the stem cells persist, that's the main reason that the tumor comes back. And so this is also transcriptome because it's single cell sequencing. And at transcriptome data, we found upgradation of hypoxic initiation factor. So this is HIF1 alpha, which causes stem cells to go into hypoxia and redundant dormant stage, because of which they cannot get lysed. So we have applied for patent. So this probably will get patent by next year, and then it should come into phase 1 clinical trial to bring it actually into clinical practice in humans. Another of my, of course, research has been looking at microenvironment, which I'm not going to detail. This is the last slide. I'll just touch on this because we are targeting BCL2A1. azaven is very, very relevant. So what we did is to our TCRs, we added azaven along with it. What we found is, so you can target microenvironment as you want because it is very hostile for AML. You try to target the stromal cells. You can target the Treg cells, the T cells, and you can also target the B cells. What we did by giving azaven is, you see the B cells get depleted, which are innocent, which are not innocent bystander, which are the ones which causes loss of potency of CAR-T cells, but the T cell milieu remains as it is. And then we got good lysis of cells in mice as well as primary cell lines in vitro as well as long killing assays. So again, this is very unpublished. It should be published somewhere next year. We should get patent. We have filed for it and then probably can bring it to clinical trial. So just to summarize, the way ALM field is progressing, I think CD19 people are looking beyond it. I think you humanize it or look at 2 target antigens, 3 target antigens. You maybe combine TCRs and CAR-T cells together. You look at further general things. You do armored CAR-T cells. For AML, people are mainly struggling with CARs, so maybe TCR is the focus here. You play with microenvironment and probably you give some of the agents by which the leukemia does not escape, or you target the microenvironment and cause increased persistence of the AML CAR-T cells. With that, I would like to thank everyone. Thank you and open to questions.
Thank you, Dr. People. Before I open for the any question, I have got small doubt, particularly in B cell ALL. When you go for CAR-T, like in our country, only one is available. Suppose both, CD19 and CD22 CAR-Ts are available. Will you look into the blast expressing CD19 or 22, and if suppose the blast is expressing CD22 better than 19, you go for CD22 CAR-T, or you will just go like that?
So exactly. So in real world, we have used bispecific and I've used CD22 also. The way we choose usually we use CD22 after CD19 failure, even if the CD2 expression is high. But yes, people are looking at it that if CD22 expression is high, because there is no correlation with the level of expression. It's more on the antigen burden rather than percentage expression in the cells. So we have been using it after CD19 failure, but people are looking at it that way. Many people are using dual CARs, but when I said like most of the trial of dual CARs have been withdrawn. And CD22, which was a NIH study from Nirali Shah, that has also been withdrawn because of very high incidence of HLH. And we don't know why this HLH happens with CD22. So the approach is giving CD19 first, followed by 22. But yes, you can use CD22 first.
So why I ask this question is, I had a patient who had come from outside and he was a BLL relapse, didn't respond to Blina, but went into remission, which I know, but we don't have any other option. We did a CD19 CAR and day 30 was MRT negative, day 66 blast. So I don't know what is this scenario, because she didn't respond to Blina. I thought probably CD19, but flow cytometry showed both CD19 and 22 good.
The problem is Blina. So there is lots of selection pressure because you've already targeted CD19. We have used CARs post Blina. The results are not at all equal to without Blina, but people do use it. I mean, you can't do anything, so you do such things.
Good news that I think CAR-T is coming for AML also, maybe initial stage.
It might take lots of time.
Going to have how many years from now?
I've already been working for 7 years. I think probably 2 years from now.
Any question from the house?
Vipul, a lovely talk. 2 questions. So one is, if you look at all the data in ALL, we seem to be getting 70-80% responses, but by 1 year, it drops off to about 40%, 50%. So in our algorithm, should we say that everybody who has CAR-T should be consolidated with an allogenic transplant? 2, one of the problems is persistence. Now, I know there was some data from the Israeli group in lymphomas looking at giving nivolumab post CAR-T infusion to increase persistence and expansion. So are those some of the strategies we should look at?
So I'll say most of the CARs that I've worked with, responses will definitely come. There is not a CAR that you will not get response. The problem is persistence. That's a problem everywhere. You're going to get response, you're going to get CRS. I think you work with the product that you have, because each product takes 10 years. I've been working 9 years on my product. If the product is not that potent, you cater the patients accordingly. So you prepare the patients in a way that will work. For us, the CARs was so potent that everyone used to land up in ICU. So we used to lower down the disease burden so that they don't land up in ICU, because they're very potent. So it all depends on that. But people are looking at persistence. Of persistence, you either reduce the affinity of the CARs or you do TCR CAR, which is called hit CAR. So you play around with tonicity of the CAR. The main reason for persistence loss is tonicity. So it binds to antigen so strongly that it gets consumed. That is one of the things that people are working. You have got Obicel, right, which persists longer and it causes less CRS. And I've seen that from the preclinical stage itself. So it's a great CAR. So regarding the second question, sorry. So PD1. I think PD1. So UPenn has a trial where they do PD1 along with CARs. Most of the people have given up on that. They didn't see good successes. I mean, you'll have response, but it will not last. So how much PD1 are you going to give? And also we used to do this when we used to look at CAR-T cells and we used to look at level of expression of exhaustion markers. First of all, CD19 should be present. That means the T cells are exhausted. And you should look at exhaustion markers. If they are there, then it will work. But maybe 3 months and then again it's going to get exhausted.
Thank you very much.
Okay. Thank you. Thank you very much.
Thank you, Dr. Vipul, for such an insightful talk. So with this, we end this session, and now we will start our last session for the night, session 4. And this session will be focused on the topics related to transplant and cellular therapy. So without delaying, I'll start with the next topic. I'd like to request chairpersons Dr. Rohit Mangal and Dr. Biju George to please join us on the stage. And our speaker, Dr. Colonel Rajan Kapoor. The topic is Opening Snapshot Bone Marrow Transplant in 2030, Changing Paradigms in Patient Selection, Conditioning and Donor Choice.
So, before Colonel Rajan Kapoor starts his talk on 2026 transplant, let me ask the audience, how many of you feel that in 2026, number of transplants will come down because of CAR-T cell therapy and gene therapy? And how many feel that it will increase? How many feel it will decrease? Or everybody feels it will increase, not decrease? Okay, so you have a tough time ahead to say what we are going to do in 26.
If it comes, my presentation. So, still, I think they're struggling to get the presentation here. Okay, so I'll just start. So, first of all, thanks to Rahul, he is not here, for inviting me here. And I should have been sitting there with Dr. Biju because I was told that I'm the chairperson of the talk. Good that I looked at the program few days back. I realized I'm a speaker. So I don't know it's an upgradation or a downgradation. At least I'm standing, not sitting. So the topic is 2030, the transplant. So I'll try to finish it off in time because we'll have a lot to discuss because a lot of young crowd, probably they'll be having more ideas how we are going to do the transplant in 2030. And no. Good to see Das sir here in his new style. Yeah. Okay. Oh, the font has changed. So that is HEMENEXT. So what I thought is I have used a lot of AI. So the topic was this, and that's I thought this line is very appropriate. Revolution from desperation to precision. This is where I am, and I have Dr. Ajay Sharma sir and Sanjeevan sir who have been here. So all of you, if you can brave the cold and the hypoxia, be my guest. This is a place where actually we are now practicing more of a classical hematology. Dr. Sanjeevan is here. This meeting, before that we had a meeting in ICMR where we got a big ticket project studying thrombosis in high altitude. So I'm sure the lessons we learn from this will be helpful for the transplanter also. I'll see if the video works. So I don't know whether voice is coming or not. So I guess, so now is the time for AI agents. I think the voice is not coming.
संजय सर और आपको सपोर्ट कर सकूं उनकी कीमोथेरेपी से पहले डॉक्टर राव ने मुझे अपॉइंट किया है एज योर केयर कोऑर्डिनेटर. क्या अभी आपके पास कुछ मिनट हैं बात करने के लिए? ठीक है, मैं शॉर्ट रखूंगी. हम 3 चीजें डिस्कस करेंगे. कल का प्रिपरेशन, फ्राइडे को क्या लेके आना है, और जो इंश्योरेंस इशू लास्ट टाइम हुआ था उसको मैं कैसे रिजॉल्व कर रही हूँ.
So this we are working with someone coordinator who
प्लीज सर्विस को रिमाइंड करना कि वो दिन भर पानी पीते रहें, छोटे छोटे घूंट लेकर। पानी ना बहुत ठंडा हो और ना ही एक साथ ज्यादा पिए। नमस्ते। Hi Saurabh, just confirming आप
So this was just to show where we're heading. We have a lot of AI agents. I'm sure we all want some coordinator who can talk, and we don't want to spend too much money on the receptionist and the other coordinator. So AI is coming in a big way. I think many hospitals have started using it, and we saw a humanoid here. So this is the future which we are looking at. And even the transplanters probably will be using more and more AI agents. I think in 2030 we'll have that. So if we see evolution of bone marrow transplants, I couldn't help but tell about this gentleman. We all have heard about O. Donald Thomas, who won a Nobel Prize, but George from Germany, he was first to attempt human allogenic BMT. He did it first on accidentally irradiated Yugoslavian physicists. I don't know what happened to them, but he did that. And he was the first one to use TBI, followed by a mixture of blood and marrow from 6 related donors to a patient with CML. And the last one is very important and very interesting. He was the first one to use ATG, and this is the observation which led Bruno Speck to propose ATG as a treatment of aplastic anemia. So this was way back in 1958, and I just searched in PubMed. In one particular journal, he published 55 articles. And see the second one. We are still struggling with selection of the best donor. He tried to select in 1966, and in 2025 we are doing the same. So he was the one. And when we look at the timeline, now it's the time it's getting zipped. The things are moving at such a fast pace that it is difficult to keep up. Now we had started in 1955, now 2000. Widespread haploidentical, now gene-edited cells, and we have been listening for morning about the CAR-T cells and other things. So we are going from survival to precision. Early when the transplant was started, overall survival was just around 10%, and I just read a paper which has just come 1 week back. In AML, FluMel, and Pax-Sirolimus, they are talking about the 5-year overall survival of 55%. I mean, it contained all bad AMLs also. So this is how fast we are going. And I'm sure in 5 years from now, more and more AI would be there. This is how it will explode. So just to give a snapshot, I just could get 2021 registry data. I couldn't get the last year one. So we can easily, we have a pointer in this. Okay. So here we can see the number of transplants which is increasing. I'm sure it must have crossed 3,000 by now, the yearly transplants. Okay. This has been brought up. So you know this green curve, I'm sure Apple maybe matching up to MRD, if not now, maybe another 3-4 years. And we had a presentation by DKMS Registry. I'm sure they're going to be out of business very soon. I mean, the way the haplos are picking up in our country. Now, this is a very interesting slide. If you see that number of centers, I think now it is 114 or 115 who are reporting to the ISBMT. But I want you to focus on this one. Now, that means most of the centers are doing less than one transplant in a month. And most of these centers are a single transplanters. So this is what we are going to see more and more. We have a very fascinating large team in large academic institutes, in bigger corporate hospitals. There are 4-5 hematologists. But most of the centers in tier 2, and probably it will go down to tier 3, are a single transplanter center. That's a very tricky situation. I'll come to that later. But we have to understand that more and more places, when they are doing the transplant, it is a single transplant center. Now, this is a very famous adage we have in armed forces: the more you sweat in peace, the less you bleed in war. So this is very apt for the transplant. Before your patient goes into the transplant unit, you have to do very diligent pre-transplant workup, identifying comorbidities, choosing the right donor, and the safest protocol. And this is where I'm going to focus on. So right now, we are doing a pre-transplant assessment, comorbidity assessment. Now, if you see the HCT, HCI, I am sure most of us are now very clued up about using this. You can clearly say if the score is more than 3, the 2-year versus 30% versus 70% with 0. So how do we do it? This is what the authors have said. Right way of doing an HCT-CI. It takes around 15 minutes. Go through the medical notes, review of data, consults, labs and tests, and final assessment. So there is a tool that we all use, this calculator. We go to that and then we can calculate the HCT-CI. Now this is the present era. Now, what do we have in 2030? So, I think yesterday only there is an article in NEJM where they have said the wearables, the Apple Watch, the Samsung, the sensitivity and specificity of picking up atrial fibrillation was 98%. So imagine paroxysmal AF starting on anticoagulation, saving so many lives with the wearables. So this is the era of wearables. Probably we'll see that. This is what I am going to talk is a digital twin simulation. Dr. Sanjeevan is with us. So we are developing in high altitude or in the normal, the para jumpers, making a digital twin of para jump and to see how much impact they have. I think this is a very interesting area where probably the transplanters also would have it. This is how the digital twin works. You have a virtual entity, a physical entity, and an input data. So there is a real-time collection. And then you can expose this digital twin to all your drugs, conditioning, and see how the patient is going to behave. So this has already been done for first-line GVHD. Now look at this number. So they included data from more than 6 crore patients and 2 lakh. So this is unimaginable in normal circumstances, but this we can use as a drug trial. Now what will happen to the comorbidity assessment? I think it would be more machine learning driven, inflammatory markers and organ stress profiles. The other thing which we do is a disease risk index. It's a very good calculator according to the disease. We have been listening from the morning. How do we risk stratify AML? So as Dr. Biju had posed the question whether transplant will go up or down, I feel that they may go down the indication because you will be able to pinpoint this is a guy who needs a transplant, this is the one who does not need it. That's it. Any guesses what is this? This has come up today already. So this is the first lab grown. Oh, I thought I had half an hour. Anyway, so that was the program which told me. So this is the lab grown blood factory. So the first time today only it came. So you have a niche, bone marrow niche and red cells. Now this has got immense potential. So you use this model, you can model the GVHD, GVL, test your conditioning drugs, study AML, MDS. So this is what we are looking at. So this is the paper which I thought this is interesting when they use an ML. So if you, it's not very clear, if you use that OS and DFS, see a high benefit. If you have intensive conditioning, there is some benefit. But if you do it in low benefit, there is no benefit at all. So you have to, in this paper, stratify into high, medium and low. If you have a low risk, do not give high intensity or a MAC conditioning. You are going to burn your fingers. So that's what we are looking at. So you may improve the conditioning. The TBI, as you know, more and more, less and less we are using. Busulfan probably maybe out of business, or you can use a targeted busulfan. You have genomics, comorbidities. So this is what I think will happen if you have an AI-driven precision doing and risk adaptive intensity. So we all know the transplanter question, whether to MAC, RIC, regimen-related toxicity, TBI, giving or not, how much you give. So we are all scared to do elderly transplant. I was very, when Dr. Biju said that they're doing 78, 75-year-old transplant, which we are not doing probably a decade back, I guess. Now we are doing it. Probably we have an aging population, comorbidities. We are heading this next week. Most important is this. We have more and more older and comorbid population who would like to live more. An 80-year-old would say, why shouldn't I make a century? So you have to offer that. We have to expand the donor pool. So conditioning, I feel more and more will be moving away. And this is a nice paper which has just come out, 3 years back, where instead of traditional conditioning, it would be antibody-based conditioning, more targeted. We already have ranibizumab. We are using vedolizumab for GVHD prophylaxis. This is a recent paper of rituximab. We'll be using as ADCs will come. CAR-T was conditioning radio level. Now moving on to the donor selection, this is what we do nowadays. Identical 10 by 10 and matched and related, and maybe we are going to 9 by 10. So this is a very interesting paper. Slides have not come up well. Again, that's the problem with Apple and Microsoft. So on the left side, earlier what we used to do is search for allogeneic donor, maybe sequential. You try for sibling. If sibling is not there, go for mud. Mud is not there, then haplo. So that wastes time. So now what they are doing, if you see the right-sided strategy, is concurrent strategy. You use a prognostic tool. You tell that the probability of finding a mud donor is very low. So you don't waste your time and money and efforts on a mud. Go for a haplo or an alternate donor. So search all donor types concurrently. You do prognostic tool. As of now, mud still is a second choice, but probably we are moving more towards haplo with a PTCY. Now in mud, when we do DPB1, so that was the contentious issue when you go for 12 by 12, or you can have something. Now we have algorithms, so you can do permissive DPB1. So if you have a permissive DPB1, the results are as good as 12 by 12, but if you do not have a permissive one, you are going to burn your finger. So this is for the residents if they are there. So you use for functional grouping of DPB1 donor T cell reactivities, which is already there. Now this is the power of AI. I don't have to cut, copy, paste. This is my take. What will happen is a haplo first model, matched sibling donor obviously will remain, but maybe haplo over MSD. I think younger haplo over older MSD would be a norm in 2030. High risk AML, AIR advantage, you may go for haploidentical, Hodgkin's lymphoma, and if donor is unsuitable. So you may see a chance in 2030 haplo coming before a matched sibling donor. Unrelated donor, I think big things are done. This is a very scary, we can't miss him. So if AI was not enough, AGI. Any guesses what is AGI? Artificial General Intelligence. Now, Artificial General Intelligence means AI has got a human reasoning. So this gentleman, we have to take him very seriously. He has said by 2030, AGI will be there, and AGI will eat up 40% of the jobs which is done by humans, because the reasoning would be there. So we had a chatbot which was following Rahul very well, but if he starts reasoning, he will question him, so which he may not like. So that is what the thing is. Probably, I think AI boost will increase the OS to 90%. HCT is going to stay. The competitors is gene therapy, but I don't think so in 2030 gene therapy would be cheap enough. CAR-T would be there, but probably HCT, CAR-T, co-indications will attack. So I had made a slide for half an hour. I'm sorry for that, but if there are residents and doctors, 2 articles you should all read which have come in any game. One is this educational strategies for clinical supervision of artificial intelligence use. This we face in and out. I face it with my residents and the doctors who come. When I go for a round, I know that he's carrying a tab or plate, and I think the resident is probably using the phone. Now, what should be? He'll know more differentials than I do. Is he questioning the AI? He should suggest the question. Can he be trusted? I mean, you can't avoid it. So they have come up with a thing called DEFT AI, discussion, evidence, feedback, teaching. You cannot avoid AI. You have to embrace, but you have to use it. Now, this is a very important graph for all my younger colleagues. Maybe I am at, most of us with the gray hairs are at this place where we never had cell phones also. So now I am at this start. I have stopped practicing hematology as of now. So if I don't do anything, I'm going to plateau and probably miss skill or de-skilling. But if I do adaptive AI, I might probably try maybe a little higher. But the problem happens if the novice, if we have never learned, gone through the grind, as you said, and starts using AI then there are two problems which are going: never skilled and de-skilling. So as a transplanter, when we nurture, when we mentor the students, this is very important to know when to introduce AI and how to use it. Very important. They have come up with very good terms. I won't be time, but have to adopt it and tell the juniors how to use it. The second is very important: bedside clinical encounter. We have forgotten. So I was discussing with Dr. Tulika also. Small things you see in the rounds, the person wincing in a pain, the resident just knows all the genomics, everything, all the data you ask. But why the patient is wincing, we don't know. He had a perianal or an anal fissure, so he never bothered to examine. So we have to reinvigorate bedside clinical encounter even in 2030. So do read these articles. And no technology is of any use if it doesn't bring out the cost. So in 90s, when I was in the medical school, wanted to listen to the Pink Floyd, I had to buy an audio cassette and shell out a lot of cash. And the other day in Leh, I saw a laborer listening to Taylor Swift, free of cost. So this is what the technology does. Everyone now can listen to the music on the mobile phone without anything. This is what technology should do. So how I or we have adapted, I don't know the net would work or not. It's going to work online? Maybe not, I guess. Anyway, I can show. So what I said, I never wanted to. So this is the data which painstakingly from 1998, Sharma, Wilsers, and so this was in an Excel sheet. No, it's very difficult. So Rahul was with the administrator and they're pumping money into hematology. For us, it is very difficult to convince our administrators to give more money to hematology. So what we did is, I don't think so it would work. Okay, so maybe I can show. So we have made these apps ourselves. I learned coding during the COVID and then with the AI. So it gives a snapshot how we can do. We have made for tumor board for protocol so that when I said single transplanter, when I was in Calcutta, I was alone. And you tend to make a lot of mistakes when you're alone. So with the dosing and other things, so it's best to use an app when you put in the dose, wait, you get the protocol, and you know that you're not going to make mistakes. So that is how technology has helped me progress ahead. That's what I have. My take for BMT is, I think number of indications will go down. PH, AML, myeloma, maybe Hodgkin's, we may not be doing that many transplants. I think no one would be denied BMT due to lack of donors. It's donor for all. Cost definitely will go down. Outpatient allo BMT, more targeted. I think the days for coordinators, receptionists are going to go down. The team strength will go down. The Dr. Rahul will go. Probably I won't get a job in his team because he will probably prefer a robot or a humanoid something. BMT centers probably will cross 150. I guess there will be more stringent regulations for single center transplanter, which are going to work. This is what I thought. Probably will take in more. So the last slide, I just saw it in the thing. The Japanese woman marries her AI created partner. I married the warmth he brings into my life. I hope that hematologists and transplanters don't get very close to the AI coordinators. And the other thing which is very important is this. This is a study which reveals AI sucks up to the people more than the people suck up to each other. So this is the punchline. The biggest problem of succumbing to the charms of chamchas is that sooner or later one will get well and truly folk. So please remember, if you ask AI, I think that female is better than you, so they'll say, yes, you are right. And you pose it the other way, you're right. So please be very careful when you use AI. So that's important. But this is the globe. I guess a good hematologist, transplanter will always be in demand, whether you are a humanoid, robonoid. People would like to talk to a human being. They are not, when we get an IVR, we don't want to talk to the Airtel IVR, we want to talk to the person. The same way will happen. That's my take. Thank you.
Thank you so much for that. Any questions from the audience? Dr. Harshit.
So, just a point, the laborer listening to the music is not free. He's paying for the internet charges and the device. The actual the cost of the device actually on the company shelf would be much lesser than we are paying for the apps and the internet. So just a point.
I just got the Indians are the largest data users in the world. 35 GB or something. I think it's from the music and the videos or something. But
the numbers.
It improves the access.
The numbers.
My point was it improves the access. You want to go?
So let me ask you a question. Looking at it from an India point of view, if we need to say that everybody who needs a transplant, I mean, I would assume that right now, if you take 100 patients who needs a transplant, probably only 40 or 50 would get a transplant.
Yes, absolutely.
Now, if we need to push that up to 100%, if you had a wish list of 5 things which you think should happen to reach that, what would that be?
So, one which I had said, using the technology, one is to select your patients very well. So right now, say, given an example of AML, probably I'll try to transplant everyone. I mean, just saying. So if we know that the numbers which we are selecting, the exact numbers, so the one who are deserving the most would get the transplant. First is using the algorithm. Now, it's humanly impossible to process the kind of data which is coming to us, as you had shown in the morning, the mutations, and especially the regimen toxicity. That's why I've said the digital twin and other things. When we know a person whose OS is going to improve, so from 40% to 70 or 80% will go to the transplant. So that would increase the number of eligible transplant. Second, I think the cost is going to go down when the paraphernalia goes away. So you don't have any BMT coordinators you have to pay for. You don't have any restrictions. You may cut down on certain, probably the nursing staff or something which is not required. So that cost would come down. So the total cost of transplant definitely would come down and become more affordable. So the pre-transplant workup, which can be given to the technology, the conditioning and actually picking up the right guy whom we need to transplant. I think that would be the one which would increase the number of deserving transplants.
Any other questions from the audience? If not, we'll close the session. Thank you so much.
Thank
you. Thank you, sir, for such an interesting and a futuristic topic. So now the next topic, I'd like to invite Dr. Narendra Agarwal. His topic is Belumosudil in chronic GVHD, a new pathway to control fibrosis and inflammation. The session is sponsored by Sanofi.
Thank you. Good evening, everybody. And it was an honor actually to receive a call from Dr. Bhargava around 3-4 weeks back that he's inviting me for this conference, for this Belumosudil talk. And I accepted it. And later on, I came to know that it's one of the sponsored talk. So, and here the slides are provided to me by Sanofi. And there are certain disclaimers, and one of the important disclaimer is that none of my patients has yet received Belumosudil till now, though I offered it to a couple of patients, but I'm not able to treat any patient with this medicine till now. So we all of us present here know about graft versus host disease very well, acute and chronic, and overlap syndrome. So in chronic GVHD, in fact, any of the body organ can be affected from top to bottom, from skin to any internal organ. It can be mild, moderate, severe, depending on the NIH scoring and severity of the symptoms and number of organs affected. And it's actually important cause of mortality. So there is no significant data available from India on number of deaths because of chronic GVHD, but from US, nearly 13% of the patients post-transplant die because of chronic GVHD. So amongst all deaths, 13% are because of severe chronic GVHD. And we know that nearly 30 to 70% of the patients across various published literature, they develop chronic GVHD after transplantation. In US, the prevalence is approximately 14,000 cases, and of which 40% of the patients can have severe form of chronic GVHD. And with growing number of transplant, the prevalence is growing year by year. Overall, out of all chronic GVHD patients, nearly 2/3 they have history of prior acute GVHD as well. So acute GVHD is very important risk factor for subsequent chronic GVHD. And these are the risk factors. So definitely acute GVHD is an important risk factor. Other than that, older age of recipient as well as donor, HLA disparity, uses of peripheral blood stem cells, T cell replete graft, and female donor for male patients, especially the female donor which is harassed female, or we can say alloimmunized, can be a little associated with a little higher incidences of chronic GVHD, and non-uses of T-cell depletion therapies like ATG and post-transplant cyclophosphamide or graft manipulation. So these all are risk factors for chronic GVHD. Pathophysiology, so it involves basically inflammation. It starts with inflammation because of fibrosis. So fibrotic development is very important aspect of chronic GVHD, which limits the organ function, impairs quality of life, and ultimately leads to severe impairment and occasionally causes death because of severe impairment. And this is how the organs are involved from top to bottom, from skin to any internal organ. Usually the most common organs are skin and mucosa, and sometimes also very common internal organs like liver and lung. Lung involvement is actually very troublesome, especially if there is bronchiolitis obliterans syndrome. It becomes an important cause of mortality because it's very difficult to treat, and it's very difficult to reverse the condition. So this is one of the severe symptoms of chronic GVHD. So basically, chronic GVHD in any organ, in skin, mucosa, it impairs quality of life very severely if it's not controlled in time. In fact, I have seen patients with mucosal chronic GVHD later on developing a cancer in the mouth. So patient with aplastic anemia transplanted way back of the mucosa, and say about 6 to 7 years later, the patient developed oral cancer because of chronic inflammation and fibrosis in the mucosa. So even this kind of chronic sequelae can be seen after chronic GVHD. So we can see that skin, mucosa, and eyes are most commonly involved, while GI tract is also fairly commonly involved. Less commonly involved systems are joint and fascia, lungs, and liver. There are 2014 NIH consensus guidelines or criteria for the diagnosis, and they have diagnostic signs and symptoms. If they are present, then we don't need to do any biopsy, and they can itself be diagnostic of chronic GVHD. While there are distinctive criteria which can help in the diagnosis, but then we need a biopsy or lab test to confirm the diagnosis. Then there can be other associated features for chronic GVHD as well. And there is a scoring system for assessment of severity. So if the score is 1 up to 1 in 1 or 2 organs, then we call it mild chronic GVHD. If there more than 2 organs are involved, or if the score is more than 1 for any organ, or if the lung score of 1, then we call it moderate GVHD, which is actually most common form. So if we properly do a scoring of a patient symptom, most of the patients will fall into this moderate GVHD bracket. Severe GVHD is called when more than 1 organ is involved with 3 or a higher score, or lung score of 2 to 3. So that way, actually, GVHD scoring requires a lot of efforts. We should have a keep in our clinics, and then we should mark each and every organ symptoms in the sheet. And that way we do. So that's how a correct scoring is possible for GVHD assessment. Coming to treatment, so first line treatment is usually steroids, corticosteroid with or without a cyclosporin tacrolimus. So steroid is first line treatment. Some may prefer to combine it with a calcineurin inhibitor, while steroid monotherapy is also as good as combination therapy. We usually prefer steroid monotherapy if patient is already off CNI, and if patient is already on CNI, then we can introduce steroid over it. So first line therapy is usually steroids. If it fails, which usually happens in 60 to 70% of the patients, as soon as we try to withdraw the steroid or taper off the steroid, the symptoms recur or worsen, which can happen in up to 70% of the patients. And then second line therapy is required. And even if it fails, then third line therapy is required. So commonly used second line therapy were ruxolitinib, which is now most commonly used second line therapy, and sometimes even in first line. Then ibrutinib is also one of the approved therapy. Other therapies are imatinib, rituximab, and then CMI, basiliximab, etanercept, and azathioprine. So these therapies can be added on the ongoing steroid or ruxolitinib therapy. So these are second line therapies. And if these therapies fails, then we actually are not having any good third line therapy or any third line agent to treat such kind of chronic GVHD. So it's a kind of a condition where we desperately need one of the good molecule to treat such patients. And here comes the role of targeted therapies, and to know something about the mechanism, the pathways involved in chronic GVHD, the inflammation, the fibrosis. So the ROC is one of the pathways, that is Rho-associated coiled kinase, one of the molecules involved in inflammation as well as fibrosis. The BTK, a well-known B cell receptor pathway, and then the JAK pathway and interleukin-2. So all these are involved in pathogenesis of chronic GVHD, and we should target one of the pathway. So JAK pathway is already being targeted by JAK inhibitor, the Jakavi. The BTK pathway is inhibited by your BTK inhibitors like ibrutinib. So these two agents are already in use. And the third one is ROC pathway. So here comes the, so now we are discussing about belumosudil, which is a ROC2 inhibitor. Belumosudil basically, I think I was given 30 minutes. So that's why I was going slow, but it's okay. So basically, belumosudil acts to balance the pro and anti-inflammatory pathways. So it increases Tregs and downregulates T helper 17 or STAT3 pathway. So downregulates inflammatory while upregulates anti-inflammatory pathways. And the ROC molecule plays a central role in mediation of prefibrotic molecules, prefibrotic transcription factors. So ROC is a molecule which plays an important role in upregulation of prefibrotic transcription factors. So that way, ROC is an important mediator of inflammation to fibrosis. Belumosudil is a drug which basically, via activation of the STAT, decreases activation of the STAT3 and triggering the significant downregulation of the T helper cells, leading to downregulation of the pro-inflammatory cytokines. And at the same time, it increases STAT5 phosphorylation and regulation of the Treg cells. Similarly, it also impedes prefibrotic signals via MRTF plus G-actin. So that way, it reduces inflammation and reduces fibrosis. So the indication, the FDA approval for belumosudil comes for adult patients and pediatric patients who are more than 12 years of age, who already have received 2 prior lines of therapy for chronic GVHD. The recommended dose is 200 milligrams given orally once a day after meals. And the treatment should continue till there is a progression of symptoms or if it fails. Or if patient achieves a CR, then you can gradually take it off. Otherwise, it's a prolonged treatment, chronic treatment. So there is some repetition in the slides. This is how velimosidil inhibits ROCK2, inhibits inflammation as well as fibrosis. Some repetition in the slide, and this is photographic. This demonstration of velimosidil molecule attaching to the ROCK2 kinase molecule and thereby affecting STAT signaling and prefibrotic inhibition of prefibrotic molecules. The trials, coming to the trials, the pivotal ROCKSTAR study, it was designed for patients who were more than 12 years of age and has active chronic GVHD with 2 to 5 prior lines of therapy for chronic GVHD. And the stratification factors were prior ibrutinib, yes, no, and severe chronic GVHD, yes, no. And 2 arms were 200 milligrams once a day and twice a day. So it was simple trial, we can say single arm study. 2 doses were compared. Primary endpoint was overall response rates. And here 200 milligram once a day dosing achieved 74% ORR, overall response rate. While the CR were less commonly seen, only 5%. PR was more common, 69%. But it was found to be statistically better as compared to historical pre-specified controls. So this is how 200 milligram once a day dose was found to be better than any historical control. The responses were better when it's used early in the treatment of chronic GVHD, say after 2 lines failure. If it's given after 3 or 4 line failure, the outcome was little poor. And the rest of the factors were almost same. I mean, whatever the underlying condition or pre-condition was there, the overall response rate was at least 65% in worst condition, and it was as good as 90% in patients when it's given early in the course of chronic GVHD. And most importantly, the organs which benefited most were skin, eyes, mucosa, joint and fascia. Least commonly benefited organ was GIT. So GI GVHD, it's difficult to treat even with velimosidil, while joint, fascia, skin, mouth were responded very well. Lung GVHD also showed some response, nearly 27% of the patients. And the duration of response was maintained in most patients even at the end of 24-40 weeks. The best response were achieved by the end of 12 weeks. So most of the patients who responded achieved the response by the end of 12 weeks. The failure-free survival rates with velimosidil, the secondary endpoint, we can see that at 18 months, 48% were still benefiting, and at the end of 24 months, 43% of the patients were still benefiting from velimosidil. Overall survival rates were 85%. Definitely, it's good, but it can be seen with any other therapies as well. So, exploratory analysis of symptom score showed meaningful improvement in patient-informed, patient-reported quality of life. Nearly 58% of the patients achieved a better score and 7-point reduction in Lee symptom score, summary score with velimosidil. So both responders and even non-responders had some improvement of quality of life. And we can see that dose reduction of steroid and CNI were possible in nearly 50 and 30% of the patients, while nearly 20% of the patients were off steroid therapy and CNI therapy after starting velimosidil. So it was, and finally it was well tolerated as well. The adverse events were seen less commonly. Only one fatal event was seen one patient who had severe nausea, vomiting, diarrhea, and leading to multi-organ failure. Nausea was a problem actually. Severe nausea lead to discontinuation of Belumosudil in 3% of the patient, while rest of the adverse events were well manageable. Most commonly seen adverse events were infections, asthenia, nausea, diarrhea, dyspnea, cough, edema, hemorrhage, abdominal pain, musculoskeletal pain, headache, and some laboratory abnormalities. And there was only one report of CMV reactivation during Belumosudil treatment during 2 trials, important trials of Belumosudil. Chronic GVHD treatment after 2 or more trial lines, 3-year follow-up of the Rockstar study. Again, the overall response rate is 74% for once-a-day dosing, 76% for twice-a-day dosing. So overall, the recommended dose is once a day, 200 milligram once a day. And the failure-free survival is nearly 40% for whether it's intention to treat or investigator assessment. So 40 to 50% of the patient were still failure-free at the end of 42 months. And the EBMT guidelines updated in 2024 that in adults with steroid refractory chronic GVHD, Belumosudil is a potential therapeutic option. Class 2C guideline, a Class 2C recommendation, encouraging overall response rate in non-randomized trials, showing a low drug-induced toxicity profile. So that way, it's a Class 2 recommendation. Subgroup consideration was that patients at risk of infection or cytopenia might benefit from low toxicity profile of Belumosudil. So that way, it's a promising agent, but it's a bit costly. It's very difficult to procure for most of Indian patients because of the high cost. So from this platform, I request Sanofi to bring some more attractive patient assistance program for this new molecule, and it's really good molecule. I believe that many of the patients will be benefited from Belumosudil if it's treated in many patients. Thanks a lot. Any questions? Thank you very much.
Thank you so much, sir, for the insightful session. Continuing with the academic saga, I would now like to invite Dr. Vipul Seth to talk on the role of inotuzumab in the evolving landscape of adult relapsed refractory ALL.
Hi. Good evening, everyone. Again, thank you for the invite. I will not take much time. Anyways, I cut down the time. It's supposed to be 20 minutes, but I will finish in 20 minutes. So this is again a sponsored talk from for inotuzumab. This is pure clinical, so I'm not going to talk any science here. This is role of inotuzumab in relapsed refractory ALL. So relapsed refractory ALL, it's very poor prognosis. I'll just put on the pointer. And as the number of lines go on increasing, the responses are going to go less, and you see median overall survival, it's hardly months, right? So whatever you do as a bridge so that you can do another transplant. And then, so the AML cure rates also decreases with age. So if you're young, not as low as 1 year, but somewhere between 2 to 15, you'll do great. But as you go on increasing with age, the outcomes with AML, as everyone knows, will go on reducing. So the whole thing is like, in good old days, of course, when I was doing residency and all, we had only chemotherapy for salvage, and there was lack of any immunotherapy in the AML field. With inotuzumab and Glina coming and now CAR-T cells, the field is widely open. And switching from salvage chemo to immunotherapy is much easier because the chemotherapy is not gone, but you reduce the dose of chemotherapy so that the side effects are lesser and you get more responses. These are 3 kids on the block. Rituximab was during that time also. Very infrequently used here, but abroad, yes, in UK it was standard of care, and even in US, anyone having CD20 positive It did show overall survival benefit, but you have to know that it has to be used in many doses, at least 16 doses. Inotuzumab is a new bit of a block with which has a linker, and it has a payload if it drops into the cell after binding to the cell. And blinatumomab, as everyone knows, it's like a magnet. So it's basically a magnet between CD19, which is expressed on the leukemic cells, and the CD and it brings T cells. So it has got a CD3 binder, it has got CD19 binder, and brings both together. It is pretty much like CARs, but in CARs you're transducing the T cells so that they can go and bind to the tumor. But blinatumomab is pretty much a magnet. Inotuzumab is a payload. So this is the dosage and administration of inotuzumab when it first came. It was used as a single agent. The first dose is always 0.8 followed by 0.5 milligram per meter square. I mean, in India, it's very difficult because of the cost issues. So we use 1 milligram flat dose, which would come to around 0.5 milligram per meter square for any adult. In pediatrics, it is difficult because you'll be wasting a while. But the optimal dosing is this. But this is without combination of chemotherapy. In subsequent cycles, you continue with 0.5 milligram per meter square if you have achieved remission to a cumulative dose of at least 2.7 milligram per meter square in total. If you have not achieved remission, then you'll again go back to 0.8 because that's the dose that you'll achieve remission. And like again, this is without chemotherapy. The drug came in without chemotherapy backbone. So this is the Innovate trial from Dr. Kantarjian and MD Anderson. This is an NEJM article. This is where inotuzumab received FDA approval. It was tried as a single agent for relapsed refractory ALL, more than 2 lines, 3 lines. Now people know that you have to bring it faster earlier. But a single agent compared to any salvage chemotherapy, you see the responses are much more, they are durable. Patients can undergo transplant. Obviously, in ALL field, you know that only those patients can undergo transplant that get response. If you are going to have refractory disease, even after transplant, you are going to immediately relapse because of very poor GVL effect, unlike AML. So this drug made it possible for patients to go to transplant and also have some kind of durable responses, even compared to multiple chemotherapy agents. So, but we have to finally move. Finally, we have to move beyond what is there. So, this was used as salvage therapy for second and third line. But now people are thinking whether it is good for first and second salvage. I'll come to the data. Whether it can be used as first line. So, first line data I'm not presenting because this is only for relapsed refractory ALL. But I'll say there are many trials that have happened, and most of them are negative. It is mostly to do with the side effect profile and lots of toxicities. But second line definitely, whether first salvage, second salvage, whether pH positive or negative patients, whether it can be used as a bridge to CAR. So this is a very fascinating field because you can't use blina as a bridge to CAR because you cannot do a CD19 directed therapy before CAR-T cell. So this is probably a good bridge to CARs, bridge to transplant, irrespective of the blast percentage, and then whether it can be used post-transplant relapse and for extramedullary disease. So this is the salvage status. So as you see, when you use the first salvage, the responses are up to 80% as compared to any conventional chemo, which nobody uses nowadays. Second salvage, the responses will go down. And all we care for inotuzumab is durable response so that you can bridge to transplant. Again, you see when you use the first salvage, the responses are much better. There is an overall survival advantage when you use it prior to second relapse, second or further relapses. And again, the question whether blast count matters, I think anybody using INO knows that blast count does not matter. Whether it's 80%, 90%, it does bring you to remission, whether single agent or with chemotherapy. I think in India, chemotherapy with INO is a more lucrative option because of the cost issues. You can come down on the dose of INO and probably 1 or 2 doses you will get remission as compared to single agent where you will first time get remission with at least 3 doses or beyond. And the next question is post-transplant. So this is an unexplored field. We use lots and lots of post-transplant. I know at Seattle. There is good data from MD Anderson also. And that is from Betuloran. This is from Professor D. Lema. This is a prospective trial. They used, I know, but you have to know the caveat. If you read the full manuscript, lots of the patients were pre-transplant MRD positive. You know that pre-transplant MRD positive is not going to have good outcomes with transplant for ALL because of lack of very good GVL effects. So these patients could still maintain durable remission using post-transplant INO. Also, you have to know the optimal time when you can start to prevent VOD and also the doses, right? exactly similar to what we use for service strategy. But yes, post-transplant I know is an option. Post-transplant I know combined with DLI is also an option. And the last is extramedullary disease. So the biggest competitor to INO is blinatumomab, which everyone knows is not very great for extramedullary disease, though blina is good for CNS disease because it causes CD3 cells to go into CNS. But inotuzumab is pretty much it's reasonably good. I think nothing works for extramedullary disease, not even transplant. So probably the best dose it has for INO. I still remember a patient in Seattle that we treated having a bilirubin of 20 with liver failure, I think 18 or something. And it's an absolute contraindication to use INO for a liver failure patient. But all the liver lesions are because of ALL. It was biopsy proven. I think it was Dr. Cassidy's call that time that we will give this because there is nothing else that we can do. We can't even take him to transplant. And we gave it with half dose. We started with that along with mini CVD backbone or some chemo backbone that we followed Seattle. And the patient was in complete remission, I'll tell you, after 3-4 doses, and the bilirubin actually normalized. So even with very bad liver disease, it could be tried, but under certain situations, but it is good for extramedullary disease. And the bridge to CAR, of course, I said it's a lucrative option because you would have run out of options by the time you go to CAR. So in order to debulk, you'll have to do something because you're not going to just give CAR in a refractory disease. You can, but then you expect a lot of cytokine storm and not durable remission. So INO is pretty much used as a bridge to CAR-T cells. Those that respond do phenomenally well. So it is also a surrogate marker to tell you who's going to do well with CARs. Those that respond well to INO will do with CARs. Those who do not respond well to INO probably might not do well with CARs. But you have to know that you cannot cross a particular dose limit before CAR because you will have lots of microangiopathy and then finally CRS is microangiopathy. So you'll end up with more CRS and you'll have to have a time gap between, you'll have to have a washout between INO and CARs. Not for the INO drug itself, but also for the normal B cell recovery because you're getting INO and CAR requires B cell for its expansion. So Philadelphia positives, I'm quite surprised. So these slides are given, but for Philadelphia positive, it's good. INO is a good option. But it was compared to blina. I'll come to slides later. Blina is much more lucrative option for Philadelphia positive. In fact, in the West, we are not even doing transplants. When we combine blinatumomab with ponatinib or any of the third generation TKI, INO is also a very good option. The only problem is when you combine it with dasatinib or something, you have very high incidence of hepatotoxicity and microangiopathy. So we used to do a lot of E6 scoring before we used to use these two in combination, but it works very well for Ph positive ALL. So this is like which patients are ideal for HSCT. Obviously, less than 65, depending on center. I mean, Seattle, they take also 80 and 90 years old, but this is pretty much for India. You would keep a cutoff of 65. With performance status, it is very important. Your HCT-CI index should be very good. And now there are multiple indexes, right? There is DRI, there is HCT-CI, there is HSCT scoring from SORAD. So you'll take everything into account. MRD negative complete remission is the best to take for HSCT for ALL as compared to AML, where you can take AML MRD positive disease as well as refractory disease. No prior HSCT is better. Second transplant is always bad, and of course, adequate social support. And this is the safety profile. Without HSCT, you see maximum 5.9% incidence of VOD. In that in second salvage, I've hardly seen any VOD happen for first salvage or second salvage. Most of us would not have seen it with chemo. Post HSCT setting, definitely, but this is in the era when we didn't know what to do. Now with timely gap between HSCT pre and post, there is not such high incidence, and we also take care of VOD better in a prophylactic way, but it can go up to the tune of 20%. So you have to be very careful. You have to have adequate washout period between INO and transplant, and also if you use it post-transplant, like I said. And these are treatment considerations proceeding to HSCT. So when you plan to do HSCT post-INO, just take care that there are no dual alphylators. I mean, nowadays post-PSA is very happening. So that itself is an alphylator, which people do forget. We consider it as GVHD prophylaxis, but you are going to use trio, busulfan upfront or melphalan. So you are dealing with dual alphylating agents, so you will have to take better care of VOD then. Treatment duration recommended is not more than 2 cycles. I mean, up to 3 cycles is pretty safe, but beyond three, I mean, beyond 3 doses, there is real risk of VOD. Total bilirubin should not be more than upper limit of normal.
GOT-PT, we used to rely a lot on MRI scan when I was in Seattle, even here in India. But more than MRI, there is lots of data on fibroelastoscan. If your elastoscan is good, then the risk of VOD is very less. There are prospective studies on this also. So probably this is a good biomarker of taking them for transplant. And you will have to give all kind of prophylactic agent like urocidol for definitely, and a very high dose if you are taking very high risk transplant. So this is a comparative between Blina and INO. Both are very good, and the third should have been CAR-T cells. But I think CAR-T cells is in a different space because Blina upfront is curative without transplant or CAR-T cells, but you would have to give at least 6 cycles, and you can do the costing. 1 cycle of Blina is more expensive than CARs, so it's not a good option. So more or less you're using Blina as salvage and bridge to transplant as well as INO. So these are good comparators as bridging treatment. I'm not comparing it to CARs because probably you're using one of these two to build the patient for CARs. In case of logistics, definitely INO is better, but Blina is also going to come in subcute route, which is much better. It's much more potent. The kinetics is also better, and the side effects are less. So that time probably the logistics will be better with both. MRD eradication, I will say INO is stronger. Blina is good, but if you are taking low burden disease, maintenance and re-challenge, again it's similar. Underlying serious disease, I'm surprised because this slide was given, but Blina definitely, CD3 cells cross the blood-brain barrier and it goes to the brain. I don't know if INO ever crosses blood-brain barrier. There is no literature at all. I probably feel from this slide they were referring to the extramedullary disease, because in extramedullary disease INO does work very well. For liver dysfunction, you will have to choose Blina over INO because of its hepatotoxicity. Prior HSCT, definitely Blina is an H because it does not cause this VOD issue, but you know, if you use post-transplant Blina, you land up in severe chronic GVHD. So not one thing is without a caveat. With INO, you will not land up in chronic GVHD, but you might land up in VOD. High tumor burden, definitely INO over Blina. pH positive ALL, again this is plus for INO, but I'll say Blina is pretty much standard of care for pH positive ALL along with third generation TKI. So this is just a conclusion and summary. In the past decade, many immunotherapies, at least 3 big agents have come up a long way. 2 mainly for bridging, so that you can give a definitive treatment, which is either transplant or CAR-T cells. Inotuzumab can be used as a single agent in ALL. For pediatric, for sure, maximum data is with single, even for adult, but I think we combine with chemo just for the cost benefit. It is highly effective in relapsed refractory ALL, causing CR rates of 80 to 90%, and even MRD negativity within 1 cycle, which is 3 doses of INO. It is effective in very high burden disease. The toxicity profile is quite easy unless it is peri-transplant, and the goal is, I would say, most of the relapsed refractory patients should be using one of these novel agents so that you can take them to HSCT. Otherwise, taking them to HSCT becomes very difficult with salvage chemotherapy. Thank you. I'm making questions. Can't hear you.
You didn't mention Blina related GVHD. I'm not aware, sir. Can you expand over it? Like why and how? Versus inotuzumab. What makes?
Because it's a CD3. End of the day, it's CD3, right? Your chronic you have all your T cells. We have not seen so much of Blina. I mean, the dose post-transplant is very different from what you use pre-transplant, and when you combine Blina with DLI, that is the time that it's much of GVHD. Single agent Blina, it's not so much.
Okay. Yeah, with DLI. Okay, right.
Okay, we'd just like to thank everyone. Thank you very much.
Thank you so much, sir. Next, I would now like to invite Dr. Pawan Kumar Singh to share the real world evidence of next CAR-19. Uh,
Okay. Good evening. Sorry for delay. Okay. So, thank you, organizers, and I'll be presenting these data, and the slides have been provided to me by Immunoact, and we'll be discussing about the real world evidence of the CAR T cell, that is next CAR-19. So CAR T cell, a lot of development is being done in our country, and in the past we have seen approvals coming in for ALL, for AML, CD19 CARs. So in India also, we have seen that in past 2 years, the CAR T cell, this is the most advanced form of cancer therapy. We can call it as a living drug, and it has shown promising results in CD19 malignancies, whether it is leukemias or lymphomas. So particularly those who are very relapsed or in refractory settings, also there also it has shown very promising results. So in multiple refractory settings also it's seen, and even the durability of response has also been reported. So the pioneering work in India was done by Immunoact, and this led to the approval of CD19 CAR for the treatment of CD19 positive B cell malignancies. So it is the world's first humanized CAR T cell therapy, that is Telicel, and it has comparable and efficacy, and I can say that better safety profile as compared to others in terms of the adverse events. So lower cytokine production and lower risk of CRS, and it has SPOR1BB as co-stimulatory domain, which is causing the long-lasting memory CAR T cell. So I'll discuss about the real world data. In first we'll see the leukemia. So in leukemia, so the almost this is old data of total of 145 leukemia patients were enrolled in 40 treatment centers across India, and it has reached across all major zones of India except for in the central zone. Otherwise, majority of patients were in the western and southern zone, and so real world experience, if we see in the leukemia cohort, so it was evaluated in real world high risk relapse refractory leukemia population with the multiple prior therapies and aggressive disease characteristics. So we can see that the median age was 30 years, range is 15 to 78 years, and so this was the you can see that the rapid and deeper remission. So overall response rates close to 90% at day 28 with the CR rates of 87%, and they had sustained clinical benefits with 76% OR rates at 3 months and 75% CR rates. And at 1 year follow-up also we can see here that the PFS rates at 6 months 71% and 1 year 57% with overall survival 84 and 68% respectively. So Telicel compared to comparable real world efficacy to globally approved CAR T cell for relapse refractory B-ALL, and the Tezacel and Brexucel when it is compared with that, so almost can see here that the PFS rates are almost close to similar outcomes. So in the progression-free survival also, we can see here that the numerically superior PFS rates were seen in NextCar, and the overall survival also we can see here that it is almost comparable. So comparing now coming to the subset analysis, so blast percentage. So this was the significant data which was part of which has come out in this. So those patients who had before CAR-T cell infusion, if the blast percentage less than 5% and more than 5%. So those who have less burden of disease, lower blast percentage less than 5%, it correlates with significant better PFS and overall survival rates, and even at longer follow-up also. And if we see the prior lines of therapy the patient had received, so in first patients we can see here that the number of lines of therapy 1, 2 and more than equal to 3. So here also we can see here that the patient, if the CAR-T cell is given in earlier lines of therapy, then it has better outcomes in terms of PFS and overall survival. So early intervention, it showed the good results. Now safety data, if we see lower CRS rates, almost 7% and ICANS 5%, and manageable and predictable safety profile. Now, so this was the comparison. So overall response rates almost comparable with the 77%, and the side effect profile is lesser as compared to the already approved T-cell and Registry in US. Now coming to the lymphoma, so this is the lymphoma. So almost every part of the India, we can see here that majority west and southern zone, then north zone, and total 194 patients across 60 centers have been administered. So this is the cohort, the baseline characteristics. It was mostly in relapsed refractory setting patients with prior multiple lines of therapies and advanced disease characteristics. So here we can see that the sustained progression-free survival and overall survival, first we'll see the response rates, overall response rate 75%, and the majority had CR close to 60%. Then sustained clinical benefits at follow-up at 3 months, 61%, 57%. And at 1 year follow-up, if we see the PFS rates were 40%, overall survival rate 63%. Coming to the subset analysis, so all patient non-bulky. So those patients who had less bulky disease, they are likely to do better. So PFS and overall survival rates were better in patient who had non-bulky disease. Now, the efficacy to globally approved like Axi-cell, T-cell and Liso-cell. So there also we can see here that the PFS rates, it is almost comparable with the earlier approved lines of therapy. So overall survival rate and progression-free survival rates is comparable to the already approved therapies in the West. And safety profile, we can see here that ICANS and CRS, these are less. Hypogammaglobulinemia, again, this was seen, but not significant. So we can manage that with the IVIG supplementation. And comparing the efficacy and the better safety profile. So this is means it has safety profile is better than the other CAR-T cells which is approved in the West. So this is the manufacturing excellence which has been attained by ImmunoACT. So if we see the manufacturing processes, so you can look at transduction efficacy 49%. I'll just see the comparative data. So of other approved therapies, this is the overall manufacturing success rate 95%, 96%, and in the telecell that is 98%. Transduction efficacy, it is almost comparable, and we can see here that the vein to vein time is also comparable with the already approved. So quality compliance, this is the stringent processes which is being followed. So these are the various approvals and the quality standards which have been given to this product. So this is how it is different from the first thing is that it is world's first humanized CAR-T cell therapy, and that reduces the cytokine rates and significantly reduced toxicity rates. Then it is the manufacturing process is there, so it is very scalable and it can increase the number of this and the trial data also, though it is short follow, but comparable results with the Western CAR-T cell. So I think till date 400 infusions have been done, and so finally to conclude, so Telecel demonstrated strong and durable clinical benefits in real-world relapse refractory leukemia or lymphoma in B cell, and high early response rates with deeper CRs achieved, lower incidence of CRS and ICANS, and so it supports the wider clinical feasibility, reliable, scalable, and independent manufacturing process. So overall, it delivers meaningful outcomes with a favorable benefit risk profile in patients with relapsed refractory leukemia and lymphoma. Thank you.
Are there any questions? So I will ask one question. In CAR-T cell therapy, what do you feel is the role of ctDNA monitoring? Number one. Number two, my second question is, does the baseline genomics help in, do you think it is going to help in triaging who will benefit from a transplant versus a CAR-T cell?
So in the previous I had debate about using upfront CAR-T cell versus autologous transplant. So as of now, there is data is not there about upfront CAR-T cell in high-risk patients. So first thing is that it is very important. We know that 40% of DLBCLs are not going to do well. So we have to recognize these patients early, and the important tool to recognize, obviously NGS is there. There are other parameters like high IPI scores and other means clinical parameters, and other one is obviously the genomics. So like TP53 lymphomas, we know that they are not going to do well. So these are the set of patients where I believe that intensifying therapy would be beneficial. Now coming to how to intensify that, obviously we don't have any data at present to support that, and even Zuma 23 trial is there that, but I'm not happy. We are not going to get the answer about that because they are not comparing that data with ASCT. So they are comparing with chemo, with comparing with upfront CAR-T cell. So obviously these group of patients, like high risk patients, they are likely to be, they should be intensified in the upfront setting itself. So one thing is that ctDNA, you mentioned about that, it is very important to monitor these kind of patients because even we know that the long-term outcomes in high-risk DLBCLs also, or in leukemia, it is not. So ctDNA is now it is being validated and it is being used in lymphoma settings. So particularly when we talk about lymphoma, so monitoring is very important because ultimately long-term outcome is even with immunoact data is also it is like PFS is only 40%. So monitoring is very important because we have to recognize these patients if they are likely to relapse by monitoring ctDNA. Sometimes we monitor with B-cell aplasias like that. So these are the ones where we should be more careful and maybe intensify with other therapies so that we can do that.
And how do you see the patient selection as because we have all heard that the CAR-T cell does not work so well. People keeps on relapsing. How do you think in your now almost 1.5 years of experience, is that the patient selection or is it only the CAR-T cell? I mean, you have a bulk of disease and you take it and your patient relapses, or it's a small disease which you have to do, or you have to reduce the bulk. How do you see the future?
So yeah, obviously, as far as data is concerned and our experience also is there. So those patients who are not responding to initial therapy. So ultimately, if we do CAR-T cell in non-bulky disease, these are the patients who are going to respond and they are likely to have long-term good benefit. So we have to control the disease. But sometimes when very high-risk patient, I call them as in fact in the REFINE study that they have mentioned that these group of patients as ultra high-risk patients. So these are the ones like TP53, they are not going to respond to initial therapy also. So to control the disease, and it is very important. So even before CAR-T cell, sometimes we have to give some bridging therapies to control the disease. So these are important things which need to be considered. Obviously, patient selection is there, but yes, good control of disease is important.
I can bombard you with one more question from Genomics, but we are trying immune transcriptomics in CAR-T cell patients. How much would you be open to use it? In the sense, what we are trying to do is the IL-1, IL-2, IL-6, TNF-alpha. We are going to the mRNA level rather than the serology, which kind of picks it up before it actually converts to serology. So, would you intervene? What would you do? What do you think for predicting CRS, that is?
Yeah. When we talk about like CRS is there, so disease characteristic is there, when sometimes patient characteristics are also very important. So like some patients who develop CRS, not every patient develop grade 3-4 CRS. So these factors are there which we can so I don't have much knowledge about that. So you have to enlighten us about using transcriptomics to look for these interleukins and cytokines who can predict the patients who are likely to develop high risk CRS. So obviously, if we can detect, and we should be more preemptive in treating that or using tocilizumab prophylactically more in these cases.
Okay. Thank you. Thank you, sir. Thank you so much. If there are no more questions, take care. Thank you.
Thank you.
So for the next session, we will have the later session first, and then we'll have the debate because Dr. Amrita Ramaswamy is just reaching in another 10 minutes. I will request. So the next presentation is by Fortis Healthcare Research Foundation. And we have our principal research head, Dr. Kuldeep Chauhan from Fortis Healthcare Research Foundation from Fortis Healthcare. We are going to showcase what Fortis does in terms of research and what all portfolio do we have in Fortis. Thank you.
Good evening, everyone. So, in the meantime, we are going to go ahead with presentation. My name is Dr. Kuldeep K. Chauhan, and I am heading the research operations at Fortis Group of Hospitals. So, there is a famous saying that if you want to assess the medical capacity of any institution, it can be assessed through the number of impactful publications the country is having. Right. So, with this thought, we will discuss what we are doing in research domain. So the Fortis Healthcare Research Foundation, it's a dedicated research unit at Fortis Healthcare, and our vision of our department is to promote education and research for the benefit of mankind. So this fellow is my friend. I think everybody remember about Rancho Das Chanja Das Chanchar, Rancho. So what he said, what's the point of blindly framing about the bookish definition? So in line with this, so when we are doing medical research, so we should aware that we should know that we should have a detailed understanding of the concept behind study specific operational plan we are doing, what is the objective of the study, and how we can conduct a study successfully. Nowadays, investigators like Dr. Rahul Bhargava, they are facing lots of challenges, like in patient recruitment sometimes. Sometimes capacity building is also an issue where the investigators like him, they may not get the appropriate support for conduct of clinical trial. But we at Fortis Healthcare, we have defined our research division. So we are going to discuss key facts first and what are the strength of the research department at Fortis. We will discuss our short-term and long-term plans and how Fortis can support in the drug development process. So these are some interesting facts. You will be surprised to know that India is having around 17% of the world population and 20% of the global disease burden. Yet we are only participating in less than 2% of global clinical trial. I understand that there are some gray areas at regulatory level, but once this, now we have NDCT in place, so slowly this number is being increased. There are some FDA audit findings, common inspection finding from the data that 51% violated from the investigational plan. Means your consent of the research participants are sometimes missing, and there are unapproved protocol deviations. 33% queries are related to GDP, good documentation practices, and 7% related to poor drug accountability at research site level. According to the data of clinicaltrial.gov, this is a huge number that 3 to 46% of the clinical trial, most of them, there is a recruitment failure, and it is due to the stringent inclusion and exclusion criteria. Sometimes there are complex study visits where patients are not able to comply with the requirement of the study. So what is the consequences of this? There is lack of resources, and the patients are being deprived for getting the treatment on time, and we are going to unmet the trial objectives. So these are the details of top 3 highly regulated industry, and medical and healthcare research is on the top. So world population is 8.5 to 9 billion, and healthcare and research professionals, they are 0.01. So kind of responsibilities these healthcare and research professionals are having, it's on and about the aviation also and banking sector where financial stability is required. So let's understand the requirement of Fortis Healthcare and how we are conducting the medical research. So the department is having extensive experience. We have successfully conducted 1800 plus clinical research project and 600 plus global clinical trial. All phases from phase 1 to phase 4, either real world evidence studies or the investigator initiated studies. This is one of the leading research centers in India that we are having 21 research sites with pool of trained investigators and data access to the data for the patient database. We are trusted by the industry leader. We are having the proven track records of working with top global pharmaceutical companies and CROs. Experienced team, like we are having expertise in conducting early phase and late phase clinical trial. Recently, under guidance of Dr. Rahul Bhargava sir, we have completely successfully completed phase 1 study CAR-T cell at FMRI. So strong academic support, and we are seeding with ethics culture. There are 15 ethics committee in India on behalf of Fortis, and all of our ethics committees are registered with DCGI, NABH and DHR. We are having well-defined clinical trial management system. Patient safety is the paramount. So we are having dedicated committees which are responsible to review the age and assays being occurred during conduct of clinical trials. Research infrastructure at all sites, not at FMRI, at all sites, we are having dedicated space to conduct the research activities in terms of storage of investigational product, equipment, everything. Right tools. So every professional is required right tools. There are 52 SOPs which guide you from the development of the protocols, study startup activities and close out of the project. So there are through this dedicated research facility in Fortis Hospital has also provided the supports like access to NABL lab, having established hospital information system, radiology support in case we need to conduct screening parameters, mainly X-ray, CT scan, MRI, as a pre-screening procedures in the clinical trial. Archival supports in compliance with the global regulatory requirement, hospital IT supports, 24/7 power backup support to the research department, so we can manage the handling of investigational product and all investigational product to be stored at recommended storage conditions, data entry and data management tools. So how we run the research at Fortis? So we are working in different segments. On one hand side, we are conducting the industry-sponsored studies. We are doing intramural research, unfunded research. Mainly, doctors are taking care of data from the standard of care, and for the publication point of view, these studies are being approved by ethics committee, and we are going to go ahead. We are also participating in projects of national interest supported by the ICMR, and several educational activities are being done. So, research department at Fortis Healthcare, we are having a research advisory committee for all our 32 hospitals, where 40% of the members are external and 60% members are internal. In case we wish to conduct any kind of investigator-initiated studies, the network mode, so these committees are responsible to guide and mentor the research project so that it should be in line with the regulatory requirement. The department is having a central team which is working under the guidelines of head MSOG, and these are the professionals, those who are supporting our operations at all sites. And our research sites are distributed in tier 1 and tier 2 cities, the hospitals which are having bed capacity more than 200. So these are the details of the research sites which are having ethics committees and research professionals, those who are supporting the operations at different sites. So these are the details of tier 2 city sites, and this is the research project update Pen Fortis. So we, along with the industry sponsored studies, we are also doing several academic research projects and ERB proposals. And you will be happy to know that all these proposals are approved by ethics committee. And total of 142 industry sponsored studies are ongoing. And wherever you know that there are limitations when we are talking about early phase clinical trial, because as per the Indian FDA, the global sponsor can't conduct phase 1 directly in India, because they have to conduct in parent country first, then we can bring that. So that's why most of the studies are late phase clinical trial. So this is the framework of industry sponsored study. Earlier we used to restrict ourselves with cardiology and gastro, but nowadays from last 1 to 2 years, the oncology clinical trials and other therapeutic areas, we are having the expertise in terms of conducting early phase clinical trials and late phase clinical trials. So department is having the established communication so that whenever any kind of NCE or investigation product is in pipeline, we can interact with the sponsors, we can connect them with the required investigators, and so that studies should be conducted. So this is continuous learning is the key, where we believe we are conducting conferences, workshops for the our investigators, ethics committee. SABI is our one of the initiative. It is the talent acquisition between industry and academia, where Fortis is tackling the workforce crisis in the clinical research industry in India. So we have prepared 8 modules wherever research scholars are coming and they are getting access to learn the key concept behind the research operations. So Insight X is also under the creative profiles, where we are inviting the experts like you, those who are sharing their thoughts in the development of the proposals and in all therapeutic areas. So these experts are providing their expertise to all the stakeholders. So these are our some collaborators. Investigator profiling is one of the things where we are coordinating with an investigator, assessing their requirements and conducting the clinical trials. So one of the important things, these are our expansion plan, short terms and long terms goals. One of our goal is we are going to establish a tissue bank at Fortis, and we are going to register ourselves as a contract research organization. So to conclude with collaboration, we believe that collaboration is the key and data is the key to the process. So we would like to invite all the sponsors and CROs. Let's coordinate and do some indigenous research in India. Thank you. Thank you, everyone.
Thank you, Dr. Kuldeep, for a wonderful overview of the research which is happening. And I think the next decade will define us not only the commercial or for-profit organization, but for an organization which will lead in front with research and collaborations. So now much awaited debate, and I know this is the last debate of the day, but it's going to be very exciting because this is how the future is going to be shaped up in the coming days. For this, we'll have a chairperson, Shahrukh, who's a brilliant clinical hematologist. Dr. Das is there. Dr. Das, can you just come on the dais? The topic is debate for the post-transplant immunosuppression conventional versus PTCY, and two people who have been doing a remarkable job in daily hematology, Akash Kandilwal and Amrita Ramaswamy. It's our proud pleasure moment to have them debate. They are the best friends of the scene, but today we are going to see a fight between them, that who's going to win between this debate on PTCY versus conventional therapy. So as we can see, Dr. Amrita is walking first. So we will give her and ladies first and women empowerment on that theme. We will give Amrita first chance to speak on conventional PTCY as a post-transplant immunosuppression. So let's listen to this debate. This is going to be lively, and it's a paradigm shift because how we function in this country in terms of post-transplant immunosuppression. Over to Dr. Amrita.
So good evening, everybody. First of all, I'd like to thank Fortis Hospitals for giving me this opportunity and Dr. Rahul Bhargav for giving me this opportunity. I thought I would go in second, but then being the lady, I think I've come in first. So when we talk about GVHD prophylaxis, I mean, obviously this is the last session of the day. So when I'm going to start talking about GVHD prophylaxis, you're going to all sigh, right? So, but then when we talk about GVHD prophylaxis, if I ask you whether conventional or PTCY, again you will say conventional, sigh again. So sigh, there is a pun on the word. So we have to be talking about cyclophosphamide. That's the molecule that I'll be talking about, how it has changed the world of transplant, haploidentical transplant to begin with, and now it's moving on to matched unrelated donors and matched related donors as well. Now, I'll in the interest of time and also in the interest of respecting everybody's dinner time, I'll be quickly going through my slides, very short about how post-transplant cyclophosphamide works. What's the current evidence for PTCY-based GVHD prophylaxis in the matched related donor and in the matched unrelated donor setting, and how PTCY-based GVHD prophylaxis fares against conventional or standard GVHD prophylaxis. Now, all of us know that a very important complication of allogenic stem cell transplant is graft versus host disease, and as a hematologist, it should be our efforts to mitigate this very life-threatening, or I would say life-impacting side effect, which is graft versus host disease. So the acute GVHD incidence is around 30 to 70%, and the chronic GVHD incidence is around 20 to 50%. We have such a wide range because it would depend. In transplant, we have so many variables: the donor type, the conditioning that you use, the disease, the GVHD prophylaxis. So that's why we have such a wide variation in the incidence of both acute and chronic GVHD. And now GVHD contributes to around 15% of mortality in stem cell transplant, and chronic GVHD especially contributes to a significant morbidity. Now, if you look at historically, the GVHD prophylaxis that we have been using is a calcineurin inhibitor based regimen in which you combine a calcineurin inhibitor, which is either cyclosporin or tacrolimus, with other immunosuppressants. You would combine it with maybe methotrexate or mycophenolate mofetil, sometimes with sirolimus and sometimes with ATG. Now, PTCY, initially it was studied in rats, and once they demonstrated good effects in rats, it was adopted in the human setting. All of us know that cyclophosphamide is an alkylating agent. We are familiar with cyclophosphamide. We have used it in stem cell transplant and conditioning. We know that it is employed because it is highly immunosuppressive and it prevents graft rejection. When we talk about PTCY, the conventional dosing that we use is 50 milligram per kg for 2 consecutive days, and it's generally given on day 3 and 4. Though there are multiple trials looking at whether we can modify the dose of post-transplant cyclophosphamide and whether we can even change the timing up a bit. Now, when we talk about the mechanism of PTCY, because the timing of PTCY is so important, it depletes alloreactive T cells while sparing donor stem cells, and it also spares the Tregs because the Tregs tend to be resistant to the effects of cyclophosphamide and they survive the effect of PTCY. And Tregs are very important in maintaining immune tolerance. So with that, so all of us know that PTCY is like the standard of care in haploidentical transplant. We have the Chinese ATG protocol, but how many of us actually use the Chinese ATG protocol? We don't use because, for one, ATG is expensive. ATG is associated with its own side effects, infusion-related reactions, whereas PTCY is cheap, it is effective, and it can be easily administered. This is the simple reason why we really do not favor the Chinese protocol even in haploidentical transplants. We all do PTCY in haploidentical transplants. So should I say more? Even in the matched unrelated donor and the matched related donor setting, PTCY would be preferred because it is effective, as I will tell you. It is cost effective as well, and because of the ease of administration, does not involve any cellular manipulation at all. What I would like to point out, this is all in haploidentical transplant, where when you use PTCY, they use PTCY 1 dose, PTCY 2 doses with TAC and MMF. And what I would like to point out in these slides is the very, very low rates of chronic GVHD, acceptable acute GVHD rates. Very few of these were actually grade 3 to grade 4. And if you look at the non-relapse mortality, very, very acceptable non-relapse mortality in a haploidentical setting. Now, when you see in myeloablative conditioning, this was in RIC conditioning that we talked about, and the donor source, if you see, most of it is bone marrow. All of us know that the conventional or the standard Johns Hopkins protocol uses bone marrow as the source, whereas we tend to use peripheral blood stem cells. Now, when we even talk about myeloablative conditioning, again, PTCY with PAC and MMF, very, very acceptable non-relapse mortality rates and low chronic GVHD rates at 1 and 2 years. Now, obviously, all of us know we would like to do peripheral blood stem cells because, again, why? Because it is easy. It doesn't involve any anesthesia, doesn't involve taking the donor to the OT, limited donor risk. And again, it is because it is just easy to do. But obviously, all of us understand that peripheral blood stem cells come with their own problems. In malignancies, you have a higher T cell dose and obviously increased GVL effect, but then that would also contribute to a increased risk of chronic GVHD. So as you see, relapse rates are less with peripheral blood stem cells, whereas the chronic GVHD rates are higher and even the acute GVHD rates are higher if you use a peripheral blood stem cell as source. But that is what we would like to use. Now, why do we want to bring PTCY to the matched related donor and to the matched unrelated donor setting? If it is so effective in haploidentical transplant, why not try it in a matched unrelated donor, where all of us know that despite using ATG, we struggle with acute GVHD, steroid refractory GVHD. If it is so effective in the haploidentical setting, why not bring it to the matched unrelated and matched related donor setting? This is because of the success story of Psi-induced tolerance, acceptable rates of acute GVHD, low rates of chronic GVHD, and most important, low rates of non-relapse mortality. I will be repeatedly revisiting a term called GVHD-free, relapse-free survival, which is the single most important measure of the quality of life of a patient in the post-transplant period. And I would like to just say at the outset that if you look at the PTCY trials, all the trials which favor PTCY in the MUD setting and probably in the MRD setting also is because of the very, very low GVHD-free, relapse-free survival rates in multiple trials. Now, if we look at the first studies of PTCY was studied alone with myeloablative conditioning in matched related donor and matched unrelated donor transplant. I would like to point out that the stem cell source in these two studies was from the bone marrow. And it was a myeloablative conditioning regimen, BuFlu or BuPsy. And PTCY was used as a single agent. If you look at the chronic GVHD rates, again, less than 20%, 10% in the first study and 14% in the second study. And if you look at the non-relapse mortality, again, very, very low non-relapse mortality.
But if you look at even if you look at the acute GVHD rates, yes, a sizable number of patients did have acute GVHD, 43%. But if you look at the rates of grade 3 or 4 GVHD, it was 10 and 15% in both the trials. So if you look at PTCY alone in matched related donor and mud transplant, if you used bone marrow as source and if you used myeloablative conditioning, we had acceptable acute GVHD rates and very, very low chronic GVHD and non-relapse mortality rates. Even among the patients who had GVHD, most of them responded to steroids with another immunosuppressive agent and 20% responded to steroids alone. The advantage of using PTCY alone is because you do not have a CNI, you have a low immunosuppressive therapy burden. But obviously, do things differ if we changed up the stem cell source? Would things be different if we just took away the bone marrow source and if we put a peripheral blood stem cell source? Because that is what we would want. We would want a peripheral blood stem cell source because of faster engraftment, easy procurement, less infections, especially in our country, and better graft versus tumor effect. But disadvantages obviously would be, we know that peripheral blood stem cells are associated with higher rates of acute and chronic GVHD. So when they try to translate this by just changing the source of the stem cells from a bone marrow source to a peripheral blood stem cell source, in the matched related donor and in the matched unrelated donor setting, both these trials had to be terminated early because of unacceptably high acute GVHD rates. 80%, 4 out of 5 patients in this study, they developed acute GVHD, and 45% of patients in the second study developed 27% developed grade 3 to 4 acute GVHD. So there was then they thought, let's add another agent to post-transplant cyclophosphamide. So this was a study which looked at adding cyclosporin to post-transplant cyclophosphamide. Most patients, 77%, that's a big number, they developed acute GVHD grade 2, but if you see 0% of them developed grade 3 to 4 acute GVHD, and the TRM was pretty low, and the incidence of chronic GVHD at 1 year was also around 16%. Now this trial, this was actually a non-randomized study in which they compared PTCY, TAC and MMF. That is PTCY, the earlier study was with just one additional immunosuppressive agent, which was cyclosporin. Now this is with 2. They thought, let's try 2 and see whether we did better. So they added TAC and MMF to PTCY, and this study used myeloablative conditioning, Bucy or Buflu, peripheral blood stem cell source, and quite a number of patients were also mismatched unrelated donors, not just MUDs, mismatched unrelated donors, and they compared it historically to ATG with cyclosporin and methotrexate. I think that slide is missing. Yeah. So what I would like to point out, I think the lettering is actually quite small. If you look at the incidence of acute GVHD grade 2 to 4, it was 19% with PTCY. This is a historical comparison versus 45% if it was ATG based. And if you looked at grade 3 to 4 acute GVHD, it was just 4% with PTCY versus 27% with an ATG based GVHD prophylaxis regimen. If you look at the incidence of chronic GVHD, very, very significant p-value again. Though it is an indirect comparison, 16% with PTCY versus 65% in an ATG based regimen, and non-relapse mortality 16% with PTCY versus 36% with an ATG based regimen. And you can obviously look at this very important measure, which is the GRFS, which is the GVHD free relapse free survival. At 2 years, it was 52% with PTCY, TAC and MMF versus 12% with an ATG based regimen. So the results even though it's an indirect comparison, the results just speak for itself. Now again, there was an EBMT retrospective, just another 2 minutes, EBMT retrospective registry study, again in which they compared It was a retrospective study. They looked at 423 adults with AML and ALL who underwent a matched-related or an unrelated donor transplant. One group received PTCY alone. Another group received PTCY with one immunosuppressive agent, and the third group received PTCY with 2 immunosuppressive agents. And 143 patients, they received ATG in combination with PTCY, which is being studied in a few trials. If you look at the GVHD-free, relapse-free survival at 2 years, obviously the ones with PTCY and 2 immunosuppressive agents, they did the best. Now, the limitations are obviously it's a retrospective study. So, I just in a word to summarize, if you look at PTCY in the matched related donor and in the mud allo transplant setting, PTCY alone could be okay if you used bone marrow as a source, but if you would use peripheral blood stem cell as a source, obviously PTCY alone is not a good idea. You need to combine it with additional immunosuppression and preferably 2 immunosuppressive agents. Why do we keep harping about PTCY? Why do I say PTCY is better? We do not want to be giving patient calcineurin inhibitors for long because we know calcineurin inhibitors have their own problems. They are non-specific. They don't just deplete the alloreactive T cells, they act on T cells in general. They cause significant toxicities, renal toxicity, and they require therapeutic drug monitoring with a narrow therapeutic index, and they have multiple drug-drug interactions. PTCY has the advantage of being combined with various other agents like bortezomib. It has been studied in combination with sirolimus. I'll just like to end with the randomized trial. All of us say, it's indirect comparison. All these are phase 1, phase 2 trials. But then what I would like to say is, even a phase 3 trial, which is the BMT CTN 1703 trial, they studied PTCY, TAC, and MMF prophylaxis versus conventional cyclosporin methotrexate in around, it was around 214 patients in the experimental arm versus 217 patients in the standard prophylaxis arm. And the conclusion and the results of the study was the GVHD-free, relapse-free survival at 1 year was 52.7% for the experimental arm versus 34.9% for the standard prophylaxis arm. So in the RIC setting, in the RIC-allo setting, PTCY, TAC, and MMF fares much better than conventional prophylaxis, conventional GVHD prophylaxis. And for people who say PTCY can be quite toxic, it has cardiac toxicity, it is difficult to give it in older patients or patients with cardiac comorbidities, there are studies which are looking at intermediate dose cyclophosphamide, lower doses of cyclophosphamide as low as 25 milligram per kg for 2 days. And if there is a question of CMV reactivation and increased infections, letermovir prophylaxis is being used. So I think we will be able to deal with CMV also in a better manner. And grade 2 infections also are preventable provided we have good antibiotic stewardship and policies in our transplant centers. So I would just like to conclude that PTCY is here to stay and it is here to slay. Thank you.
Dr. Akas.
Well, excellently put up. PTCY is definitely here to stay. Slay, I don't know. Because everything which shines will always be accepted very fast. Oh, it's very good. Oh, it's very good. Same, I think, can be drawn parallel with a CAR-T setting here. So, is old is really gold or like diamond is forever? Whatever. Let's see. So, if we talk about conventional treatment, let me talk about what is exactly a conventional treatment here. Are we talking about cyclosporin, methotrexate, tacrolimus, MMF, sirolimus? I don't know, sirolimus conventional or not. Though it's a CNI, ATG, Campath. So, why I brought this up is because we can always mix and match these and might get the answer right here rather than going to a PTCY. So this was a study which showed some things why and how cyclosporin and methotrexate came to the picture versus tacrolimus methotrexate. Tac methotrexate fared well. These are old studies, very old. Um, but similarly, cyclosporin and MMF versus methotrexate and cyclosporin. Here, MMF fared well. This is actually a prospective study. The study got closed because it was so good. But I don't think so anybody uses cyclosporin and MMF together. It's more TAC and MMF. So it's interesting how, because some studies use TAC MMF became the mainstay. So it's more about acceptance, and actually a center related acceptance is more important, like rather than a general awareness that everybody accepts it. Coming back to Campath, yes, Campath also showed a lot of promise, no GVHD, blah blah, cause toxicities because of infections and everything. Later, Campath, I don't think so. A lot of centers or much centers use it anywhere across the globe. Then came haploidentical transplants. Definitely, PTCY is definitely there to stay in an haplo. So there is no debate on it. I won't be talking about haplo. I don't see TCR alpha beta as a conventional therapy either. So you can take or choose whatever between them wherever you want to accordingly. Coming to the match unrelated donors or match related donors. So there are few problems which he has also highlighted with it. The most important, which I feel, is the fact that the non-relapsed mortality, because of various reasons, could be an organ toxicity, could be infections, could be even lack of GVL effect down the line. And there is not just a viral infection called a CMV, there could be a BK virus, there could be what viruses, you can name it, there can be a virus for it, which patients can have post PTCY settings, and it's relatively more as compared to other setups of CNI or ATG. Well, I'll keep Campath away from that. Campath can be equally bad. So, so this is something which we want to discuss, is the fact that if PTCY showed some such a promise that it was even considered using haploidentical donors and PTCY, and a younger donor fared well. Even haplo, there are studies that show that haploidentical donors with PTCY as a backbone fared well. These are recent studies, fared well when compared to a matched sibling donors. So it looks very promising, but there are very less and less data on it, and more or less they are not prospective studies. Also, there is similar data in mismatch MUD versus a PTCY. It's a very recent study, 2024 again. Though PTCY is ahead of the curve in every aspect, in terms of disease-free survival, overall survival, GVHD survival. So it's very interesting when directly compared between PTCY and ATG, but the combination might be very much different if you're able to use it in combination with either sirolimus and ATG, or something which we can come up with by using conventional therapies as well, because PTCY has its own problems, which we'll see again. So this is a very new, very recent paper, 25 got published, claims that PTCY unchained is a miss in the matched siblings, the D is silent in GVHD. So it's a very catchy line, but it concluded how? Let's see about this paper. See, if I can show you, see this blue curve. What is this blue curve? Blue is PTCY, CNI, MMF, PTCY, ATG, and CNI. And what do you see here? The cumulative infection difference between this and this is substantial with a positive p-value. However, GVHD was better, no doubt. So cyclophosphamide, it will definitely eat up some T cells, so GVHD will be less, but therefore chronic GVHD is less. And well, about the other things like GRFS, leukemia-free survival, I'm not really sure. It can be variable, and of course, there's a difference between a bone marrow graft and an peripheral blood graft. So that is something which is which we don't know, and we don't have a complete answer to it because a lot of studies have a different time frame. Some have bone marrow grafts, some has peripheral grafts, some is before letermovir prophylaxis. So we don't know exactly, and we should be designing a prospective study to get the complete answers. But again, prospective studies can also have its own problems. So this is the same paper which concluded with the fact that they require more data to really say what's going on and what is the way ahead. They wanted to combine PTCY with ATG to get the best out of it. So again, why does we require another agent if PTCY was so good is again a question in my head. So similarly, there is also an eBMT data on PTCY-based prophylaxis for matched sibling donor allogeneic bone marrow transplants, which is again a very recent data, got published in 2024. These are all recent data we're talking about. Ma'am did present a lot of data, but it is, I think, older data. So this data again show with a difference of PTCY versus CNIs or conventional ones. Though the graph is blurry, but red and blue can be seen directly being compared. This is GVHD over here, overall survival. Similar, GVHD difference, chronic one is a real difference. There is better with PTCY, but that is supposed to happen. There is no debate on the fact that GVHD was lesser, but the overall survival, there was no difference. And infections rate were much higher with PTCY. So again, interesting data. You can find data for everything if you are looking for it, though. But again, something to ponder. So there is another data which shows that ATG with and ATG plus PTCY is the best way forward for GVHD prophylaxis, especially in matched donor transplants. So again, PTCY alone is not faring well. And if you think about it, do we really require that much of GVHD prevention especially in a match related setting? I agree in haplo, I agree in mud to an extent that GVHD is bound to happen, but I think selection of donors and the disease should be the mainstay in defining why you want to use PTCY in this case, rather than using it for everyone. So again, another data. So why I'm showing is that because we still require some novel strategies, be it abatacept, be it ATG combination with PTCY, before we jump to a conclusion that it's wonderful. Also, low dose PTCY is maybe the way forward. It's not just the conventional dose. This is a prospective study done in China which showed low dose PTCY plus low dose ATG for GVHD preventions in 10 by 10 unrelated donors, peripheral stem cells. So one should look into this data. This is pretty exciting, but we should have our own data, especially with PTCY. Questions which are still open is the dose of PTCY, the risk of infection, especially in Indian settings. We don't know how much of an impact when combined together it will cause. The cost efficacies should be discussed because with infections, the cost also rises. Again, the risk of relapse, I'm still not convinced that you can use PTCY for everyone and everywhere. Also, novel combination strategies, which should be always been looking forward and should be helpful in this case. Thank you.
Thank you.
Great debate.
Dr. Akash for taking no more time. Amrita, you can answer what he has told, maybe 1 minute. Then we'll ask.
So whatever studies were shown were all PTCY in combination with ATG. ATG has been there for years. We have encountered GVHD for years, but then now everything is combining some agent with PTCY. So I would say that PTCY is the real game changer. It is effective. It is cost effective. It is easily administered. And you could even do it in older patients if you could modify the doses a bit. So I think wider availability, and this is what actually help do haplo-identical transplants. So I would say that PTCY is
three things. All those studies showed there is a higher relapse rate, in particularly relapse rate. I was seeing your study. In one of the studies, 46% was the relapse rate. You are not showing what is the viral infection, particularly hemorrhagic cystitis or CMV. Yes, you can give letermovir, but it's there. So, and is there any direct benefit in match related or match unrelated transplant? Haploidentical, as Dr. Akash told, it's no question. Still, we are using PTCY. But in a match related or match unrelated, is there a definitive
Definitely, in the RIC setting, we have strong evidence to say that PTCY is better even in mud and in match related donors. But if in the max setting, we do not have enough evidence yet.
Yeah, absolutely.
Yeah, choice as of now still for batch sibling we are going with CNI and methotrexate, but we have been using only for haplo PTCI is being currently. That's what by practice is at present.
No, I agree with it.
Yeah, so the context is very important. For mass sibling, is still cyclosporin methotrexate. It is means our preferred regimen, and some data is there for PTCI, even reduction of cyclophosphamide dose from 50 to 40. So that is some people are using one dose only. So these are things are there. Even mass sibling PTCI is being tried, but we are not following that.
We don't know the exact dose also, to be honest. Koi 40 for 2 days, 40 for 1 day.
One more thing, the
In a mud.
you said about omission of CNI, but there is an RCT recent one in 2025 where they have combined PTCY with cyclosporin. So that has, actually there are two RCTs. If you compare PTCY, the first one in the haplo setting, so it is the standard of care. The recent one in 2025 where they have compared, say, the conventional thing like a CNI plus an antimetabolite versus PTCY plus. It has gate, but the CNA cannot be omitted in that setting also. So, what is your take on that?
He's talking of triple inter.
No, in the match sibling
About
setting.
PTCY, single agent PTCY, we know it doesn't have great results.
She already
All
shown in the
used in
data.
combination with the CNI and MMF.
Dr. Rahul, your opinion. You only asked everybody, so you have not given your opinion.
I think if from the Western world, if you have to see, then they are moving towards PTCY because they feel that it is much more easily tolerable and the incidence of chronic GVHD is less. But in India, because of the delayed engraftments which we have encountered by day 16 or day 17, we are very conventional still at Fortis because we want our patients to be out on day 12 because the cost continues to increase. So if you talk from a science perspective, yes, PTCY is the present and it is going to be the future. But from a cost constraint setting in India, CNI methotrexate, because everybody has been trained so well, patient tends to engraft by day 12 and day 13 and they can be discharged early. That is why it seems the CNI and the methotrexate combination continues to remain. So we have got Paritosh, who's DNB, who's going to pass out. He is looking at the use of ATG and can we compare the incidence of acute GVHD versus chronic GVHD with the addition of ATG with CNI and methotrexate and omitting the PTCY. That's a work in progress. But yes, the future in an ideal setting in Europe and in the Western world, PTCY is the way to go forward. So I think both are.
When I was in Pune, we were doing transplant for the civilian. They are poor people. They cannot follow. They are too aplastic anemia. I did PTCY because they cannot afford once they are discharged. But both of them has the problem of mixed chimerism. That was again issue. After that, I thought, no money too. We should work on mental. But these things nobody analyzes. If you give the full dose PTCY, you are bound to have mixed chimerism. But they were plastic anemia. They did well because even with the mixed chimerism, they are doing.
I think it's a science in progress. We have to collate our own data to look it forward, which is going. And believe me, we are now collating data. We are now mature enough, like a democracy. We are mature enough hematologists across Delhi. We have got 29 centers in Delhi who's doing transplants. So there's a lot of data being generated, but there's all that we have to collate. And then I think end of the discussion would be that both are the winners because It's a one is the
But
ideology.
everybody spoke in favor of Dr. Akash, so now Akash has to tell something.
No, I believe PTCY is the way forward. But I showed some data point also that you can try this as ab dikh nahi raha, okay. So PTCY with ATG with CNI, I think with a lower dose might be the right way forward. Don't know, it's a blind arrow shoot, but yeah, something on those terms might help. And similarly, abatacept data is coming. There is also a very interesting data with PTCY and abatacept, which had 0 GVHD, but the data set was like 10 patients. But it's a very early set. You never know.
So tomorrow probably Suparno will be there, who is so passionate about abatacept. He can speak about abatacept, and Dr. Reddy is in the process of bringing abatacept to the market by next year. So a lot of new things in there happening. We have reached to 60%. The final wording would be, but we will not stop till we reach till 100%. And we have to provide a quality of life post-transplant. So transplant is just the beginning. Rehabilitating them and giving a quality of life without GVHD is the bigger challenge now we are facing. First challenge was saving lives with transplant. We have achieved. Now having a good quality of life is going to be the next one. With this, we come to an end. Thank you, everybody. We come to an end of a great day today. And let's now start the dinner and get to the musical festival now onto this place. Thank you.